IBD update day 1. Audio mute lo pettuko.
Recording in progress.
Hello, check 1 2 3. Kiran, nanu adugu. Vastunda input. Other side. No ఒకసారి మాట్లాడు, అన్మ్యూట్ చేసి. మ్యూట్ చేయి. దగ్గర ఉంటుంది వాల్యూమ్ అనుకో. నేను నీకు లింక్ పంపిస్తాను. 1 మూమెంట్ ఉంది నీకు. ఐబిడి దేవన్ దానిలాగా ఇది అది వస్తుంది. తనకి ఇన్పుట్ వస్తుంది అడుగు. తనకి ఇన్పుట్ వస్తుంది అడుగు. ఓకే, ఒక నిమిషం సెకండ్. ఆశీష్ చెక్ 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 బయటికి రావట్లేదా? మాట్లాడుతున్నాను, తనే మాట్లాడుతున్నాను. ఆశీష్ కీప్ టాకింగ్.
Check. 1 2 3 check. Check check. 1 2 3 4.
లైవ్ ఏనా? ఎంబెడ్
Good evening, everyone. At the outset, on behalf of Yashoda Hospitals and SAIA Association, I would like to invite you for this 2 days exciting conference on IBD. So today's session, starting from now for another 3 hours or so, is going to be a patient empowerment session. So Yashoda Hospital, as you are familiar, one of the leading hospital groups in Telangana and Andhra Pradesh. And SAIA is an organization that stands for South Asian IBD Alliance, mainly formed to promote or improve patient advocacy and patient-clinician partnerships by virtue of improving patient participation in the clinical care, promoting education, promoting research among providers, and it's a great honor to be associated with SAIA. So this conference is going to be a hybrid model, so we got few audience sitting here and participants coming across from across different parts of the world. So without further delay, I will just hand over the mic to Tina Omprakash Saswani, who is the president of SAIA and patient advocate. Over to you, Tina.
Thank you so much, Dr. Fezzi. Welcome, everyone. My name is Tina Swani Omprakash, and it is my honor today to have our new organization, South Asian IBD Alliance, be a part of this important patient-clinician IBD conference. Special thank you to Yashoda Hospitals and Dr. Kiran Fezzi. Thank you all for joining us today. As a brief introduction, I'm a patient advocate living with Crohn's disease and a permanent ileostomy bag since many years. I'm based in New York City in the US, and I'm very passionate about breaking down the barriers we as South Asians face living with both IBD and just the challenges around IBD, both in the mainland of South Asia and as the largest diaspora in the world. With numbers of IBD growing in our community, it is imperative now that we as patients and clinicians join hands to help create awareness and education around this disease. That is the basis upon which SAIA has been founded. A team of us patient advocates from around the world came together as Team IBD Bases and then approached a number of South Asian clinicians, including Dr. Fezzi, from all over the world to join us, and that's how SAIA was born. We are proud today to be working consistently and steadily on patient education and empowerment, medication access, professional development, and research that is South Asian specific and addresses our community's needs. I thank you all for joining us today, and I am proud to introduce you all to my brilliant friend and colleague, Ms. Madhura Balasubramanian. She is a premier Crohn's patient advocate based in Chennai, India, and is a social sciences graduate from IIT Madras, who has been specializing in qualitative social sciences research. With that, I would like to turn it over to Madhura to tell us a little bit about our work within SAIA and her patient journey.
Thank you so much, Tina, and thank you so much, Yashoda Hospital, SAIA, Dr. Fezzi, Dr. Bhatia, Dr. Vishu, and Tina, of course, for putting together this amazing conference and for creating a dedicated patient empowerment session. I'm so proud to be part of this, and I'm so thankful for this opportunity to share my thoughts here as well. And today I'm really proud to be speaking on behalf of Dr. Neil Nandi and the Patient Outreach and Advocacy Committee of SAIA to share with everyone our efforts and our goals to improve IBD care for our South Asian community across the world through meaningful patient-clinician partnerships. So, let me just share my screen. So really today I want to focus on how it is that we hope to elevate IBD care for our South Asian community. And before I begin, just a little bit about myself. I'm a Crohn's patient, like Tina said. I had GI symptoms like diarrhea, malnourishment, vomiting. I've been underweight for several years before I was diagnosed in 2019. And I'm sure, like many IBD patients here, I also really struggled with accepting my disease and accepting the medications that I needed. I believed that I had caused my disease and I kept delaying accepting treatment. And because of this, I started developing multiple complications, including skin issues. I got sicker, I lost a lot of weight, and I needed a feeding tube to manage my nutrition. And getting a feeding tube really reminded me that I needed to advocate for myself and I needed to take charge of my care now. And this is when I began to seek support from fellow patients and began to educate myself, and we came together as Team IBD Desis as well. And talking to other patients and learning more about IBD, learning more about IBD therapies really helped me seek better care and start a biologic. But in this process, I also began to realize that we all face some common challenges. For the longest time, I thought I was the only one that was struggling with all of these issues around IBD. And I realized the more and more I spoke to patients that the reality is a lot of us face similar issues as South Asians. And it doesn't seem to matter whether we're in India or in Pakistan or in Bangladesh, or whether we're in the US or in the UK. These issues seem to be affecting all of us in specific ways. So for today's conversation, I wanted to highlight three common issues: access, stigma, and lack of support. And with respect to access, in South Asia, for all those of us who live in South Asian countries, access to a specialist gastroenterologist who can diagnose and manage IBD, and access to medication, especially medicines like biologics, is very challenging because they're limited in availability and extremely expensive. At the same time, tests like colonoscopies or MR enterography, CT scans, these are very expensive tests too. And this is even more complicated by the kinds of insurance barriers we face here. And this overall creates a challenge of very poor access to quality care. For our fellow IBD patients in the US and the UK, these challenges are similar too. There especially, they struggle with accessing culturally competent care. What this means is that their doctors don't necessarily understand what are their challenges as South Asian patients accepting medication, the kinds of struggles they have with diet and so on. Access on the one hand. The second very common issue that we all face is the kinds of stigmas and myths associated with IBD and the kinds of misinformation in our community around IBD. So I'm sure we've all seen and felt that kind of silence around bowel diseases in our community, where it's considered almost shameful to talk about the kinds of issues that we might be having, chronic diarrhea, for instance, or blood and stool. These are very difficult to talk about. And this silence makes a lot of us feel very alone. And it also allows for a proliferation of misinformation about IBD. So commonly we hear that IBD is caused by your diet, or IBD can be cured by your diet. We hear that medications are very dangerous, they have numerous side effects, and we are also constantly pressured to look for a cure. And often this cure is through alternative therapies like Ayurveda or homeopathy. And that pressure to try alternative therapies is huge in our community. The third most important challenge to my mind is the lack of awareness in our overall general society about IBD. I'm sure we've all faced this, where we've tried to explain to a relative or to a friend that we have a disease called ulcerative colitis or Crohn's and it causes ulcers in our digestive system. And they would respond by saying, "Oh, so you have stomach ulcers, is it? What's the big deal? Why are you complaining? Why are you saying it's a chronic illness? Why can't you just cure it and move on?" And there is that constant judgment that you've caused your disease. And all of this really makes the patient feel blamed for their condition. And sometimes this translates into overt discrimination. And this is something that our friends with ostomies or people with feeding tubes face as well. And overall, this causes many challenges with respect to our outcomes. It causes major delays in care, in seeking the right diagnosis and getting on the right treatment. This also means that many of us lead very poor quality of life and we feel very isolated in our journey. And this is precisely what SAIA wants to change. Like Tina and Dr. Peddy spoke about SAIA and SAIA structure, I just wanted to share this image. This really highlights our different arms, but also how our different arms are integrated. And what's really at the heart of our organization is the patient-clinician collaboration.
We believe that by bringing our voices together, we can improve IBD care for our community as a whole. And there's far more power in all of us speaking together and working together, bringing our energies together for meaningful change. SAIA really hopes to minimize disparities, dispel stigma, promote early diagnosis, and improve access to effective therapies. I want to spend a little bit of time talking about the patient outreach and advocacy committee's efforts. And our goal really is to transcend some of the barriers that I just discussed through meaningful patient-clinician partnerships and joint advocacy. At the core of all of this, at the core of our efforts, we recognize that patients and clinicians bring very unique perspectives. Patients, on the one hand, we bring our lived experience as IBD patients, the expertise that can only come with living with a condition 24/7, 365 days a year. At the same time, our clinicians bring their expertise and their training in diagnosing and treating IBD. And we want to join hands to improve access to care and shatter the stigma around IBD and build support with the goal of elevating IBD care for all of our South Asian IBD patients. So our two major interventions, one is to improve awareness among key stakeholders like government authorities, insurance providers, pharmaceuticals, with the hope of improving access to care in a timely manner. This is a long-term project. And our second very important goal that we've been working consistently towards is to build patient education and build patient support groups. So our patient education project is really driven by the goal of educating our IBD patients and empowering each IBD patient to be able to advocate for better care for themselves. We do monthly talks, which are designed both by patients and by clinicians as a joint effort. And our hope really is to provide evidence-based education on different aspects of IBD, make these available to patients, but also make them available to patients in a way that is easy to understand and easy to share. And we recognize the value of patient expertise. We recognize that our patient audience, just like they want to listen to their doctors and learn from their doctors, equally they want to learn from fellow patients as well. So we bring together patient and clinician partners. This happens on Facebook. We have anonymous forms for you to ask questions and engage with our panelists so that you can feel free and feel comfortable. And these videos are available to watch later on our YouTube as well. So just as an example of the talks that we've done in recent times, ranging from ostomy to COVID to intimacy in IBD and other topics as well. And we have more talks upcoming. The second most important aspect of our patient advocacy work is the patient support group. IBD Desis is so proud to be running this patient support group, and this is a non-judgmental space. It's meant for South Asian IBD patients and their caregivers, and our goal really is to make sure that not one more patient feels alone in their IBD journeys, the way that we have felt in our journeys in the past. We hope by creating this space, we can help patients feel more comfortable, feel more supported, and we're very proud that we are over 1,000 members now. We invite you to join our group if you would like this kind of access to this kind of support. And I'm so proud and so honored to be able to introduce IBD Update's patient advocates. I believe that IBD Update is a great example of this kind of clinician collaborative effort that I was just speaking about, where you value a clinician's expertise, but you also recognize that patients have a very important voice here. So without further ado, let me introduce our patient advocates for today. Sharon is from the UK. She was diagnosed as a pediatric patient and she's had Crohn's for over 20 years. Through her journey, she's been on a number of biologics. She also developed a stricture a few years ago and she underwent a subtotal colectomy. She lived with an ileostomy for 3 years before it was reversed, and she's currently on Kinumab. Tina, of course, really needs no introduction to our South Asian IBD community. But just in case there are people who don't know her, Tina is from the US. She was diagnosed with IBD 16 years ago. And through her journey, she's had over 20 surgeries, including a J pouch. Her diagnosis was later revised to Crohn's disease as she developed fistulae. And she's just recently had surgery herself to clear out adhesions and other complications from the multiple surgeries she's undergone. Tina is a permanent ostomet and she's on Kinumab as well. Harita is from Hyderabad, India. She's in person. Hi, Harita. She was diagnosed with Crohn's 13 years ago. She was on azathioprine and steroids. She recently was diagnosed with a partial stricture. And after a lot of thinking and a lot of discussion, she's currently on Infleximab to treat the stricture. Ruchita is from Mumbai in India. She's currently in the US pursuing her master's. Ruchita has fistulizing and stricturing Crohn's disease, and it took her 8 years to be diagnosed with multiple fistulae, multiple fistulectomy surgeries before she was finally diagnosed in 2018. She's currently on adalimumab and doing much better. She was previously on azathioprine as well. Chaitanya is from Andhra in India, and he was also diagnosed with Crohn's disease 16 years ago. He has perianal fistulizing Crohn's, and he's been on azathioprine and steroids for many years, and he's recently started Infleximab to treat his IBD as well. I'm so proud to be here today to share this space with some amazing clinicians and patient advocates to highlight the importance of patient-clinician collaborative partnerships, because this is so key to creating meaningful and long-term change in the way IBD care happens for our South Asian community. I really hope that through our efforts, we can normalize IBD, normalize needing medication, normalize surgery, and enable and empower each and every IBD patient in South Asia and in our diaspora to lead their best lives. Thank you so much for giving me this opportunity to talk. And I'd like to hand it over to Dr. Peddi to talk a little bit more about Inactivated IBD as a great example of this patient-clinician collaborative effort.
Okay, so Madhura just gave you an introduction of how ideal patient-clinician partnership should build up. So I'll just quote some examples, and in an ideal situation, ideal world, how this partnership should be developed. So what is a patient-clinician partnership? So it's an healthcare model where patient takes an active role in the management of their own health and to give best outcomes and improve quality of care and make it very cost-effective. Traditionally, the healthcare models are designed to deliver in a unidirectional way. The clinician tells something, patient takes it home, and then that's it. Comes for follow-up, and then there is no interaction between patient-clinician, and there is no active role of the patient. So in patient-clinician partnership, patient plays a greater role. And if it is a superior model, why is it difficult to implement? So what are the limitations of delivering patient-clinician partnerships in IBD? Quite often, clinicians are very busy, so patients find it very difficult to access clinicians, and there is no one in between a patient and the clinician. And patients are really worried about asking any questions, and limited access to specialist care, and a lot of stigma associated with the disease, as Madhura just mentioned. So people are really hesitant to ask about their condition. There is no pre-designed infrastructure or systems in place, and no specific awareness sessions for patients, and mostly learnt on Google. So as SAIA is building up a lot of knowledge base and knowledge systems, and traditionally there are no systems already existing. And the different services in IBD care are not clearly defined. For example, in IBD care, any IBD care patient might require, for example, vaccination service, travel service, advice before travel, advice before marriage, advice before childbearing. So all these different services are not clearly defined. And there is often some element of mistrust on modern medical health care for the fear of cost and fear of adverse effects. And age-old belief on traditional complementary medicine still exists, and unfortunately in IBD, it doesn't work. There's a lot of stigma associated with surgery as well, as ostomy is not a nice thing to have, of course. And there's no formal training for specialist nurses and consulates, especially in countries like South Asian countries and especially like Indian countries. So what are the advantages of better patient-clinician partnerships? You can really empower patients in their own disease management decisions, and each patient health, personal, supportive, and financial needs to be clearly understood by both patients and also healthcare provider. It provides better education for patients, and better research outcomes will come out, and improve access to various new treatments, even trial treatments and also modern treatment. So what is Innovate IBD? It's a service basically aimed at improving patient-clinician partnership, and it's currently implemented at our unit in Yashoda Hospital and also at my individual clinic. So it really implies innovations in IBD. So what does it have? It does have a system in place, some infrastructure, personnel, and also various services. So let's look at each one of them. So the system actually runs in a protocol-based approach, and we initially know the patient when the patient comes to us. We predict the nature of the natural course of the disease. Not everyone behaves in the same way. So as we know, each patient is different, and there are certain high-risk features which if we can identify, we can tailor the treatment to suit patient's journey. And we need to have disease mapping. What are all the exact areas that disease involved? There is a small intestine, large intestine, or fistulizing disease, or upper GI tract, in fact. And then we need to do immune mapping. What is the immunity, like hepatitis B, hepatitis C, HIV status, what is the chickenpox immunization, for example. So all these immune status need to be mapped. And we need to plan so that some protection measures can be taken to protect from opportunistic infections, especially by means of vaccination. And we can plan individualized therapy. And when the patient goes on therapy, quite often there is a possibility that patient may develop adverse events due to therapy or due to disease. So we need to identify, for example, anybody with IBD may develop liver problems or bone problems. And all these need to be monitored carefully and then prevented. And we also need to prevent disease-related complications such as malignancy, for example, and some other complications. And there is always a call for help, either in the form of counselors or dedicated website. So infrastructure, we have a dedicated clinic space with good ambience and state-of-the-art endoscopy units and efficient, safe recovery areas. And personnel, very, very important in any service delivery, extremely important. And that ideally, in an ideal world, in any IBD service, involves consultant gastroenterologist, IBD dietitian, IBD counselor. We do have IBD dietitian here, Mrs. Gayatri, and also Mrs. Sunita, our dietitian here at Yashoda. And IBD counselor, Harita takes care of most of the counseling part for our patients. We have IBD endoscopy technicians, my own technician Liladhar, and also we have SAIA and other staff members here, Grace sister. And clinical psychologist, pelvic floor physiotherapist, specialist pharmacist, and some supporting specialists like colorectal surgeons, for example. Patients do often require rheumatologist support. Infectious disease specialists, especially after COVID pandemic, we all realize that infectious disease can be a major problem. But fortunately, IBD patients did very well during COVID pandemic. So what are all the different services one can plan? We should be able to offer offline services, offline consultation and online consultations, counseling services, especially psychological counseling, vaccination service, family planning, and travel advice before travel, and what are all the precautions need to be taken, and how do we connect a traveler with IBD who is traveling and to local healthcare provider. He is traveling abroad. Networking would always help, and then we can connect to somebody who can provide a better IBD care wherever the patient is going. Genetic analysis is upcoming, and especially with the family history. We know that IBD runs in family, and doing genetic testing can actually predict some of the family members who are going to develop the disease and do some early intervention, early detection and early treatment. Microbiome testing is on the price, and some commercially available products are available now to test the microbiome and start some individualized therapy, dietary therapy, and modify the microbiome of the patient, and thereby improving the outcome. So in conclusion, active patient-clinician partnership is very crucial for good outcomes in IBD management. And we need to understand, especially all the patients suffering from IBD, you need to understand your disease very well. That not only improves your understanding itself, but it will improve the outcome of your management. You need to take charge of your disease and be guided by your own clinician, and make most of the resources available nowadays on the internet and support groups and organizations like SAIA and IBD Disease. So lots of resources available. You need to make the best use of it, and don't hesitate to seek any help from any of these resources. So with that, I will stop there. And for the rest of the session today and also tomorrow, I will introduce my colleague, consultant gastroenterologist, Dr. Sriram, who will act as master of ceremonies to take things forward. Over to you, Sriram.
Good evening, everyone. I'm Dr. Sriram, consultant gastroenterologist in Yashoda Hospital Somajiguda. It is my privilege to welcome you all for IBD Update 2022. For our next talk, we welcome Dr. Bharti Kochar, instructor in medicine and gastroenterology, Harvard University and Massachusetts General Hospital, USA. She specializes in IBD in older adults and pharmacoepidemiology of IBD. I request Ms. Madhura and Ms. Tina Ashwani as patient participants for this session. Thank you.
Okay, can everyone see my screen in full screen mode? Can someone confirm? Can everyone see my screen?
Yeah, we can see your screen.
Okay, thank you. Okay, excellent. So namaskaram, adab. It's such an honor to be virtually present in Hyderabad for this first patient provider IBD conference in India. I was asked to speak about health maintenance, and Dr. Peddi set it up very nicely. I counted, he said prevent at least 10 times in a few minutes. So this is a fantastic way to start talking about this topic. Advance, okay. Over the next 15 minutes or so, I'll cover these big topics as I discuss them with my patients. It's meant to be a broad overview of things to consider and maybe some tips, but it's not a deep dive into all of the data supporting these recommendations. So first we have to start with what is preventive medicine. And I always like thinking about Benjamin Franklin. He's an American scholar, and he was known to have said, an ounce of prevention is worth a pound of cure. And so preventive medicine is the practice of medicine with the goal to prevent disease, disability, and death. The preventive medicine pyramid is important to see at least once. In the context of a chronic condition like IBD, primary prevention is to prevent people who do not have IBD from getting IBD. Secondary prevention is to prevent people who are at risk for IBD, like first-degree family members, from getting IBD. But the focus of this talk will be on tertiary prevention, which is to prevent disease complications for people who already have IBD. And preventive medicine in general always results in kind of weighing a cost and benefit analysis of what we're doing. And so with that context, we'll just talk now directly about preventing complications in IBD. So you all might be knowing that IBD is a very complicated disease process. It's an interaction of your environment with your genes, a loss of balance in the microbiome that you have, and then a hallmark of the condition is this uncontrolled immune response. So this uncontrolled immune response is very important because parts of your body's immune system, specifically T cells, function as your body's army and police. So like the police, they internally police all of your cells from becoming cancerous cells and preventing cancers. And like the army, they prevent the external environment for infections that can invade your body. And when your immune system is distracted because it's fighting your own body, these patrolling mechanisms do not happen very well. So this distracted immune system is a big reason for why patients with IBD are at increased risk for infections. And here I highlight the 3 infections that are vaccine preventable, specifically pneumonia or bacterial pneumonias, influenza or flu, and the herpes zoster virus. So I'm sure you're all aware that India has the largest immunization program in the world. However, the focus is entirely on children and pregnant women. Adult vaccinations is a much more recent concept, but one that is very important to patients with IBD. We recommend annual influenza vaccination with an inactivated influenza vaccine for patients because every year the vaccine is reformulated with new strains and the immunity does not last for a long time. So pictured here are the two inactivated influenza vaccines that are available in India. They're obviously quite expensive, as you can see, because they are foreign made. The Indian vaccine industry is very prolific, and there are a number of Indian flu vaccines, but they're all, from what I can tell, live attenuated vaccines, which are not recommended for patients on immunosuppression. So something to keep in mind. And then we also recommend a pneumonia vaccination series. So first we start with the 13-valent vaccine. It covers 13 strains of the pneumococcus bacteria that can cause significant pneumonias. And about 8 weeks after that, it'll be the second dose of a 23-strain vaccine, the pneumococcal polysaccharide vaccine. So this is a one-time series though, and even though the prices are quite expensive, the prevention of bacterial pneumonias, which can result in ICU stays, is quite significant, especially for patients on immunosuppression. So now we'll talk about the infection that's on everyone's mind these days, COVID. So it's important to recognize that IBD patients are not at higher risk for contracting COVID on their own. So these are data from our experience here in Boston in the first 6 months of the pandemic, where the general population prevalence for COVID was 1.1%, but in IBD patients, it was only 0.7%. But poorly controlled IBD is a risk factor for severe COVID. So in this chart, you see that having a severe PGA or physician global assessment is a strong risk factor for having COVID that results in a hospitalization, the gray bars, or COVID that results in ICU stays or even death in the blue bars. It's also very important to know that corticosteroids are the only IBD treatment that is associated with severe COVID. So I've highlighted for both hospitalizations, severe COVID, and death, only corticosteroids are shown to have a strong association. So obviously these data, like most of what I'm presenting, are from the West. This is in about 6,000 patients globally. There's only 39 reports from India, but again, no reason to think that this would be different whatsoever mechanistically. So severe COVID can be prevented though. And so this is very nice data from a study showing that the mRNA COVID vaccines are effective in patients with IBD. The mRNA COVID vaccines are the Moderna vaccine, which is now available in India, and the Pfizer vaccine. And so what you see is that those patients who've gotten 2 doses of the mRNA COVID vaccines, 95% of them show some response in their blood of having immunity against COVID. So the lowest response rates are actually here in patients who are both on a tumor necrosis factor agent as well as an immunomodulator, this combination therapy. But even that is quite high, it's 88%. So for some reference, we've been recommending the influenza vaccination every year for quite a while now in patients with IBD. The response rates are somewhere in the 70% range. So this is actually a very good vaccine. But because of the slightly lower response rates compared with the general population, more than 2 doses of the mRNA COVID vaccine are encouraged for patients with IBD. So nearly all of my patients have 3 doses, and now I'm starting to encourage the 4th dose as well. And I can't talk about COVID vaccines in India without discussing this recent, very nicely done meta-analysis from an Indian group showing that vaccination against COVID was effective in patients with IBD. So in this study, they also assessed the vector-based vaccine, which is more easily available in India as Covishield. So I'll quickly talk about cancer. There are disease-related cancers to consider, as you just heard, mainly colon cancer. If more than 1/3 of the colon was inflamed for over 8 years, then you should be on a routine screening colonoscopy schedule. Some older data suggested that perhaps there's a slightly increased risk, especially in Crohn's disease, of lymphoma and cervical cancer. None of the newer studies were really able to replicate this. I don't know if this is true, but I use this opportunity to encourage all of my women to stay up to date on cervical cancer, encourage HPV vaccination in my younger women, and then routine screening, because this is a preventable cancer. And then there are medication-related cancers to be aware of on patients who are on tumor necrosis factor agents and thiopurines. There is a slightly increased risk for the non-melanoma skin cancer. And unfortunately, in South Asian nations and Indian culture, there's sort of a norm that you're prevented or protected against skin cancer, which is not true. So there is actually an increased risk. And routine sunscreen is very important, as well as skin checks. So now on to bone health. Calcium is absorbed in the small intestine. So if there's inflammation in the small intestine, then absorption will be decreased. And inflammation around your body, like from an inflammatory condition like IBD, decreases bone mineral density in a very complicated pathway that you can see here. So the end result is that patients with IBD are at risk for bone thinning or osteopenia. So in the middle picture here, you see that the bone is thinner than a normal bone. And this is actually quite reversible with high-dose calcium and vitamin D supplementation if it's caught early. And if the bones are very thin, it's called osteoporosis. And these days, there's actually very good medication for this as well, but it has to be diagnosed, obviously. So I think about it often. And osteoporosis is quite scary because it gives you an increased risk for fractures. So this is a list of risk factors for osteoporosis, and you can see that many patients with IBD have a lot of steroid exposure as well as poorly controlled inflammation, which are two big risk factors. So what can you do about this then? So if my patients have more than 3 months of steroid use in their lifetime total, about 6 to 12 months after the last steroid dose, I will recommend and have them do a bone density test. And this is to screen to see how thin their bones are. I recommend routine calcium and vitamin D supplementation in my patients anytime they're on steroids. And most importantly, this is something all of you can be doing, which is resistance exercises. So if you see that this ba here can do it, then you can do it too. So I'll quickly touch on your mouth. There's increasing knowledge to suggest that oral problems are related to the oral microbiome. And these microbiome changes in IBD that are listed here on the right can also be seen in patients with gum disease. So gum disease or gingivitis, if caught early, can actually be reversible. And these are often dentists that are making these diagnoses. But if it's not caught early and reversed, then it can progress to severe gum disease or periodontal disease, which puts you at risk even for tooth loss. So the consequences are quite significant. And you know, there's a lot that you can do about this, so it's very important to recognize. There are good data to support brushing 2 times a day and after eating. So all of the food is out of your mouth, you're not feeding the bacteria that's in your mouth. Flossing is an important habit to develop. You remove the small particles between your teeth. Again, stop feeding the bacteria, as I like to simplistically tell my patients. Using mouthwash is important, and getting regular dental checkups and cleanings is actually also quite important. So we'll keep moving very quickly. I talk to my patients about family planning all the time. The first thing I make very clear is that IBD is not birth control. Patients with IBD have similar fertility to people without IBD, and this is a nice graph showing that patients with IBD in the red bars have, again, similar fertility to people without IBD for their age-matched cohorts in the blue bars. And then I direct patients to this website here, the Ibd Parenthood Project, which has a lot of very good and high quality information on becoming a parent with IBD and then being a parent with IBD. So then I review the risk factors for decreased fertility. In women, you can see here, anatomically speaking, the female reproductive organs, uterus and ovaries, are very close to the bowels, like high up in the pelvis. And so the left ovary is even overlapping the colon here. So you may understand that if there's active inflammation in the left, in the colon, it might be harder for the ovaries to function normally, for ovulation to happen. So in planning for pregnancy, I always say that achieving remission should be a priority before pregnancy. Another risk factor for decreased fertility, especially in women, is pelvic surgery, because there's some scar tissue from the surgery that can build up and make it again harder for things like ovulation. In men, sulfasalazine is the only medication that can decrease sperm motility or movement, and so becoming pregnant could be harder. So if men are planning to have a family, we recommend getting off sulfasalazine for 3 months before, but it's also very important to recognize that this is the only IBD medication that affects sperm. None of the others do. Then for men, I shared this recent study that shows that the father's exposure to IBD medications is not dangerous for the pregnancy or the baby. There's no increased risk of congenital malformations, low birth weight babies, and preterm labor. We also have data from thousands of women to show that mothers' exposure to IBD medications, even immunosuppression, is not dangerous to babies. There's no increased risk, again, in congenital malformations, spontaneous abortions, preterm birth, low birth weight babies, and fetal brain development, and all sorts of very important outcomes. So this is also a sub-study from this piano registry shows that steroid use in mothers is the only IBD medication that is associated with a higher risk of poor pregnancy outcomes. So I emphasize to my patients all the time that this is very important to avoid steroids in pregnancy, and any other medication really is mostly safe in pregnancy except for methotrexate and some of the newer small molecule agents, but all of the biologic agents are very safe in pregnancy. Thiopurines are safe, and avoiding steroids is best done by planning ahead of time getting into remission. So I also reassure mothers that even if they're on immunosuppression for IBD, a small amount can cross the placenta, and we have some data to show that with the biologic agents, there's even a small amount that could be detectable in the baby's blood at birth. But despite all of that, there's no increased risk of infections for infants born to mothers with IBD, even on immunosuppressive medications. And actually what you see is numerically the mothers who are not on immunosuppressive medications had babies with a higher rate of infections, even though this wasn't statistically significant. So lastly, I emphasize that your kids are not guaranteed to get IBD. There's definitely a genetic component, and you see here excuse me, data from a Scandinavian population, and Crohn's seems to be a little bit more genetic than ulcerative colitis. But again, data from Scandinavian populations suggests that even if both parents have IBD, the child only has a 33% chance of getting IBD. And the flip side of that is that means even if both parents have IBD, which is a high genetic risk, then your child actually has a 67% chance of not getting IBD. So I never say that everyone must have children, but my goal is that the decision not to have children is not dictated by IBD, but any other factor in their life. And in summary, really, I hope that after these few minutes together, you consider talking to your doctors about vaccinations, adult preventive vaccinations, cancer screenings, bone health, mouth and oral health. And if you're considering family planning and pregnancy, to do it well before you actually want to be pregnant or have a child. And overall, we know from all of our experience so far that having well-controlled and treated IBD decreases risk for disease complications like severe COVID, infertility, pregnancy complications, and so on. The list is long. So thank you very much once again. It's such a privilege to be here. I'll stop sharing and love to have a conversation.
Thank you so much, Dr. Kocha, for this absolutely whirlwind talk on all things preventative medicine and IBD. I think this is so hugely important for us as South Asian IBD patients to remember that it's not just treating your IBD, but it's very, very important for us to take charge of our overall health and make sure that we do what we need to do to be as healthy and as well as possible. And I think it'll be great if we could chat a little bit about this. And I just want to turn this over to Tina, because she's just recently had a bone density scan that she's also shared about. And ask her, Tina, would you like to share your experiences of managing bone density challenges, and perhaps also share about your vaccine experiences?
Absolutely. Thank you so much, Madhura, and thank you so much, Dr. Kochar, for a fantastic presentation. So yes, I had a bone density scan just last week, and it's a pretty simple procedure. You just got to go in and they'll check your forearm, they'll check your spine, they'll check your legs, things like that, and it takes about 10 minutes, but it is a preventive procedure like Dr. Kochar was sharing. So my experience was pretty straightforward. Got the report the next day and I'm freaking out. And I'm like, what is going on? How do I have osteopenia? They marked me as postmenopausal. And so it was misread. My doctor came back to me a couple days later. She's like, you have nothing to worry about. You know what, Tina? All your exercise, all the things that you've been doing, the calcium, vitamin D supplements you've been taking have been helping. But I want you to take a little bit more calcium, vitamin D, and in the vitamin D, make sure there's some vitamin K. And she's like, you were on steroids recently with surgery. I was on budesonide, which is known as Entocort as well. And I was on that for about 5 or 6 weeks. So she was like, that was about 3 months ago now. Let's just double check your bone density because you haven't had a scan in 2 years. She said mostly that things had improved from 2 years ago. It was just my forearm that had sort of declined a little bit. So she wants me to continue to work on this and continue to exercise a lot and take appropriate supplementation, but also through diet. She had recommended things like broccoli and tofu, cheese, yogurt. These are all things I have in my diet to begin with as a vegetarian. So I'm working on this through diet, supplementation, and exercise. Basically similar to what Dr. Kochar was saying. Regarding my vaccine experience, so this is very interesting. I, was dead against the flu shot for so long. I was like, you know what, I can't, I'm gonna get the flu. That is a myth. You are not gonna get the flu from the flu shot. I learned this the hard way. I was coming back from a flight from San Diego in California in 2016, and lo and behold, I got the flu. It came with labyrinthitis, which was in my brain, and that came with vertigo, which lasted 4 months. I had an infection in my GI tract. I was hospitalized. I coded in the hospital. I was hospitalized for about a week, and I told myself at that time, I am never missing my flu shot again. I am very, very staunch advocate for vaccines after that. And with regard to the COVID vaccine, at this time, I have 3 doses. I am planning to get the 4th dose when I'm recommended to do so, which is in the next month. I'm trying to stay on top of this, make sure that I'm preventing any sort of complications or any kind of issues with COVID or the flu by getting the flu shot every year and by getting the COVID vaccine whenever it's recommended to me. I am masking, I wash my hands. I have been masking on planes and trains ever since 2016. That experience was just so horrifying. I did want to ask Dr. Kochar one question around pregnancy. With regard to medications, I know a lot of patients in India are on azathioprine or mesalamines. Is there any kind of contraindication with using those in pregnancy, if you don't mind elaborating?
Absolutely. Well, thank you for the question and for sharing your experience. I definitely agree. I mean, the one big thing that a lot of my patients will say is if I get the flu vaccine, I'll get the flu. And so then I'm very frank and I say, if you get the flu and you have a cold and a cough and maybe even a mild fever and you stay at home, I feel for you, but it's not bothering me and it shouldn't bother you. What the flu vaccine is meant to do is prevent you from being in the hospital from the flu, from being on a ventilator from the flu. And that is what I cannot tolerate. So you have to get the flu vaccine. So I am very, very frank. And I know it sounds dramatic, but it's really not. I mean, we're not God, like we're not preventing everything in the world. We can just try to prevent the complications, and the vaccines do a very good job. Same thing with COVID. I have a number of patients that said, I got the COVID vaccine like you told me to, and then I got COVID. I said, yeah, but you got COVID, but you're at home. So you're at home, you're not in the hospital. I'm not getting a phone call from the ICU at 3 in.the morning that your patient is on a ventilator with COVID. And so that is what these vaccines are meant to do. And they do them very well. But regarding medications, that's absolutely a great question. Thiopurines are actually exceedingly safe in pregnancy. And I tell my patients this ahead of time because the most common thing that happens is that a woman gets a positive pregnancy test, a local obstetrician will say you must be off of all medications, and they just stop. And then they'll call me 12 weeks later when the flare starts. And so then we'll have to start steroids. And that can also safely be done, actually speaking. And any obstetrician will say, take care of the mother and we will take care of the baby. But it's very uncomfortable to start steroids in pregnancy. And so I tell my patients, any woman with a uterus, I say, is at risk for pregnancy, whether or not you want to be pregnant, whether or not you think you're going to get pregnant. I even tell my very young patients this with their parents in the room, that, you know, if you have a uterus, you're at risk for pregnancy. So I'm saying this now, this medication is safe in pregnancy. Do not stop it when you get a positive pregnancy test. The medications that I do warn against are methotrexate. Methotrexate is actually at higher doses an abortifactant, and so a pregnancy is not viable on methotrexate, and abortion is essentially medically recommended if there's a pregnancy on methotrexate. So that I do say ahead of time, and for women who are even considering getting pregnant in the next year, maybe 6 months, I'll say, okay, we won't do that. For other women, I'll start methotrexate and say, you know, since pregnancy is very far in the future for you, we can do methotrexate now. You'll get off methotrexate, and then 3 months later, you can start trying to conceive. And then some of the newer small molecules like tofacitinib and ozanimod, we don't have as much data on, so I do counsel about that. Mesalamine is a great question. Mesalamine is an old medication. It's been around for a long time. There's one formulation of Asacol that has a particular chemical in the capsule. So it's not the medication, but it's that chemical. And I don't remember off the top of my head if that formulation of Asacol is on the market in India. In the US, it's off the market now as of at least the mid-2010s. So again, mesalamine is very safe to remain on pregnancy. And any obstetrician will tell you that there's an inflammatory rule of thirds, they call it. So it's very broad. They tell patients with any inflammatory condition, rheumatologic condition, multiple sclerosis, all of this, that, you know, 1/3 of women get better in pregnancy from their inflammatory autoimmune condition. The other third of women get worse in pregnancy, and then 1/3 of women stay the same. So that's a very big picture, old data-driven recommendation or kind of guidance that they give. But really what that means is that if you're in remission before you go into pregnancy, then your chance of staying in remission is 66%. If you're flaring before you go into pregnancy, then your chance of flaring through pregnancy is 66%. And I've been pregnant twice, and in general, pregnancy is just not a pleasant, you know, time. And then on top of it, to have to deal with symptoms of IBD sounds absolutely horrific to me. So there's a lot of importance in getting the disease under control before pregnancy. So I will actually, I do this almost every week. I have a woman that I'm scoping and say, okay, you're in remission. Now go ahead, try to get pregnant, and, you know, let me know with the good news. So I think it is very important to have these conversations very actively because it takes time to get into remission.
Absolutely. I think that's really, really important, Dr. Kochhar. Thank you so much for going over it. And just to reiterate, really speak to your gastroenterologist about your family planning plans that you have and make sure that you're being proactive about it, because it's very important for all of us to make sure that we're as healthy as possible and be as well as possible before trying to get pregnant. I think that's a really, really important take-home message for all of us. And I also think it's very important for us to make sure we're coordinating our care properly. For flu shots, I know it can be challenging to get a flu shot in India. I've struggled myself. I've missed the shot this year because, you know, I just couldn't find somebody to give me the shot. So again, please speak to your gastroenterologist. Please make sure that they are able to guide you well in time and guide you to find the shot and to take the shot on time. Same for the pneumococcal vaccines and all of the other vaccine preventable infections as well. Your GI knows how to handle it. You just have to have the conversation with them. And with this, I really want to thank Dr. Kochhar and thank Tina for putting together this really important session on preventative care And I think it's so, so vital that we stay on top of these things and make sure that we're taking care of our health, our bones, we're taking care of our gums, we're taking care of our skin, and we're making sure that we're in the best health possible for pregnancies and family planning as well. Thank you so much, Dr. Kochar.
Thank you for having me.
Of course.
Thank you.
Bye.
I think will be, please go ahead, Dr. Petty. No, that makes sense.
Thank you, sir. So I just have one doubt related to COVID. I got affected COVID a couple of times in my last 1 year. So, my doubt is, will be there any side effects in the long term for IBD patients who are affected with COVID? So, just wanted to know about that.
Ma'am, could you hear the question, ma'am? Dr. Kochar, can you hear the question? I think she's... Yes. Can you please repeat the question once?
This is Surijit. So my question is for the IBD patients who got affected with COVID, will be there any side effects or some complications in the long term?
Dr. Kochar, the patient want to ask that, are there any long-term side effects of COVID in IBD patients?
Did she log off?
Yes.
Yeah,
I think she's logged off.
I think she may have logged off.
We'll get back to you on that question, or I request Dr. Kiran sir to please answer that question.
Surajit, as you know, we don't know the long-term consequence of COVID yet. We are seeing different effects of COVID, not only in IBD patients, in general population, like lung stiffness and lots of chronic fatigability and other things. So in specific to IBD patients, I don't think there is enough data to comment either way. So I think that, but hopefully, a lot of IBD patients did very well during COVID and also after the COVID. So hopefully there will not be any major issues.
Thank you, sir. For the next talk on importance of trials in IBD, I request Dr. Sharada Pasangalapati. She's a senior consultant gastroenterologist and hepatologist in Yashoda Hospital Somajiguda. She is UK trained and certified in gastroenterology and hepatitis and hepatology. And she specializes in women's health in gastroenterology and liver diseases. Ma'am, please.
Hello everyone, thank you Dr. Kiran sir and Dr. Sriram for the invitation. Let me just start sharing the screen. Right, so I am Dr. Sharada and I work as a gastroenterologist here in Yashoda Hospital Somajiguda. I am going to talk to you over the next 10 minutes or so about what clinical trials are and what are the types of clinical trials that are usually done in the field of IBD, and how a clinical trial is conducted, the various phases of the clinical trial, the potential benefits of the clinical trials to volunteers, and also talk to you about the common myths about clinical trials, and I'll try and bust some of those myths today. Right, so what is a clinical trial? So clinical trial is a research study that is conducted on human volunteers, which is designed to evaluate the effectiveness of either a drug or a treatment, which eventually adds to medical knowledge. So what are the common types of clinical trials? The most common one we hear about are treatment trials, like a drug treatment or a surgery or a procedural treatment that might be beneficial than the currently existing treatment. Next come the preventive trials. So Dr. Kojar talked very much about preventive medicine, say vaccinations in IBD. What is the outcome of, for example, vaccination in non-IBD patients to response to vaccination in IBD patients, as an example. Then come the screening trials. We talked about colon cancer risk in IBD and trials which are now established, which have now established a screening mechanism, like anyone who's had more than a third of the intestine which is flared and have had the disease for over 8 years need colon cancer screening. So these are the screening trials. Next come the diagnostic trials. For example, if someone has Crohn's disease, which test is better for this patient? Is a CT scan better or an MRI scan better? So, and lastly, the quality of life trials. This particularly applies to conditions that are chronic. So long-standing conditions or chronic conditions, the disease per se may not be enough to be studied. So the effect of the disease on the long-term quality of life needs also to be studied in addition to the disease effects. And what actually happens, so before going to the trials, I'd like to take you through the steps that are involved in developing a drug or a treatment. First come the preclinical trials. So these are trials done in the laboratory, either on human tissues or animals or other equipments. So this, once successful, a molecule is thought to be of value in a particular condition. An investigational drug application is made, which is then forwarded through 3 phases of clinical trials. I'll talk to you about this in more detail, following which a new drug modality is registered, a new drug application is made, following which this drug comes into the market. And also, even after the drug comes into the market and we clinicians start using it, there is an ongoing phase 4 trial wherein adverse drug reactions or the real life experience of the drug is again reviewed in phase 4 studies. So the phase 1 study is the first time it's tested on humans. So up until then, the preclinical studies are tested in the laboratory. So the first study in a patient, which is usually a healthy volunteer, not a patient, mind you, is done as a phase 1 study. Phase 2 study is the first.
Been seen by the
Zoom.
Oh,
I'm sorry about Zoom, right. So phase 1 study is done in a small number of healthy volunteers. Phase 2 study is done on patients with that particular condition. It is mainly to assess the drug dosage and drug form. Phase 3 study is mainly to look at how well a drug works, so efficacy studies and also the adverse drug reactions, that is side effects of a drug. Phase 4 is a post-marketing surveillance study to make sure what has been proven in the clinical trial actually is true for a real-life experience as well. So just to give you an idea of numbers of how people are recruited in these trials. So preclinical trials done in the lab, phase 1 studies, a few handful of healthy patients, healthy volunteers to see if a drug has any particular side effects. Phase 2 study is in a small number of patients, mainly to look at how a drug needs to be given and what dose the drug needs to be given in. And phase 3 study is mainly to look for how well a drug works. And this is done in a large number of patients, 1,000 to 3,000 patients. And for conditions like IBD, because the numbers are small, it is usually done in a number of centers and sometimes across the globe. And phase 4 is after the drug is available. So now you might be wondering, what is the need or what are the benefits of participating in trials? So on a community level, I think if you've participated in a trial or your colleagues or friends have participated in a trial, you are contributing to medical knowledge and you are shaping how the disease is going to be treated in the future. And the decisions also shape how research is done in the future. But on an individual level, you might have access to cutting-edge therapies. So some drug which might be in the pipeline, I think in the last slide I failed to mention, that it takes up to 100 months for a drug from the lab to reach a patient. So 100 months is just over 8 years. So if you're in a trial, you might get there in maybe 3 years or 4 years' time. So you will have access to better drugs and receive expert care. So in a clinical trial, usually there is a principal investigator, there are sub-investigators, and their coordinators. So all of these people at various levels will be taking care of the patient. So there is more time spent in the hospital and more time spent with clinicians, ultimately resulting in better care, which is why we still do phase 4 trials, because you might be receiving extra special care in a clinical trial, so you automatically tend to do well. But in the real life scenario, we really want to see how well a drug works without that extra level of care. Do I approve this? Yes. Now, I'm going to talk, the rest of my talk is about trying to bust some myths about the clinical trials. So some volunteers might be thinking that they are just human guinea pigs. I think that is the most commonest myth and probably the most untrue of all. From the clinical trial design that I showed you earlier, a drug comes to be tested on humans after various stages of after testing in the lab as well as animals, and then phase 1 and phase 2. Most of you might get involved in phase 3 clinical trials, and you could have seen that there are a number of patients who have been exposed to the drug and a number of years that has been spent by the time it is tested on IBD patients. So by no means is a random drug is not randomly given to a patient. So the patient is only given the drug if we think they are going to be benefited from that trial drug, and that some other treatment which is existing is probably inferior to the drug we are going to test. Next is that clinical trials can be dangerous because they use new practices in medicines. Not all clinical trials use new practices in medicines. For example, a drug, an immunosuppressant drug, which works very well in another autoimmune condition like rheumatoid arthritis, can now be tested on a patient with Crohn's disease. So it may not always be new modalities or medicines, but as I mentioned earlier, the drug has gone through a number of checks before it gets to you. And also every center that does clinical trials has to have the trial approved by an institutional review board, and there are also lay people in that board. So there could be a lawyer, a teacher who form part of the board, and they wouldn't let a patient be disadvantaged because we are just randomly trying a new practice. So the next one is that if you join a clinical trial, you might get a sugar pill or placebo, or more commonly called the dummy drug. So first of all, most trials now use the standard of care versus the new treatment. the only trials that use placebos are in conditions where there is no established treatment available. So if we don't know that there is this, for example, if for malaria you're trying a new drug, you would compare it with the existing drug called quinine and not with paracetamol, because we know paracetamol only reduces fever in malaria. But if there is a condition called, for example, alcoholic hepatitis, we do not have an established treatment, then we can compare with placebo because we don't know which one works. So we better test it without any medication. And the other myth is that once I decided to participate in a clinical trial, I will not be able to change my mind, is what patients think. And I can see some heads nodding there. Before starting or entering a clinical trial, there is a very thorough established consent form. And I think you will have, well, not I think, I know that every patient or volunteer will be provided the information as to how long they are committed for the trial, what is involved in the trial, how many visits, at which week the patient has to come, and when are the procedures planned, how many tests are involved, and only if they're committed would they be taken up into the trial. And there is no binding, anyone can leave the trial at any time. It is by no means mandatory to continue. Now, the other myth is that clinical trials may include painful or unpleasant procedures. For example, a colitis patient might be expected to have colonoscopies or might be scared of having too many colonoscopies. This again is also very thoroughly set out in the clinical trial protocol. There will be, say for example, colonoscopy at 0 visit, which is before entering the trial or just after entering the trial. There might be another colonoscopy at 6 months or at the end of the trial. So no procedures are actually allowed in between unless the patient deteriorates or needs it for another reason. So again, will not be done without the patient's or the volunteer's consent. Then the other thought is that, or the other myth is that the clinical trial won't help the patient but helps other patients in general. No. We choose patients for a clinical trial if we think they are going to benefit from the trial and not just the general population. I think I've lost the screen. What's happening here? Can I continue? So yes, clinical trials will help the individual patients as well as help their community in general. Next, clinical trials are only appropriate for people who have exhausted all of their treatment options. And this is one thing that are very commonly asked. Yeah, no other treatment works for me, therefore I'm being recommended for a clinical trial. That is also not true. There are a lot of patients, or there are a lot of studies coming up for patients just at the time of diagnosis. So this could be treatment naive patients, we call them. Patients who've not tested or tried any other treatments can also enroll in some clinical trials. These are obviously approved when we think these drugs are going to be better than the already existing drugs and that they don't have to exhaust all options before going into clinical trials. And then another common myth is that they won't have access to the treatment, the experimental treatment, once the clinical trial ends. So most clinical trials, for example, if the trial is for 1 or 2 years, there is an option to have an open labeled arm. So if the patient feels that they've benefited from the drug, the trial often offers the drug for an extended period of time to patients. And I think I will go through a couple more. And another myth is that investigators conceal evidence when an experimental trial treatment doesn't perform as well as expected. So first of all, the investigators cannot conceal information because there are lots of people the investigator needs to answer to, and adverse drug reaction. For example, if 2 or 3 patients in the trial are having low hemoglobin because of this drug or whatever, it's automatically picked up by the trial coordinators who are beyond your investigator, and this is reported to the patients. Now, if there seems to be a very common or life-threatening adverse drug reaction, or even if a drug doesn't seem to be as efficacious as it is thought to be, the trial can be terminated prematurely. So no, not all information is passed on to the patients or volunteers. Some patients think that they have to give up standard therapy in order to participate in a trial. As I said, usually, for example, in IBD patients, if they're already on steroids, some patients just need maintenance steroids. Most of the trials give allowance for, like, for example, if you're on 15 milligrams of prednisolone, you can start the new drug while you're on 15 milligrams of prednisolone. So it depends upon the trial design, and you do not have to give up your standard therapy. And finally, most patients think that if there is a clinical trial, your doctor will tell you about it. Your doctor may not know about all the clinical trials that are existing, and I think patient groups like this will help you find trials that might be available in your area, and you can educate the doctor. And there are websites like clinicaltrials.gov, wherein all the local trials in that area are listed on this website. As of this morning, there are 1,400 Crohn's trials ongoing or just recently published, and about 1,200 UC trials in the pipeline, which is looking very promising for newer drugs. That's it. I'll take leave now. Thank you. And I'll hand over to Madhura and Tina to give maybe a first-hand experience of participating in trials. And I know Tina has. I'm not sure about Madhura.
Thank you so much, Dr. Sharda, for such a great overview of clinical trials and really demystifying clinical trials for us as patients. I think you've answered all of the questions that a lot of us have. Does being in a clinical trial mean you're a guinea pig? What about the side effects? What happens in a clinical trial? And can I withdraw from a clinical trial as well? So I'm going to ask Tina a couple of questions, because this is something I'm interested in as a patient as well. Tina, you've been in a couple of trials. So do you want to share your experiences with the trial? And, one of the things that we face as patients, we're always scared about starting a new medication, let alone one that's not in the market yet, right? So what have you learned from your experiences, and what would you tell patients who are thinking about a trial?
Thank you so much, Madhura and Dr. Sarda. It's great to be here talking about clinical trials. I think this is a very difficult subject for us as patients. There's a lot of stigma attached to clinical trials, and many of us struggle, like, is this a last resort drug? What is my option like after that? I want to assure you all that there are so many clinical trials in terms of a pipeline of medications coming out. I don't want you to feel like this is a last resort or that you're a guinea pig in this process, as Dr. Sarda was saying. I myself, there is a medication, a biologic called Kinumab that hasn't been released in India yet. It's known as Stelara by its brand name. And I have been on that for 7 years now. It's a subcutaneous injection. I inject myself in my leg. I have been on it since 2015. Most of us with ostomies, with fistulas, really struggled to get into clinical trials. I didn't have any options left. I had tried Infleximab, adalimumab, vedolizumab at the time, and I had had so many surgeries. Normally, having had so many surgeries is an exclusion criteria, so you want to get into this trial before you develop complications. So I was lucky enough that my doctor was a primary investigator in this trial, and he got me in. It was a late stage phase 3 trial, and it was going to be approved in another year, year and a half. So I got into this. they learned so much from my case, and I didn't feel like a guinea pig at all. In fact, I felt like I got better care during this time. I was being monitored so closely. They were taking my blood work. I felt like, you know, they really knew what was going on with my body and had an idea of, you know, with MRIs and such, and blood work and stool studies every few weeks. I think it really allowed me to feel like I was getting very specialized care. And within 3 months, I started to see an improvement. The one fistula that I had left open closed, and I suddenly had better energy levels. I was traveling internationally for the first time in 9 years, and I was able to consider patient advocacy work. I want you all to realize that as we may tend to have fear towards these things, towards new medications, but before they even bring medications into trials, there's already been some testing done on them in animal models, et cetera. They're not going to bring something into a clinical trial that they're not going to monitor you closely on. So I want to assure you that this is a safe process. Even in India, from the doctors I've spoken to, they're very committed to taking care of you. I've been in a couple other studies. I started to lose response to ustekinumab in 2019. So I was part of the POWER study where they reinduced me. Loading dose of ustekinumab in the first place because it was in clinical trials and they didn't realize until after that, you know, they might need to load people with a stronger dose in order to get maximal efficacy sooner. So they gave me that loading dose and they realized really quickly, within I think 6 or 8 weeks, I had an MRI and I was in remission again. So this was another positive experience. I was scared, but at the same time, I know I was going to be monitored closely. I've been in COVID vaccine related studies, monitored very closely as well in terms of my antibody levels, and that's providing our providers with the information that they need to know, are these vaccines working, like Dr. Kochar was talking about? Yes, they are. And they're seeing that efficacy because I'm going every single month to have my vaccine levels, the antibody levels checked to make sure it's working. So there's thousands of patients in these kinds of trials, and I think it's very important for us to have an open mind if we want hope for our future. Thank you so much.
Absolutely, Tina. Thank you so much
Mother,
for sharing.
Did you want to answer a question, Mother, or anything about clinical trials?
Sure. So I think I'll just quickly, very quickly add to what both of you have said as well. I think it's really important for us to think about trials as another drug in our toolkit, because sometimes, especially when you're going through multiple medications, it feels like you're running out of options, and it's a very scary experience to have. For me personally, just being able to see that there are so many trials, and like Dr. Sharda showed that, you know, you've got the clinicaltrials.gov website. Similarly, in India, you have the CTRI website, where you can see what are the current ongoing trials on Crohn's disease or ulcerative colitis and where these trials are happening. Just being able to see these trials, I think it's very important for us to think of these not as experimental treatments, but rather multiple new emerging treatments in our toolkit to handle IBD. And Dr. Sharda, very quickly, for IBD patients in India who might want to access these trials, how do we begin these conversations with our doctors? Because like you very rightly said, it's a myth that your doctor will recommend a trial to you. So how do we begin these conversations? Where can we get the information? And how do we coordinate this better for ourselves?
A difficult task. Getting a consent, I think, is easier. So the first process is what is most difficult. And it is a slow process. We don't mention it like there is a trial, go and see our coordinator, and that never happens. So you keep talking to the patient over multiple sessions as to what might be a better route for them. And then the in a way, unfortunately or fortunately, the source of information is through the gastroenterologist in India. There's hardly anyone in between the gastroenterologist and the patient who can give all this information. So if we feel as the PI or as a sub-investigator that this patient is going to be benefited from this particular study, we go through all the eligibility criteria with the patient and any exclusion criteria with the patient, and then refer them to the clinical trial network, including the coordinator at the first step. And then the patient is taken through the protocol and explained the protocol in their own language, and sometimes given out information to take to study and read, or probably in an email. And once the patient has gone through all of this, and next probably over another couple of OP visits, once the patient is convinced, then we move on to take a consent. So it is a stepwise and a slow process.
Absolutely. I think it's very important, like you said, for all of us to remember as well that, it's finally our free choice here. We have a choice to enter these trials. We have a choice to exit these trials if they don't work for us. We have a choice to be on therapies concurrently with the trials if we need steroids and so on. So I think it's very important to remember that the goal of a trial, we are not, yes, we are feeding into the improvement of IBD care for several other patients, like Tina has done with the Kinumab trials. But at the same time, we are also taking care of ourselves better. So a trial is a great way for us to take care of our health better and take charge of our health better. Thank you so much, Dr. Sharda and Tina, for sharing your knowledge about clinical trials and sharing your patient experience on clinical trials as well. And I really hope that this demystifies clinical trials for our IBD community and helps at least empower some of us to perhaps think about this when our doctors raise this with us as options. Thank you so much.
Pleasure. Thank you.
Thank you, Dr. Sharada. Thank you, Dr. Tanu. Thank you, Tina and Madhura. For the next session, it's a panel discussion on use of biologicals, myths and facts. It's going to be presented by Dr. Shubha Bhatt. She's a PharmD. She's a gastroenterology clinical pharmacist, Cleveland Clinic, USA. For these sessions, the moderators are going to be Dr. Srinivas Bishu, Assistant Professor, Crohns and Colitis Center, University of Michigan, USA. He has extensive expertise on immunology and IBD. And Dr. Sumit Bhatia, Senior Consultant Gastroenterologist in Paras Hospitals from India. The patient participants for the session are Ms. Ruchita, Ms. Harita, Ms. Madhura, and Mr. Chaitanya.
I think we just need to, okay, perfect. It should have on.
Hey, good morning or good evening, depending on where you're coming from. Are you guys able to hear me and see my screen okay?
Yep, we're able to hear you.
Perfect, thank you for confirming. So my name is Shubha Bhatt. I'm currently a clinical pharmacist. I spend a lot of my time with patients with IBD, and I do a ton around medication management. So I'm really excited to be talking to you today about the use of biologics and help deciphering some of the most basic effects. This is a topic I could go on and talk about forever. So I'm really excited that I'm going to focus on some of the key points that I think are important to know. And I'm really excited for the panelist discussion afterwards. So I'd like to just begin with highlighting some of the studies that we have done in the United States that focuses on biologic use, specifically in South Asian patients, and particularly those with Crohn's disease. So we have compared the two primary studies that are presented here on the slide that have looked at South Asian patients with IBD and compared to Caucasian patients that also have IBD. And what they found was that when they looked at the treatment of these patients, that South Asian patients particularly are less likely to receive more than one biologic during the course of their disease duration. And interestingly, if you look at a biologic use breakdown, so in another study with 31 patients, you can only see that approximately half of the patients were actually treated with anti-TNF, that it took approximately about 4 years, potentially up to 6 years, for patients to even initiate these kind of treatment. And the number of treatments that we use was around average of 1 to 2. You can see over a vedolizumab and Kinumab, even though these are available in the United States, the use of these were actually surprisingly pretty low among our South Asian patients. So this brings up the question of, so, okay, why is this a concern? Why do we care about the optimal biologic use in our patients? And so as we all know, with inflammatory bowel disease, there generally tends to be like a preclinical course, meaning that there's a disease onset, but the diagnosis doesn't actually happen until much later on. And what we essentially know is that if we don't treat that condition at that point, or if we don't diagnose at a timely manner, the inflammatory bowel disease can then go on to progress and lead on to additional complications like strictures, fistula, abscess, etc. And what we also know is that when we use biologic treatment earlier on, that we catch the disease early on enough, we use effective treatment options to control this inflammation, that patients are likely to have a higher response and a better outcome. So at the end of the day, delaying therapy, especially in the setting of complications, when we know that the disease inflammatory burden has progressed and it's advanced, the concern then at that point is that essentially the response to biologic therapy can be much slower. So this is really a main thing, again, to realize that the use of biologic treatment up early on is important. We also know that biologics are effective, so they're generally indicated for moderate to severe disease. The type of biologics that we have available work on different parts of the inflammatory pathway. But we also know that essentially what the biologic outcomes have been shown is that they help improve GI symptoms. They can induce and maintain remission. Then they reduce the need for hospitalization and surgery. And collectively, these are all outcomes that when combined together can lead to reduced healthcare resource utilization and ultimately improve patients' quality of life. On the right side of the screen, you'll see that these are some of the medication options that are available. So we have two main categories that we essentially call biologics, and there's another class of medicine that's been more recently identified called small molecule. So these all completely work in different mechanisms, but essentially for the biologic class, we have anti-TNF medicine. So this includes infliximab, adalimumab, certolizumab, and golimumab. And we also have anti-integrin, which is the vedolizumab, and we have anti-interleukin, which is Kinumab. And then for small molecules, we have a Janus kinase inhibitor, so this is tofacitinib. And more recently in the US, we had obtained a paper for Ibd Vaccination. And then we also have a new class of medicine called the S1P receptor modulator, so this is ozanimod. However, so while this is all great, I know that not all of these medications are actually easily available the rest of the world. So that brings on to my next category, that there's a lot of barriers to biologic use at this time. So we're definitely going to focus on cost and access. I know that's a big barrier. So I'm excited to hear the panelists' experience and insights on how to help navigate that. There's also a complexity to these medications, and we know that they're administered primarily through self-injections or infusions. So that requires a whole entire set of additional logistics to taking these medications. There's a major concern about side effect profiles, so we'll highlight some of the side effect concerns and how to help mitigate these or put it into perspective, if you will. There's definitely a physician discomfort with these medicines, so based on the perception, based on the knowledge that they have, there might be a concern about using these specifically in their patients. We talked a little bit about this at the last study, how there's some health, at the last presentation, that there's some health inequality. So we know that South Asians especially are underrepresented in clinical trials. So this could be another concern where, okay, you know that this medication works in that population. How can you safely say that these findings are gonna also apply to me? And then lastly, there's a big barrier with cultural perception. So we know, particularly in the South Asian community, there's a preference to manage by diet, herbals, and complementary agents. And there's definitely a big lack of trust in terms of conventional medicine. So I would like to spend some time to highlight some of these barriers, and I'm hoping that we can also address these in the panelist discussion that will follow afterwards. So in terms of cost and access, so I know that primarily in India, there's a that the biologic expense primarily falls on the patient. There's very little coverage from an insurance standpoint. So patients are primarily expected to pay out of cost for these medicines. And on top of that, when we talk about financial resources that are available to help these patients, it's actually pretty limited. And I don't know how accurate these numbers are, but I did find it in a publication. So they said that the approximate cost of Infleximab is about $12,000 and about $4,000 for biosimilars. And that the cost of adalimumab is also actually pretty high, so about $20,000 to $22,000. So again, looking forward to seeing the panel's input on this, but bottom line, we know that biologics are expensive, and it's definitely a resource limitation when patients are expected to carry that cost burden. So at the end of the day, being on these biologics long term, it's just not financially sustainable. However, this comes with a whole set of caveats. So what we essentially know is that if you do discontinue treatment, especially when you're in remission, that there's within a year, there's likely a 50% chance of relapse. So it's likely that even if you're in remission, you get off medication, you're doing fine, you're not necessarily having any inflammatory burden or symptoms, about 1 year and 50% of patients that stop these treatments will then go back on to develop inflammation and will likely require treatment. That percentage actually will increase over time. So the longer you go without medicine, it's likely that the percentage will increase in terms of the likelihood of relapse. The other main concern, particularly for anti-TNFs, is that if we do stop treatment, there is a likelihood that just because of how the medicine is designed, that there's a possibility your body can actually develop resistance to the medicine. And this is commonly termed as anti-drug antibodies. So essentially, if you do develop anti-drug antibodies to anti-TNF, it basically works to clear the medicine out of your body much faster, thereby not letting the medicine have its intended effect. So eventually what will then happen is that it's a medicine that we can't use anymore because you just won't have a response to it. And so this is a concern because we know that when you start anti-TNF, your best chance of really decreasing likelihood of anti-drug antibody development is to stay on it and try to do your best to be on time with getting the doses and getting the doses as instructed. But if you do stop it and try to restart it again, there's a likelihood that your body has already been exposed and won't respond as well as it has before. So I know that biosimilars is another area of interest. I know that there's some biosimilars that are also already available in India. The cost might not necessarily be a helping point just yet, but I'm hoping that with the growing market, this might hopefully help offset some of these burdens. So just a quick touch upon, we mentioned again that these medications, even though they're super effective, they do have some complexities that come along with it that definitely affect patients' lifestyle. So even if you do self-injection, the benefit of that is you get to do it at home. There is a potential, it still is an injection, so there's a concern about potential for having a phobia of needles. So if some patients are afraid to inject, then that could be a potential barrier. These medications often do require refrigeration, so having access to a refrigerator that's stable could be a potential another barrier. And ideally, these medicines should be disposed of in a striped container for proper disposal. So having access to that and coordination of that could also be another potential concern. From an infusion standpoint, there's still also a concern for needle phobia. But the bigger barrier here with infusions is that there is an additional coordination of care that's required. So making sure that you actually take the time off from work, you make travel arrangements, and you basically go to a center to receive your infusion. So we're not talking about straightforward medications here where you essentially are just taking a pill and you go on your day. These are additional considerations that patients need to keep in mind when using these treatments. So just real quick, I'd like to highlight some of the side effects. I'm not going to go into every single side effect that we see with these biologic medicines, but I want to highlight on some of the more common ones that patients generally tend to be more concerned about. So when we talk about biologic therapy, they generally will break it down to side effects that are more common versus like the real serious side effects. And honestly, a lot of these treatments are well tolerated. At most, maybe you might have a little bit of skin irritation when you go to inject or get the infusion, but have a little bit of fatigue after you get the medication. But honestly, most of these patients tend to tolerate these treatments well. However, there's still a consideration that, there are serious side effects, but the good news is that we have ways to mitigate these. So when we talk about serious side effects, infection tends to be a big one. And I know particularly in TB, tuberculosis endemic areas, this is actually a big concern that a lot of both providers and patients may have. So what we recommend for TB is that you should routinely screen for tuberculosis by using a chest X-ray and by tuberculosis testing. If you do find to have active TB, then you should go ahead and try to treat that. And it's okay to delay biologic initiation or temporarily suspend treatment if the patient's clinically doing okay. So it depends on the clinical situation at hand. But the good news is that we have tools to help screen and identify for TB and make sure that we're not necessarily letting this escalate. Other infection risks that have been seen with biologic therapies include hepatitis B reactivation, upper respiratory infection, pneumonia, etc. So the main thing that we do to help mitigate these risks is that we have you obtain baseline labs to identify your risk ahead of time, making sure that you don't necessarily have any active infection at the time of starting the treatment. We definitely highlight the importance of immunization. So I did hear Madura briefly comment that sometimes that can be a challenge to do. So it might be challenging to get some of these vaccines, but that's another way that we can help minimize these risks. And then we generally recommend standard precautions. So just general stuff that anyone should be doing in terms of making sure that they're avoiding or minimizing their infection risk. So that includes like washing your hands and using appropriate hygiene in terms of respiratory and cough precautions. So the other main big side effect concern that tends to come up with the use of these biologic agents is primarily cancer. So this can be lymphoma, skin, cervical. The good news overall is that anti-TNF, so the biggest class of medicines that's probably likely associated with the cancer risk would be anti-TNF. However, studies have actually been pretty mixed in terms of findings. And what we're finding of anything is that the use of combination therapy, so when you use anti-TNF with an immunomodulator, particularly thiopurine, the risk of cancer actually is instrumental or bigger in that situation. So one practical approach to help mitigate this is that you actually use anti-TNF monotherapy. But then again, there's some considerations on how to make sure that that's the best approach to do. But bottom line is, so I just want to highlight that again, and when we're talking about patients about cancer risk, this is actually a tool that I like to use. So it helps put into perspective that if you have 10,000 people that have Crohn's disease that are getting a combination of anti-TNF and immunomodulator therapy, the risk of developing particularly lymphoma is 6 in 10 in 1,000. So if you look at the picture, that seems like a really, really small proportion. Of course, some patients might be concerned, well, what if I'm that 1 in 6? But then at that point, I come back and I say, well, you do have a risk of colorectal cancer if we don't control the condition. So it's almost like a trade-off. Do you want to have a cancer risk that's very, very, very low? Do you want a good quality of life? Do you want to be feeling well and know that overall the ways that we help mitigate some of these cancer risks is that we do have you follow up with a dermatologist, and we do have you get a pap smear. So there are ways to make sure that we're screening for these cancer risks. Or conversely, do we let you go untreated and have that big risk of developing colorectal cancer? And we know some of the risk factors for this is having long-standing disease and extensive and complicated disease. So again, keep that in mind that there is a cancer risk likely either way, but the use of biologic medicine, that risk is likely to be very significantly much lower. So just to highlight, this is a pyramid that I love to use in terms of highlighting the IBD medication safety. At the end of the day, steroids, while they're effective, are actually the least safe medicine that we have. There's a big significant infection risk with these medicines, and the side effect profile is just mind-boggling, and it leads to a lot of complications. Following that, we then have thiopurine and an anti-TNF combination. Then next safer would be thiopurine or tofacitinib alone monotherapy. And then if you look at our pyramid, you actually see that our top 3 tiers are biologics. So this again highlights that these medications are actually pretty safe in the long run. And so there should not necessarily be any safety concerns when starting the treatment. So I know complementary medicine is huge in South Asian culture. So briefly just want to highlight some of the concerns that we have with complementary medicine. We know that these products are not often regulated. There's no oversight in terms of these products, in terms of the ingredients. So what I say I could put into the bottle, or what I list on the bottle, not necessarily what I'm required to put in there. And so there could be additional like contaminants or additional infiltrants that don't necessarily belong in that, but no one's holding me to that standard to make sure that I'm actually making that product safe. We also have, we don't actually have a ton of studies that really are well designed to assess the true effectiveness and safety of these complementary agents. Additionally, there is a potential for drug interactions, and it's hard for me as a pharmacist to help identify these because, again, I don't know what's going into these products. So again, there could be potential that it's interacting with other medications, and that can lead to more problems or complications. And then lastly, we have no data that supports complementary medicine as a replacement to conventional biologic therapy. So we have a ton of data showing that biologic therapies are safe, they're effective, they work. And we don't have any head-to-head studies that says that complementary therapy is just as equivalent or as useful as biologic therapies. I know curcumin or turmeric tends to be a big one that a lot of patients actually use. It does have anti-inflammatory properties, which is pretty neat about it, but I will let you know that it is poorly absorbed. It tends to be highly metabolized and rapidly eliminated. So the use of it in terms of potency compared to a biologic is nowhere as there. It might be more appropriate to consider maybe in the use of mild disease, but if you have moderate to severe, this is not an appropriate treatment strategy to consider. So I'm gonna briefly wrap it up. Just want to highlight some other additional myths that I've heard from patients in terms of biologic therapy. So the first one is that biologic therapy is not safe in pregnancy. Maybe a while back we could have said that, but we actually are having a lot of research come out now, the piano study being a big study that has followed women that are pregnant over time and looked at their birth outcome. But they essentially found was that the birth outcomes are not compromised at all by any means with the use of these biologic therapies. Some medications like tofacitinib, methotrexate, we don't necessarily, we know the methotrexate, we know kind of definitely cause some harm to the baby. So there's some recommendation around that specifically to not use that in pregnancy or to make sure that you abstain at least 3 to 4 months before conception. And then tofacitinib, we have some data that's kind of starting to slowly emerge, but as of right now, it's not widely recommended. But overall, the other biologics, so anti-TNF, vedolizumab, ustekinumab, we know are totally safe to use in pregnancy. The main pregnancy take-home point, honestly, is that healthy mom means healthy baby. So if we flare, we know that that's going to mean bad outcomes for the baby. So if we can keep you healthy during pregnancy, that's the main key point that I want you to take away from here. I've heard that people also have concerns about biologic therapy being poison. One important thing to note is that the immunosuppression that's happening with the biologic therapy is nowhere near as extensive as being on cancer or transplant medicine. So we're not wiping out your immune system by any means with the use of these treatments. If anything, we're modulating the immune system a little bit to get that inflammation down. We know that the source of these medications have been well tolerated, they've been studied, and I can tell you that the manufacturing standards are high. So it's not like there's just some outside factory making these medicines. It has to undergo a rigorous process to make sure that these medicines are safe and effective for patients to use. And then some other additional comments have been that my family or friends did not tolerate biologic treatment or had some complications or side effects. Keep in mind, everyone responds to medications differently. And the other thing I've also noticed is that correlation or association is not always established. So maybe it just might be like a weird coincidence, or it might be some kind of timing. But just because that person did not tolerate it does not mean that the same experience will happen to someone else. And then lastly, treatment duration is always a big concern. So what we know is that the use of these biologic therapies is that for IBD, we know IBD is a chronic condition. We know that there's a high recurrence rate if in remission and you get off medication. So again, 50% likelihood of developing the inflammation again about 1 year off of the treatment. And that percentage will just only continue to increase as the duration goes on. We also know that the first biologic treatment typically works the best, so that generally tends to be the main observation. And so as a result, the continuation of biologic treatment, even while in remission, is still recommended. It is possible to discontinue treatment, but this really needs to be a tailored conversation between the patient and the gastroenterologist, in the sense that both the benefit and risk needs to be taken into consideration. So just to recap, main take home point, biologics are safe, they're effective. There's definitely some barriers to use. But from a safety and efficacy standpoint, that should definitely be minimized because we know that we have the evidence to help support that these treatments should be used first line and that they're definitely superior over complementary therapies. At that time, thank you.
Yeah. Thank you, Dr. Shubha. That was a wonderful lecture. Thank you so much for taking out time to dispel these myths, against biologics. So I personally believe biologics are the drugs which have, dramatically changed the outcome of this chronic disease. But, as you rightly pointed out, there are multiple myths and cultural barriers, especially at least in our country, against biologics. And one of the primary ones being that this is poison. This is something like akin to chemotherapy, and you should stay away from biologics as far as possible. That's one of the major factors which we find amongst patients not accepting since, because most of these are injectables. They'll require infusions. They are prohibitively expensive, and they will play around with your immunity. So that's one of the myths. And I'm happy that we have a lot of patient advocates here. And I would seriously encourage Madhura and Tina to take on any of the myths which the patients might have. You must be getting a lot of questions. Now you have Dr. Shubha here online. I see Dr. Srinivas has come back online. So we can have a small discussion here about the safety of biologics, about the efficacy of biologics.
Absolutely. We've got 4 panelists here today from the patient advocates. And so could I invite Ruchita to share her experience? The 4 of us have been on biologics, are on biologics now, and have dealt with a lot of these myths and a lot of these barriers that Dr. Bhatt and Dr. Bhatia pointed to just now. And I'm hoping that through this conversation, we can discuss some of that as well. Ruchita, do you want to take us through your experience?
Sure, of course. Thank you, Dr. Bhatt and Dr. Bhatia, to speak about biologics, and I would like to share my experience about them. So when I was diagnosed with Crohn's, I was asked to start the biologics, but there was a huge fear and mental block associated with the injections, and they sounded like they were a very big deal, and injecting yourself bi-weekly for the rest of your life seemed like a challenging thing, and not in a good way. So also I have a huge phobia around needles, so I was from the very beginning saying no to the biologics because I did not want to inject myself or have infusions from the very beginning. And since I and my family were so scared, we tried to find a second opinion or a second resort. So we started with azathioprine, and that kept my symptoms under control for a few months maybe, but I never felt normal. And the reason I was so terrified about biologics was it seemed like it was an end-stage treatment, like it was prescribed to patients only who had no other options, but only taking biologics at the end of all other medications. And I thought I wasn't at that position. So the lack of awareness around them made me feel like I was to take biologics only if I needed them. And if I would have taken them, I would have been disabled in a way that could hinder whatever was left of my normal life. But thankfully, when I consulted Dr. Gursing Rinpoche, he sat me down and he explained how biologics actually work and how they could change my life and might be able to live, and I might be able to live a normal life, and that too symptom-free. He was not wrong. I started adalimumab last year in July after a horrifying colonoscopy result that indicated that my colon could suffer perforation at any moment given. So fast forward to today, a week ago from my current colonoscopy, the results say that there was a 90% improvement from adalimumab, and I had strictures, which I no longer have. And these past 9 to 10 months on biologics have actually been life-changing. And I'm talking about a good change here, and I have been symptom-free, and most importantly, like I feel normal, a good quality of life, and I find myself doing everything like a normal, healthy person does. And as a graduate student, I'm able to study and work harder, and as well as party harder. So with biologics, it's been a miracle for me, and I would never understand why I ever needed to be convinced before. So that's what my experience was. Thank you.
Thank you so much for sharing that, Ruchita. I think it's so important for us as patients. I think all of us have been in that place where we're so concerned about starting a medication and we're thinking about all that can go wrong. We don't necessarily focus on all that can actually go right and all that can make work and make us feel so much better and live with the quality of life that we deserve. We also have Harita on this panel, and she's actually in person at the conference. So Harita, could I invite you to share your experiences with biologics as well?
Experience with biologics. When I started, it's like I have been asymptomatic for a year and a half, and during 2019, it was like I suddenly diagnosed a partial stricture, because of which I was prescribed to go on to biologics, and that made me a lot of panic because I was in a position not to afford it. So during that time, I spoke to many of my IBD friends who are already on biologics. So they referred me, they reviewed me about the biologics, like some of the friends reviewed it like it's a miracle medicine and life-changing for them, and some of them were getting troubled with the insurance, and some of them were like running behind the struggles of the cost effect, and some of the patients lost their response to the biologics and trying combinational therapies. So despite knowing all the ups and downs of biologics, I was still worried because of the cost of the biologics, and also because of the availability of the next level of medication. So I requested my gastro to put me on some alternate medication for the biologics. So during that time, my gastro helped me with a short-term steroid and Azeron. And in the meantime, I started researching, like I was reading a lot about it and speaking to so many experts, and even to many of my IBD friends to gain knowledge on how to heal this stricture and the biologics that are available in India all over, and the dealers who are offering different costs in the local aid, and the biological trials and the upcoming medications, etc. So, and after an year, we found that Azeron and the disciplined diets that I was following was not healing my stricture at all, and it's just managing it. So knowing that the stricture treatment, delaying the stricture treatment can make it fibrotic, I didn't want to take the risk. So I asked my gastro to start the biologics. So I started my biologics in the last November, and going good right now. So despite of my particular health condition or the biologicals working, it's like biologics or making, like challenging us mentally and financially till date. Thank you for having me here. That's my biologics review.
Thank you so much for sharing, Harita. Before we move on to our other patients, Dr. Vishu, Dr. Bhatia, do you guys have anything that you would like to share with our patient community based on what Ruchita and Harita have shared so far?
Yeah, I just have a couple things that I just wanted to mention. I think notwithstanding the cost of biologics, which may be prohibitive for a lot of patients globally, including India, it's really important to understand, it sounds like everybody here has had a positive experience with biologics, but there are 2 points that people, I think, should really understand about biologics going into it. One, they're not going to work in everybody. So once you've made a decision to sort of start biologics, there really has to be a commitment, because your chance of responding will be 5 or 6 out of 10, which means you may need to shift on to a second agent. And I think that a lot of people do get frustrated if that first agent doesn't work. So you really have to sort of be committed to that. The second point I'd like to make regards strictures, actually. So by the time strictures have formed, it is probably a little too late for biologics if you're heading for surgery, because biologics, they prevent inflammation, but they don't necessarily treat strictures. Now, the next generation of biologics we're hoping will treat strictures, but right now, things like Humira, Kinumab, Infleximab don't actually treat the stricture themselves. But it's important to keep that in mind.
Thank you so much, Dr. Bishu. Dr. Bhatia, do you have anything to add before Chaitanya and I share? Dr. Bhatia, you're on mute.
So I'd like to address, I think, another cultural barrier, which Shubha, enumerated in her slides, that there is also a physician discomfort associated in our country with biologics. Not every gastroenterologist or a physician is very, very comfortable using this. Again, it comes from the cultural practices because they are expensive and they have an inherent risk of, precipitating some infections, especially tuberculosis. So physicians are also hesitant in initiating biologics upfront or suggesting biologics to their own patients, because when a patient is spending, most of our patients spend out of their pockets for these drugs, and when they are doing that, the expectation is always for a 100% relief of symptoms and 100% cure. And as Dr. Srinivas pointed out, the chances of success with any agent will be at best around 50 to 60%. So, that kind of acceptance has to be discussed with the patient, with the clear response rates and the clear knowledge about what we are doing. The second thing is, most patients, as you pointed out, are fixated on the negatives of biologics. They don't want to, clearly see the other side, whether these drugs can dramatically alter the course of the disease. So once we tell them about tuberculosis, they are highly fixated on that, that the risk of tuberculosis will go up and the risk of reactivation of hepatitis will go up. At most centers and most gastroenterologists, when they are prescribing biologics, let me assure you, they are running, a whole battery of investigations before these are, initiated for any patient. And we have clear-cut data from India itself, from most, the majority of the academic centers, that the reactivation rates for tuberculosis is 10%, which is very high. And most of these centers were the government centers. And every patient generally undergoes a CT scan of chest. That's because, we cannot only solely rely on chest X-rays in our country, because tuberculosis is majorly an endemic problem here. And the viral markers are always done. The basic tests for tuberculosis are done. And it's only once the physician and the patient are both satisfied that, there is no active infection, then the patients are initiated on biologics. So there is a safety drill which is followed for every patient. So there is, I don't think that the fear of developing infections should be so high. Okay, so these are the 2 points I actually wanted to make.
Thank you so much, Dr. Bhatia. I think Chaitanya and I'll quickly go over our experiences, if that's okay, just another minute or so. Thank you. I just wanted to quickly add also about the cost of medication, because we've been speaking so much about it. I think it's equally important for us to speak about what is the cost of uncontrolled disease, right? And for me personally, that has been my experience, and that's really what motivated me to start a biologic. Because when I was diagnosed, I'm a researcher by training, and I was traveling for fieldwork to remote parts of India very frequently, once every couple of months. And my diagnosis meant that I had to quit my job because I was not able to control my symptoms. I wasn't able to access toilets or access safe food when I was traveling. And losing my job and becoming dependent on my family was really, it took a real toll. And in addition to the loss of income, I was also frequently in and out of hospitals, in and out of outpatient care, needing multiple procedures, multiple IVs of different kinds, and these expenses add up as well. So for me, really the motivation to start a biologic was to feel productive again and feel like I had my life and quality, had my life back and had my career back as well. And I think it's important. We're in a position where we're walking this tightrope between very expensive therapies that might help us do better, but on the one hand, and cheaper therapies that are more affordable and less of a drain, but that might not help us control our disease adequately. So I feel like this is a tightrope that we're walking, that I wish patients didn't have to walk. And I really hope that through our advocacy efforts, we will see this change. And I would also reinforce what Dr. Bhatt, Dr. Bishu, and Dr. Bhatia said, which is this myth in our community that you're not sick enough to be on a biologic, that you really need to wait to have a stricture or a fistula or active, severe ulcerative colitis before you can start a biologic. This is an absolute myth. Biologics are very effective when they're initiated early on in the disease progression, and they can slow the disease progression and they can modulate our disease course. So I started a biologic in the absence of these symptoms because I was told that this is the best way for me to ensure that my disease progresses more slowly and that I don't develop these complications. Could I quickly ask Chaitanya to summarize his points as well? Okay, sure. I'm sorry about that.
Thank you, Dr. Bhatt and Dr. Sumit Bhatia and Dr. Srinivas Bishu and all the participants for the next panel discussion on psychological aspects of living with IBD as a South Asian. I invite Dr. Anjali Pandit. She's a Assistant Professor of Medicine, Gastroenterology and Hepatology and Psychiatry and Behavioral Sciences, Northwestern University of Feinberg School of Medicine, USA. She's a psychologist with specialty in gastrointestinal behavioral health psychology. I request Ms. Tina Aswani to moderate the session. Thank you.
Can you hear me and see me okay? I hope so. Let me know if you can't.
We can.
Thank you. Great introduction. I'm so pleased to be with you today here in Chicago. I am going to speak about psychological and social impacts and influences on IBD. And so I wonder if now when you think about your healthcare team, you probably think about your physician, maybe your dietitian, maybe your nurse, the medications you take. We just heard so much about biologic medications, maybe surgery. And I hope by the end of today's talk and discussion, you might think a little bit more about your mental health and the social and cultural factors that might play into the management of IBD for you. Okay, and so like I said, I am a clinical psychologist, but have specialty interest in training in working with patients with health conditions. And so in that way, I think, most likely your medical provider is really focusing in on the biologic factors of the condition. So genetic factors, medication responses, those kinds of focus factors. And I think a lot about the context. So what is the context of the patient? So what does IBD and the treatment of IBD look like in terms of a bigger picture? So what about the social impact? What is the patient's demographics? How much support are they getting from family and friends? We were just talking about biologics, access to medications, income, costs of these really important treatments, and of course, cultural factors. How does someone's cultural background, beliefs about health and medicine, how do these things impact how engaged they are, how much they're able to self-manage their IBD? And then psychological factors too. So factors like mental health. Again, coming back to what does someone deep down believe about their health, believe about illness, believe about these medications, and also factors that I think are related to culture, can be related to culture, of how does the community experience inflammatory bowel disease, and how does that impact someone's day-to-day experience? Are they experiencing stigma from others? Can that even translate to internalized stigma? So shaping beliefs about themselves related to inflammatory bowel disease. Personality factors, also important to keep in mind, as well as behaviors in response to illness. So what does somebody do when they're not feeling well? What does that look like? And all of these factors really influence someone's experience with inflammatory bowel disease. And so that's, as a psychologist, what I'm looking for when I'm talking with patients or working with them. And what I am not saying at all is that mental health is a cause of IBD at all. I think that that's a misconception that very much we're moving, hopefully moved away from at this point, because it's simply not the case. However, you know, from my seat, they're linked to one another in a lot of different ways. There are some direct pathways and through inflammatory processes of the body that someone with depression might have more inflammation, as well as indirect pathways. So if we think about how important inflammatory bowel disease is for each patient to do the work of self-management, a lot going into that. Things like adherence, decision-making around which treatment to pursue, having just disease knowledge. I mean, inflammatory bowel disease is an incredibly complex illness. Being able to understand what's going on inside the body and making treatment decisions based on that, as well as, you know, another important factor in terms of self-management is how do you relate to and communicate with the medical team? Even bigger picture than that, we think about, you know, especially thinking about the patient panel that we'll be hearing from and you've been hearing from throughout the day today is, you know, your inflammatory bowel disease is part of the picture of who you are. So how are we preserving or creating meaningful life roles and adjusting based on the needs of the disease? And you know, that's I think an incredibly important factor too in thinking about self-management and how does someone self-manage well. And then of course, acknowledgement and management of the emotional and psychological impact of IBD. So being just acknowledging that this is something to consider and think about and possibly get help for if needed. And so I wanted to, again, think now about specifically mental health. So what are these, probably the top conditions that we see when it comes to mental health and IBD? So we see when we measure experiences like anxiety and depression, we see pretty high rates. So in a US study, finding that anxiety is prevalent in about 20% of IBD patients. There was a study here done in India looking at consecutively enrolled patients and finding a rate of anxiety of 67%. Depression, similarly, even higher rates, so 26% of US IBD patients, 72% of Indian IBD patients, again, consecutively enrolled. And post-traumatic stress, which we'll talk a little bit more about what that is in a later slide, 32% of US IBD patients, again, one single study, finding that these symptoms are coming up. Why do we care about this? So, you know, presenting you some data about these high rates of anxiety and depression, what does that mean when it comes to IBD? Well, we know that now anxiety is associated with lower adherence to medications, increased risks for surgery, and a decreased quality of life. And similarly, depression linked to decreased medication adherence, increased inflammation, increased experience of pain, and decreased response to treatment. So now we're looking at how, you know, if we can treat these mental health factors, maybe we can help treat IBD itself through indirect and direct pathways. Because I'm not sure how familiar everyone is with these mental health conditions, I wanted to just introduce briefly what they look like. So, you know, these are things that you might be able to look out for or, you know, screen for in yourself or others. So what is depression? One thing I want to keep in mind as I go through what these diagnoses are is that every human being has shifts in mood, and that is perfectly normal, and how we experience life and how we actually live a fulfilling life is having ups and downs with how we feel. So I transiently feeling sad or down or blue is no big deal. When we, start to be concerned about depression is when that feeling sad, down, or blue or empty is starting to last for pretty much all day, every day for 2 weeks or more. And someone is also experiencing less enjoyment out of life's experiences. So things that usually brought a lot of joy are just not that interesting anymore. When that starts to happen for that 2-week period or more, and happening almost every day, pretty much all day, that's when we start to ask questions about whether or not this is a depression that we should be considering treating. Alongside of those symptoms of feeling down or blue, not enjoying activities, can come with feelings of guilt, worthlessness, helplessness, shifts to appetite, shifts to energy, shifts to sleep, having more difficulty with concentration, maybe moving more quickly, feeling like you're more commonly is moving more slowly. So kind of feeling like you're trying to move through water, even though you're not in water. And then it can be accompanied with feelings like life is not worth living. This is all pretty abstract. So this could look like in someone's real life, things like thoughts of, what's the point in taking my medication today? This is a chronic disease. It doesn't really matter. It's not going anywhere. Maybe some change in behavior, like, I usually being very engaged and excited about school, but turning in an assignment late because it was too hard to focus and feeling overwhelmed. And again, maybe that's a shift to your common experience with school. And then, or maybe things like, I don't want to go to my cousin's party today. It will be too exhausting. And besides, I just won't be able to cope with how everyone asking me how I'm doing. So it, could show up like that too. In and of themselves, none of these are diagnosable, but just could be indicative of symptoms. Anxiety. So the hallmark symptom of anxiety for many people is uncontrollable and excessive worry. So finding that your mind keeps going to unsolvable problems and you can't really stop your mind from thinking about those things. So having that mind spinning about something that you can't do anything about, but having a lot of difficulty shifting your attention elsewhere. And that worry can come up and disrupt sleep. It can make someone feel more irritable, more fatigued, can come with muscle tension, so feeling a tightness in the muscles, restlessness, feeling like you can't sit still, and also trouble with concentration. Again, kind of translating this could show up as kind of just like a persistent pain, body pain and aches, a tightness in the shoulders, back, and jaw are really common areas. Thoughts like, I just won't be able to manage Crohn's disease and graduate school. I just don't want to fail. It's just not even worth trying. What if I need surgery? What if I need a certain treatment? It's just too much and overwhelming. It's not worth it. Maybe my doctor suggested 2 kinds of therapies. I don't know which one to try. I can't figure it out. I don't want to disappoint him. I don't want to make the wrong choice. And then feeling kind of stuck in that indecision. And maybe even a sense of feeling very tired, but not having the ability to sleep or having really disrupted sleep. That also could be a symptom or sign of anxiety. Again, in and of themselves, not diagnosable, but just ideas. And then post-traumatic stress disorder. This is a psychological condition in response to suffering trauma. And historically, we've thought about trauma as being in a life or death experience, suffering from abuse. And those are absolutely very much true. But and when we're talking about IBD, we're learning a lot more about how medical trauma is also a trauma and can produce post-traumatic stress symptoms. So coping with inflammatory bowel disease is incredibly stressful. And it can be a matter of life or death. And so when those experiences accumulate, we might see post-traumatic stress and do see post-traumatic stress in our IBD patients. Symptoms that this might look like are finding yourself having intrusive thoughts. So memories or thoughts about experiences just popping into the mind and feeling very distressed about them. Having nightmares or flashbacks to actually experienced events. Avoiding reminders, avoiding the hospital, avoiding the clinic, avoiding anything that could remind you of those experiences. Maybe some amnesia around experiences that you've had. Having negative beliefs about yourself, self-blame, feeling detached, less connected to people around you, finding it hard to feel happy, feeling more angry or reckless. And being more vigilant to your surroundings. So kind of being on edge, kind of being scanning your surroundings more frequently, or feeling like you can't turn that off. Again, this could look like things like, I can't sleep. I don't want to have a nightmare about I don't want to have another nightmare about my surgery. Not going back to the doctor because of fear, or because of just feeling so much discomfort. Less interaction with others because of just feeling more irritable and more angry. And also, post-traumatic stress symptoms can come with increased use of alcohol, tobacco, or drugs. So things to look out for, and things that we know can impact self-management of IBD and things that we have treatment for. So these are conditions that there is hope for and we can improve upon and subsequently improve IBD. And then, I don't want to be too negative because there are certainly a lot of positive factors too. And one of the ones that I'm most interested in is resilience. So resilience is an inherent and modifiable capacity of an individual to cope or recover from adversity. I know often we think about resilience as sort of a quality someone has or doesn't have. And now we know that this is modifiable. We can increase someone's resilience through some therapies and some other strategies. And we know that increased resilience, so people who demonstrate more resilience when we measure it, in terms of IBD, have less disease activity, increased quality of life, and in Crohn's disease specifically, seem to have fewer surgeries. So again, this is another way we can look at some of these psychosocial, psychological aspects of IBD. So I hope that coming out of today's talk, when you think about your healthcare team and how you manage IBD, of course, it includes all of the factors that we saw on the first slide, but maybe you're thinking more and more about the mental health piece of managing IBD as well, because it really can be integral. Where you can find help. So I know here in the United States, even psychologists embedded within the GI centers aren't terribly common, but if you have someone affiliated with your medical center, fantastic. But also outside of those medical centers. So just freestanding depression, anxiety, trauma symptoms can have an impact on IBD. You may not need a health psychologist specifically to help. But there's also some bibliotherapy, some really great books out there that can help either increase knowledge and also help with some of these mental health symptoms too. And of course, other resources to look out for. Here's places where you can get really good understanding about IBD and resources that might be out there too. And I think that wraps it up for me. And I think we've got a great set of panelists to talk about their experiences.
Thank you so much, Dr. Pandit. Really appreciate a fantastic talk on mental health and IBD. This is absolutely essential in our care. I think her slides are still up, if there's any way to take that down. Perfect. I wanted to introduce our panel today. So Chaitanya will be first in speaking, and Dr. Pandit, if you could stay on, here's some of the comments, and if you have, they may have some questions for you, so we would love to hear your comments too. Chaitanya, please go ahead.
Yeah, thanks, Tina. Hi, everyone. First, a little bit about myself. I'm Chaitanya. So I have Crohn's disease. I'm diagnosed with Crohn's disease in 2009. So most of the years I have used the other drugs like azathioprine, mesalamine, mesalazines, and steroids. So in 2018, the biggest flare-up of my life happened. So I was suggested biologics at that time, but I couldn't proceed because they're too expensive and we couldn't afford them. So I was on steroids for almost a year and a half, and that has helped me a little bit, but they also caused a great deal of side effects, and one of which is mood. I used to be gloomy all the time. I used to sleep on the bed all the day. I even had suicidal thoughts a few times. I don't know if it is due to the disease itself or it is due to steroids. So finally, I started biologics last year. It's been almost 6 months. Now I'm currently under the treatment of Dr. Kiran Beddi of Yashoda Hospitals. Now I think I'm going good on biologics. I see some significant improvement. So now I think comes the most important part, that is the psychosocial aspects of living with IBD. So this is my 17th year of living with Crohn's. I mean, that's more than half my age. So I was in class 11 when I started showing the symptoms. From then till the completion of my post-graduation, I had many academic setbacks due to my illness. Even simple things like sitting in the classroom and listening to the lectures proved to be very, very difficult. I even had to take a couple of years off from college owing to my bad health. I finally managed to complete Master of Pharmacy degree at the age of 25. I think that's probably my biggest academic achievement till date. So I have got my first job when I'm 26 and I resigned at 28. Now I'm almost 32 and I'm jobless. I see people of my age having successful careers, getting married and starting families of their own. I feel like I'm stuck in life when all the world around me is moving forward. So also being the only son of my parents, it makes me really sad that I had to trouble them at this age. I feel like I should be the one who's taking care of them. But unfortunately, it's the other way around now. So my parents support me fully, and they even they are the ones who are sponsoring my medication and all, because I have absolutely no savings left from my job. So yeah, even though they support me fully, I have this constant lingering pain that I'm unable to look after them. So the past 3 years of has really changed my life. I mean, all the pain and the suffering that I have experienced has really helped put things in perspective. Now I know that I have to place my health above everything. So I have reconsidered my career choices and I started doing freelance work this year, and also mental health. So unfortunately, mental health, even the mere talk about mental health is a taboo in India. Already the IBD is a taboo topic, and on top of that, mental health too is a taboo topic. So like with all other chronic diseases, IBD also, it has a heavy toll on the mental health. Sometimes I feel that dealing with the emotional aspects of the disease is more challenging than dealing with the actual physical aspects. So as men, we are expected to be strong. So we are always told from childhood to suck it up and be a man. So I have even heard people say stuff like, don't cry like a girl, stop whining. I really feel bad about this, because such remarks are not just insensitive, they're outright offensive to women. So whenever we show our vulnerability, people will think that we're weak. That makes it increasingly difficult to talk openly about my condition. So I have tried to get therapy. I live near a tier 2 city, but there are only very few therapists available here, and they are always overbooked. So I have looked online. I have looked, in fact, extensively online. So there are a few options, but those are really expensive. Me already affording biologic therapy out of my pocket, even adding this would be too difficult to handle. So finally I have found someone who specializes in cognitive behavioral therapy. I have had a few sessions, but I had to stop because the therapist has no idea about what IBD is. So I think this is a real problem. We need therapists who understand IBD. I think only then the therapy can go in the right direction. And I also know and speak with a few men who suffer from IBD. And I hear a lot of concerns about their careers, their mental health, even their marriageability, and about their ability to have kids and all, and the mental aspects, the mental burden of marriage. So I think these are some real problems that we need to address. So male mental health, it shouldn't be a stigma. And this I would like to say for all the men who fight with IBD, you don't have to go through this alone. There is help available. And speaking up about your vulnerability isn't weakness. And being a macho is overrated, seriously. I may be vulnerable, but I know that I'm not weak. Thank you.
Thank you so much, Chaitanya. That was excellent. And I love your point about male mental health being very important. We need to take care of our emotional health just as much as their physical health, especially living with a disease like inflammatory bowel disease. It's very easy to get down, as Dr. Pandit has been sharing as well. I do want to move forward and pass the baton over to Sharon Kayla of the UK. Sharon, if you don't mind coming forward and sharing your experience on the psychosocial front.
Hi everyone, thank you Tina. So just a quick background, I'm from the UK. I was diagnosed with Crohn's in 2002, and when it comes to psychosocial factors, I of course had surgery in 2014, a subtotal colectomy to form an ileostomy, and to have that in my 20s of course was quite challenging mentally, because not only did I not really have any knowledge on living with an ostomy, I also felt that it's such a deeply stigmatized thing to have in our community that I was adamant to have it reversed as soon as possible. At the 3-month mark, however, post-surgery, my weight had gone up to 45 kilos from 41, which was an improvement, but of course my surgeon and GI both felt that it was too much of a risk to consider having a reversal. So they said, for the time being, we just want you to get better, get your quality of life back together after having had emergency surgery. So I think that was when I really had to kind of try and come to terms with living with an ostomy. I tried to join several support groups online to find, like-minded people who were going through the same thing. I found that playing around with supplies, finding the right bag, and of course in the UK we have support wear is readily available to us. So I think having all of that made it a lot easier for me, and it helped me gain confidence in having an ostomy. And I would say that at the 2-year mark, I was completely comfortable with my stoma. I was back at work full time. I joined a local netball team, so I was playing sports again, which I hadn't done since I was at school. I could go swimming. I was traveling with my bag. I would go to music festivals. There wasn't really anything that I felt the ostomy was keeping me from doing. But around the 2-year mark is when my GI brought up the conversation about potentially having a reversal if I wanted to, because he knew how desperate I had been to have one at the beginning. So he said that, if this was something I still wanted to consider, because I am young, and he thought that, the success rate for me would be, it would be a successful surgery. Although my surgeon did raise to me that there was a 50% chance I would go back to needing an ostomy at some point. So there was obviously a lot to consider, but I think coming from a South Asian family, what my family and I started to discuss was marriageability and how having an ostomy might affect me being able to get married or finding a partner that would be accepting of that situation. I think even before the ostomy, I used to worry about marriage and how, you know, being chronically ill might affect my chances in finding someone that was accepting of that. And of course, in our culture, we don't just marry the person, we come together, both families come together, and you do have to take their opinions into consideration as well. So I did worry that even if I was to find a partner, I might not be the daughter-in-law that, you know, his parents were looking for. So I think in the end, that was what led me to having the reversal. And looking back, I wish that I had put my quality of life and my health above everything else, because 6 months after my reversal, I was back in a flare and I stopped responding to adalimumab, which I was on at the time. So then I needed to go, you know, I was in and out of hospital, needing scans, trying to find the next treatment option for myself. So it did feel like I had made the wrong decision. And of course, that took a toll on my mental health, because I felt like I had taken this step and done this to myself, whereas I could have just left things as they were with the ostomy. So I can't, of course, go back and change how things were for myself, but I do hope that, you know, going forward, we do continue to see positive stories and experiences of people living, you know, full and healthy lives with ostomies, because they really can be life enhancing and bring back the quality of life that you haven't had for, you know, how many ever years. I think for the first time since my diagnosis in 2002, having an ostomy is what brought back that quality of life that I was lacking. So I do feel that as South Asians, there's just so many factors we have to consider rather than just our quality of life. And I wish it wasn't that way.
Thank you so much, Sharon, for sharing, and thank you, Chaitanya, again for sharing. Dr. Pandit, just wanted to close off and see if you had any comments regarding mental health in our South Asian culture.
No, I really appreciate all the patient comments as well, because I think that is so valuable to hear about. And I think the thing that I think about most is kind of the expectation of ourselves and putting that in the context of the disease, and having the flexibility to shift those expectations. It seems like, you know, something that it helps aid in the resilience factor. I think that's something that I think can be really foundational and help with this self-management piece. And I know it sounds like the resources there, at least in India, are pretty limited. And so I wonder, you know, maybe even just connecting with other patients on some of, you know, the SAIA Facebook page, or, you know, any kind of patient community is a phenomenal way to kind of build on some of the mental health pieces and resilience that we've been talking about. So.
Sharing your life experiences with us. Now we have a topic of diet in South Asian diet in IBD. I would like to invite Ms. Neha Shah from University of California, San Francisco. She holds degrees as registered dietitian, certified nutrition support clinician, certified health education specialist, and master of public health. I request Ms. Sunita and Ms. Gayatri, who are dietitians, who deal on a daily basis with IBD patients, to moderate the session. Thank you.
Okay, everyone. Thank you. I'm so happy to be here today. Like he mentioned, my name is Neha Shah, and I am a dietitian at the University of California, San Francisco. I'm also in private practice and have been specializing in nutrition for IBD for the past 15 years. Thank you so much for having me here today. Here are my disclosures. Our learning points for today include the following: understand the role of foods that may possibly play with the development of IBD, and certainly to highlight claims and evidence of foods used in the treatment and management of IBD. And last, I want to share with all of you practical applications that I use to help my patients improve intake and reduce symptoms within the Indian diet. The role of diet is an important role in IBD, ensuring all foods from all the food groups, non-veg and veg protein, dairy substitutes, whole grains, fruits and vegetables can help bring in a variety of nutrients to really be at a healthy weight, lessen symptoms, and reduce the risk of nutrient deficiencies. However, not all foods are equal in the same food group. Strategies may involve types and portions of foods to include and how to build trust again so you feel more confident in your food choices. The response to diet may vary from person to person, so it's really important that diet is used along with medical treatment to really optimize its efficiency. There are a total of 12 diets explored in IBD at this time. Knowing this, I'm not surprised of all the questions of what diet to follow for IBD. It is beyond the scope of the diet talk today to review each diet in detail. Although the current evidence does not yet support specific diets as primary and sole therapies for IBD alone to resolve inflammation, that does not indicate there's a lack of benefit. We just need more studies to help learn more of the role with diets in IBD. A common theme between many of the diets proposed for treatment in IBD is to include fiber. Fiber is the non-digestible part of the plant, and it's found in fruits, vegetables, whole grains, and legumes such as beans and dal. Humans cannot digest fiber, but our bacteria in our gut through the process of fermentation can. There are different types of fiber in the diet, and different types of fiber have different functions in the gut, where some may help reduce diarrhea, some may help more with constipation, and certainly there are fibers in the diet that does not produce as much gas as well. The proposed role in IBD include that when bacteria act upon fiber, it is their byproducts that promote the production of short-chain fatty acids that are anti-inflammatory to our gut. Studies have shown that fiber may reduce the risk of IBD in some, and especially in Crohn's disease, reduce the risk of more flares in some. Now, the next set of discussions will include looking at the various food groups and their role that may play in IBD, and what food options I have seen to be tolerated well. Oops, I'm so sorry. Okay, so with that said, for non-veg protein, we'll refer to meat, poultry, fish, and eggs, and veg protein refers to protein coming from plants, such as beans, dal, and chana. In Crohn's disease, a few studies have shown that a high intake of animal protein may increase the risk for Crohn's disease, whereas other studies have shown more moderate intake, could be possibly related to smaller portions, or perhaps it's not included at every single meal, has not been associated with the development of IBD or its relapse. Now, for those who eat non-veg, we'll suggest that, certainly not to eat non-veg protein at every single meal. It is okay for those who are non-veg to eat chicken or fish in small portions, about the size of a deck of cards. For those who are veg, foods like chana or rajma or dal can be blended and add to the side of the meal. If there's a lot of gas with these foods, certainly it's okay to soak in water overnight and rinse, and then cook with new water to help reduce the gas. And another example I can highlight for those who eat quinoa, a half a cup of quinoa, it's about 5 grams of protein, can be added to phowa or pulao, and certainly can be added less if needed, depending on the comfort level for the portion. Now with dairy, certainly consumption of dairy has not been associated with increased risk for Crohn's disease or ulcerative colitis. However, many find dairy to be bothersome to symptoms such as diarrhea, gas, or bloating, which can be possibly related to poor digestion of lactose, which is the milk sugar found in dairy. And it may lead to lactose intolerance on some level in the setting of inflammation in the gut. Now, with dairy, certainly dairy is a high source of protein, calcium, and vitamin D. It can be a part of the diet for IBD. I will highly recommend do not eat unpasteurized dairy, as this may worsen inflammation or worsen symptoms. As dairy is also an animal protein, eat dairy in only small amounts, such as a sprinkle or a slice in foods. Options such as chas or curd or lassi or paneer are all okay options to have in very small amounts, like a half a cup of chas or a little bit of milk and chai or a few cubes of paneer. If dairy is bothersome to symptoms, can certainly choose lactose-free as available and have it in small amounts as well, whereas dairy substitutes would be okay to have as well. Now with fruits and vegetables, certainly with fruits and vegetables, they're a rich source of vitamin A, C, fiber, and phytonutrients that are all anti-inflammatory. For fruits and vegetables, high intake of fruits has been associated with reduced risk of Crohn's disease, and both fruits and vegetables may reduce the risk of ulcerative colitis. As fruits and vegetables have been associated most with reduced risk of development of IBD, and its flares in some, it is important to gradually add a fruit or a vegetable to each meal. What may improve tolerance to fruits and vegetables is changing the texture to even blending or mashing the fruit or vegetable, removing the skins as much as possible, and eating in half a cup, which is about the size of a tennis ball, in very small portions, especially in setting of a stricture or as needed with an ostomy. Not all fruits and vegetables are equal to one another. Some might be more gas producing than others. Certainly options I have seen to be tolerated well in my own patients are banana, cantaloupe, kiwi, mango, eggplant, gourd, like loki, and potato and spinach. Now with wheat and gluten, certainly gluten is a protein found in wheat, barley, and rye. For wheat and gluten, there is no evidence that we're learning so far whether avoiding wheat and gluten, promotes mucosal healing in the lining of the gut. However, studies have shown that many feel better when there is less gluten in the diet with less symptoms and more energy. It is suspected that those who do not have celiac disease that have symptoms with gluten could be related to the carbohydrates called fructans found in gluten that do not digest, as humans do not have digestive enzymes to digest fructan. So with that said, there is usually minimal need to completely remove gluten from the diet. However, it may help to eat less, not completely avoid if there are symptoms associated with gluten. Choose a mix between gluten and non-gluten grains. Options could be have, a food with gluten at one meal and the rest of the meals could be gluten-free, such as upma in the morning made from millet, phowa in the afternoon, and chapati in the evening. Now for sweets. Okay, so certainly high intake of sweets. We haven't really seen much data that there is any worsening of IBD when comparing intake of sweets, sugar, with fiber. However, too many sweets certainly may potentially worsen symptoms of diarrhea, gas, and bloating. It is okay to eat sweets in small amounts, especially around our Indian festivities, such as Diwali. I will recommend not to eat it daily, as some sweets may have dairy. It can certainly be made with lactose-free or, certainly with dairy substitutes as needed and as available. Options that I've seen tolerated well are small amounts of halwa or half a laddu or one gulab jambu. Now, certainly bringing back to the topic of fiber is that, the amount of fiber that we may eat and the type of fiber that we may eat may vary between a flare or coming out of a flare or into remission. So certainly here are some of my strategies that I've helped my patients eat fiber during a flare, where it might be a small amount of fiber, just at least one at each meal or at one meal during the course of the flare with low gas producing fiber. And certainly when they're coming out of a flare, I may add an extra cup of fiber to another meal. Then they may go to 2 meals and 3 meals a day. And certainly in remission, the goal is to have multiple foods with fiber at each meal to really bring that in. But nutrition, care, fiber intake is not linear. Certainly symptoms will dictate how much fiber what may come in. And then certainly to almost wrap it up is that, part of the long-term goal of eating healthy in IBD is to really also over time build a balanced meal. And, a balanced meal meaning that there's multiple food groups at this meal that will bring in a variety of nutrients. And certainly the goal is to include one protein in the corner, like a dal or a rajma or chana. And certainly one corner may have a grain such as rice or a roti. Another corner may have a cooked vegetable of some sort. Again, blended or mashed if that is needed. Same thing with fruit. Dairy can also count as a protein for those who are vegetarian, and that can be all part of the mix. And this is a long-term goal, but it is a process to work towards. And finally, final thoughts is that overall, the recommendation is to follow a plant-based diet that includes multiple food groups, fruits, vegetables, whole grains, and legumes as the main sources of carbohydrates. We want to bring in that fiber. Any spice or herb is okay to use as long as it's tolerated, like Ibd or Ruchita. But if spicy foods are bothersome, then can certainly limit. And then, a lot of my patients are bothered by garlic or onions. So I felt like I had to add, you can certainly try Jane recipes if that is the case, because those recipes will not include garlic and onion. And then finally, I will end with, focus on what to add more of, not less of, to help treat IBD. And with that, thank you for inviting me here today. And I would like to invite Gayatri and Smita to share their experiences locally.
Hello, Neha, and that was very interesting talk. You have given deep insights into the topic and, of course, revealed some interesting facts. Yes, good nutrition is the foundation stone for good health. Like any other diseases, I think, including IBD as well, which plays a very important role. Whether it is the etiology, I think the westernized diet, which consists of more saturated fat, refined carbohydrates, a lot of sugar. All right, we see the incidence is more in the Western population as well, and now increasing towards in India as well. And talking about the treatment, we talk about exclusive enteral nutrition diets, low residue diets. And when we talk about prevention during the remission, I see most of the patients, they try to be on a very restricted diet, try to self-manage the GI symptoms and restrict too many things. I think there we need to intervene, guide them. I think the diet has to be more individualized, like the tailor-made diet, because it is not the same for all the patients. Symptoms are different. So probably we can put them on more. As you said, the diet is different during the flare-up, during the treatment, and during the remission phase. So I think every step has to be modified, and they have to be under proper guidance so that they have a better outcome overall. Yeah, and once again, it was very informative and very, I would say, enlightening. Yeah. Gayatri?
Yeah, hi Neha. Good evening, everyone. Yeah, as you mentioned that the personalized diet is more needed, and we are also giving the counseling the similar way. People who are able to tolerate some food groups, we are increasing their quantities, proportions in the diet. and people who are still need some help, then we are advising them to take some mashed or pureed form of food including in the diet. So that way we are also giving the counselings here for the patients who are having IBDs. Yeah, thank you. It is very informative.
So we will be handing over to the patients now. To speak, Harita, if you don't mind sharing your patient experience with diet, and then we'll move to Sharon and proceed on to the next session. Please feel free, Harita. I believe she's in the audience.
Yeah, being a vegetarian, like I tried many diets like SCD, Candida, and Paleo, etc. Like these diets are like so confusing when some of these diets doesn't allow most of the foods, and my gut doesn't tolerate some of the foods, and because of which I used to left with very limited options to eat. So leaving these all diets, I tried a whole plant-based diet because it helped me to go with most of my go-to foods. So then, like maintaining these diets definitely helped me to a great extent because especially during the COVID times, as I was not in a position to meet my gastro personally, this helped me to settle most of my symptoms, and at the same time, my blood markers like CRP was also normal. But when we got our screening tests like CT or colonoscopy, we found that my inflammation was still active and silent and slowly progressing inside. So it indicated me that, even though we are on strict and disciplined diets, medication is equally important at the same time. And at the same time, even the diets are important when you are on high-end medications also. So here we even know that that is not the only triggering factor for the IBD. So, and when coming to the diet, even though I'm on maintaining my disciplined diets, my diet was not the same all the time, because with every flare-up, my tolerance level used to change. So I keep on changing my diets accordingly, even which it was affecting my family too, because as the food is mostly the family thing when it comes to the, so though we are trying hard to keep up our nutrition and weight balances, it's sometimes we fail doing that because most of the foods we don't tolerate here. So this is here we definitely need a IBD-centric dietitian who can help, and when we are lost during this time. So I would like to thank my dietitian too for this aspect. And the other issue we face here is whatever the diets that were available in the social media, or web pages we see in the internet, they're all Western diets. It was hard to cope up with those diets and adopt them or change our diets accordingly. So it would be great if we can have any South Asian specific blogs or pages the recipes or any information regarding the religious foods or regional foods. It would be great, especially for the children who are getting diagnosed with this IBD and not able to maintain these diets and all. Yeah, that would be a great help we can get. Thank you.
Thanks, Harita. Just to add to that, from a UK perspective, of course, I was diagnosed as a pediatric patient. So the first line of therapy for me was exclusive enteral nutrition via nasogastric feeding tube, which at the time I felt quite embarrassed to have one because I didn't want to be seen in school with it. I didn't want people to stare and make comments about it. And I think even for myself at that point, I had only ever really seen it in babies or elderly people. So having an NG tube myself as a child, I felt uncomfortable with it, and I tried to avoid social situations as much as I could. But of course, considering the positives of it, when I was diagnosed, my weight had dropped down to 28 kilos. So having the enteral nutrition was effectively what allowed me to gain back that weight so quickly, and it kept me from becoming or staying severely malnourished. And even today, as an adult, whenever I need to go back to enteral nutrition, I have kept it as part of my diet. My GI and I both agree that it needs to be something that I stick to whenever I'm in a flare, or even if my appetite isn't great, because I do lose weight very quickly. To avoid becoming malnourished, it is, I think, the easiest way for me to maintain my weight and to avoid malnutrition. And to touch on, effective dietary advice as well. Of course, when I was first referred to a dietitian here in the UK, the advice was very much catered to a Western diet as well. So when my mum and I, we were reading through the leaflets we were handed, and the advice basically just said to avoid spices, coming from a Punjabi family, and up until that point, having, my meals were mostly dals, roti, sabji. So it was very confusing at the time to try and figure out what they meant by avoiding spices. To me, that meant avoiding Indian food altogether. So I couldn't, my mom and I couldn't really figure out what they wanted us to do with the diet. So my mum thankfully did like a trial and error herself. So she used to make variations of the dishes that she would make for the family and make a small batch for me to allow me to feel included in meal times as well, because I found it incredibly isolating to not be able to enjoy the same foods that my family were eating. So by making alternative meals that were similar in a sense, but maybe using different ingredients, I wish if that kind of advice had been offered by the dietitian and the care that they provide was culturally competent in trying to understand us as individuals and trying to cater, as was mentioned before, that diet is such an individual thing, and I think you need to work alongside with patients to try and make sure that you're providing them the advice that they need based on their background and based on their upbringing. Diet is never one size fits all, so providing everyone with the same advice very rarely works.
Thank you so much, Sharon, for sharing. I would have to agree, cultural competency is extremely important, whether we are in the diaspora or even in South Asia. We have so many foods in our cultures, from North Indian to South Indian. All over India, we have different cuisines, and trying to understand what suits our body and what doesn't suit our body can be very challenging, and oftentimes a dietitian can really help. Neha, Gayatri, Sunita, thank you so much for your comments, and Neha for your presentation. I'm just going to hand it back over to Dr. Sriram.
Ms. Neha, now for the last talk of the patient discussion, I request Ms. Madhur Ramdin, Clinical Nurse Specialist, NHS UK, to talk on the role of IBD Nurse Practitioner and IBD Counselor. Ms. Harita and Ms. Sharon are requested to moderate the session. Thank you.
Hello, everyone. I'm not sure if you can see my screen. Is my screen already shareable? Thank you.
Your screen hasn't been shared.
All right. Not sure. Is that better?
There you go. Yeah.
Okay. So thank you, everyone, and thank you to our SAIA colleagues for inviting me today to share, what the role of the inflammatory bowel disease clinical nurse specialists and advanced nurse practitioners are. In terms of my role, I am the lead clinical nurse specialist at St. Mark's Hospital in London, which I'm sure most of you probably know. So in terms of the role of the clinical nurse specialist, our role is multifaceted. We carry out, day-to-day run-ins of the service of, most hospitals. And do forgive me because my knowledge is obviously based on what we do within the UK. However, that said, I do have an idea as to what our colleagues within other parts of the world do. So similarly to the US and Australia, New Zealand, and other parts of the world, Canada, we know as well there are IBD nurses emerging from places in South America because we have constant contact with some of our colleagues in Brazil. So in terms of the role we carry out as IBD nurses and advanced nurse practitioners within the UK, includes on a sort of daily basis helping with an advice line. That's one thing that we have here, which I'm sure Sharon could probably tell you about later on. And I'm hoping that, it's sort of highlights in a good way, because the advice line that we run within the hospital that I work in, it's daily, Monday to Thursday from 9 till 3, and then on Friday from 9 till 1. In terms of the way that advice line is run, patients will call us with many queries, including when they are experiencing a flare-up of their inflammatory bowel disease. As you can understand, with sort of St. Mark's being a sort of international tertiary referral center, we can easily have between 40 and 50 calls coming in a day. It's viewed that St. Mark's is sort of singing and dancing because we have a lot of CNSs, a lot of nurses, but still on occasions we struggle daily to sort of, reach out to all our patients within 24 to 48 hours. And that's not just a problem sort of local to us, that's across our nation, the 4 nations within the United Kingdom. And obviously there are many sort of benchmarking processes that take place to ensure that this is addressed, and ensuring that patients with inflammatory bowel disease do have the help that they require. But I can tell you it is definitely a struggle. In addition to that, we do follow-up clinics. Some nurses as well will have patients who in their clinic are experiencing a flare. And in terms of how the clinics are run, it varies. You can have a patient coming in for education for a new diagnosis, patients coming in given the fact that the medication might not be working for them, given their diet is not probably working for them at the moment, because not all of us have, sort of availability of a dietitian. Yes, St. Mark's does have a dietitian, but not all the other centres across the UK has a dietitian. So that can be very tricky. So in terms of our follow-up clinics, it varies sort of, what we do and how those clinics are run. Just to add as well, at St. Mark's, we have what we refer to as our community clinics. Our community clinics are very much our patients are very much in remission and has been in remission for quite a while. So they are sort of managed out in the community primarily by their GPs, and with the advanced nurse practitioner sort of taking on that role to ensuring that those patients are sort of kept away from secondary care and sort of utilizing slots within secondary care as well as not coming through the front door of our A&E. And that takes us nicely into inpatient reviews. According to the IBD standards within the United Kingdom, one of the standards set out within those standards is that all patients who suffer with inflammatory bowel disease and are admitted to hospital, they must be seen by an IBD nurse. So, you know, within our hospital, we have a bleep service, so almost like a service where you can just be called and informed about a patient. Obviously, this can sometimes get a little bit messy, so you need to ensure that this is all streamlined. So you will ask the named consultant or the consultant covering the ward and the team covering the ward and that patient to ensure that a referral is appropriately made to the IBD nursing team. In terms of our roles as well, we are very much of a multidisciplinary team, and we work very effectively within that team. And we are also highly respected within that team. In terms of the multidisciplinary meeting that we hold, most hospitals within the UK will definitely have this once a week. And within that meeting, we would give our, we would present our cases, and occasionally we will share our opinions as well. In addition to that, we do have colleagues who will chair that meeting in the same way a doctor or a surgeon will chair that meeting. So in terms of our role there, it's also multifaceted. Moving forward, again, our role in terms of education, we are there to educate our patients about various aspects of inflammatory bowel disease, be it their drug therapies, their diet, body image, and more recently, one emergence has been that a lot of patients didn't find it very comfortable talking about sex and intimacy. And this is something that, you know, as a patient advocate for those patients with chronic diseases like inflammatory bowel disease, just being that advocate to educate your patient as to how they can deal with those problems that they are facing is something that is newly emerging. And I'm sure my colleagues in the US and across other parts of the world can concur with me. But that's also something that, you know, more recently as nurses, we've had to learn about ourselves and try to ensure that we build that rapport to help our patients through that problem that they may be faced with. Another role that we carry out, which is very, very important, is the counseling and sort of therapeutic drug monitoring. So we will counsel our patients on the use of azathioprine, methotrexate, tacrolimus, mercaptopurine, and also their biologics. So we are very fortunate at St. Mark's to have a new starter biologics clinic. And this clinic is a multidisciplinary team approach. So a pharmacist, a doctor, and a nurse is present within that clinic. So that clinic sort of accounts for the counseling of the drug that they will be initiated on. And then, of course, once that patient is initiated on therapy, the drug needs to be monitored, and that is very important. So we have various systems within St. Mark's, and so do other hospitals across the UK, where they monitor, which aids the monitoring of the drugs that are being used. Another aspect of our role is that we do undertake rapid access clinic, and this ensures that patients have access to us, not 24 hours, because that's not a service that is sustainable, but they have access to us that if they are experiencing a flare and they do need to, you know, urgently see a nurse alongside a named consultant, their IBD GI consultant, that is facilitated as well. In addition to that, we also liaise with our GP colleagues in primary care, and that can sometimes be a little bit tricky because often, I'm sure Sharon could attribute to this, occasionally wherever you live in the UK, it could be that it's a postcode lottery. So some patients may have access to certain things and others will not. And obviously, we're trying to change that in the UK, but it's a lot of hard work. And in addition to all of that, and doing the clinical aspects of it as well, we do participate in research and audit. There are nurses within the UK who lead on research. They are PIs as well. So we do take a lead role in that. We also are key stakeholders in terms of policy and protocol development, not just locally within our hospitals, but also nationally and internationally. And in terms of growing, the number of nurses we have, it is important that, we continue to train other nurses and other colleagues, not just nurses, with the knowledge that we have, share that with them and ensure that, there is growth within the IBD world. So I just took out a few sort of key aspects of our role that I think, is really important as an IBD nurse. And one of the key things to me is personalized care. And more recently, within the last decade in the United Kingdom, this is something that has been very much given a lot of focus. And yes, as we all know, patients with chronic lifelong conditions like IBD, it's important to have personalized care. And often we can get a little bit warped and think that personalized care means, okay, we just make a policy or protocol and run with it. No. If you think about each patient as an individual, that care has to be holistic, that care has to be personalized. And don't get me wrong, we don't always get it right because, and you don't just set it in stone and say, well, this is the gospel and this is what you do, because you have to keep reviewing it. You have to keep sort of working with that patient, having that holistic approach, giving them the opportunity to self-manage, to support. And by including that patient, making that decision, you then have coordinated joined up care and ensuring that that personalized care plan is reviewed at all points. So this is something that has also been benchmarked by the IBD standards, and also in terms of what is set out in the IBD standards for us to ensure that we meet as benchmarking service provision levels in the UK. So obviously, in terms of personalized care, I'm sure that our colleagues across the pond in the US is probably doing very similar things. But again, I think it's slightly different because of the way our NHS is run and the way your health service is run. And probably, in terms of what happens in India as well, I'm not sure in terms of personalized care, what level of that is being delivered or what level of that is given to patients at the moment. So it'll be interesting in the discussion to hear a little bit about that. So moving on, another role that we carry out, as I mentioned earlier, is the therapeutic monitoring of drugs. And this is something that is really, really important because often you would have follow-up appointments with your GI name consultant, and that appointment could be 3 months, 6 months, or 12 months. However, your IBD nurse, your advanced nurse practitioner, is the person you are mainly in contact with, who is monitoring that drug. And in terms of us monitoring that drug together with the patient, it gives us an indication as to whether that drug is working for that patient or not. In turn, we can then discuss that with the name consultant, with the GI consultant, to ascertain what is the next best step for that patient. In terms of supporting, as I mentioned earlier, education is a huge thing. Another key thing that has come about sort of again within the last decade, and is something that's really, really important, and more so, at this time we are observing colorectal cancer month. And surveillance is such a big thing because obviously those patients with ulcerative colitis has an increased risk of colorectal cancer, which we know, and ensuring that those patients have the appropriate surveillance pathway gives them a better quality of life, gives them that little extra reassurance that someone is looking into this, someone is paying attention to, what's going on with my disease. And so that's something I don't know, again, if that happens in India and how much of that happens there. So again, it will be interesting to, hear in the discussion how that unfolds. And I must say, having read quite a few tweets on Twitter recently with regards to colorectal cancer month, yes, there are patients who, and there's no age barrier to this, there are patients who are currently in that process of, dealing with colorectal cancer as well as inflammatory bowel disease. So it'd be interesting to hear what happens there. Another big thing is, for us here in the UK, is shared care agreement. So as I mentioned earlier, there's the postcode lottery, which means that some of our clinical commissioning groups do not facilitate shared care agreement between primary and secondary care. This is something that is key to patients being looked after in the community as well as in hospital. Because if GPs locally can help with as much of a patient's care, then that prevents that patient from coming into hospital, taking time out from whether it be work or, things getting worse. So sort of, it's a stopping gap, if we want to call it that. Another role that we carry out, as I mentioned before, is liaising with the multidisciplinary team and the primary care services that we have within the UK. And I know Neha just spoke about diet and nutrition, and yes, at St. Mark's, we are very lucky to have that, but nurses across the 4 nations do not have that service of a dietitian within their service. So that's something that we're looking to grow within the UK, and obviously listening to Ruchita and one of the other dietitians, it's interesting to hear how, the services in India is also run as well. So in terms of self-management, which ties in a little bit with personalized care, or probably very much ties in with personalized care. So within the UK, most services, most IBD services provide their patients with a flare card. So that flare card is almost like a business card, a call card. But in addition to that, it gives the patient a process map and gives them sort of contact details for a sort of different availability of help that can be given to them. So that flare card will tell our patients what is available from Crohns and Colitis UK. It will tell them what is available from Stoma UK, from the Dietetic Association, and then obviously give them that contact details to come back to us within secondary care, who are their main providers. And obviously, as I mentioned before, personalized care planning is so key to helping that patient to self-manage at home. And yes, I agree, and I totally understand that maybe personalized care isn't just something that you blanket all patients with, because patients are in different periods of their disease. So some patients will be in remission, some will be having a flare, and depending on where they are in that path, they need to understand what is required. So hence we require sort of a review of that constantly. And sort of, I think cost-effective education and signposting falls in quite well with the flare card, which most services across the UK try to give to their patients. And signposting in the UK is becoming more and more a thing that we are using because of the fact that services are overwhelmed with the number of calls that we are getting. And obviously that service provision, that telephone advice line and the email advice line, is a service provided by the nurses. And because it's so overwhelmed, throughout the 4 nations, we have a lot of support from people like CCUK and other organizations, other charities as well. One of the main things that we use in the UK is patient-reported outcome measures. Patient-related outcome measures, as it's also known. So that helps in us sort of, getting an idea from the patient as to, what to do next. And that ties in quite well with patient knows best and patient-initiated follow-ups, which is what we're trying to sort of get cracking within the UK, where so patient knows best and sort of patient-initiated follow-up are for those patients who are primarily in remission and they can initiate their own follow-up. So let us know as and when they need to be followed up. And this is something that is used in other chronic diseases as well. It's used in many other services, not just inflammatory bowel disease. So as you can see, in terms of our role as an IBD nurse and as an IBD practitioner, it's multifaceted. Oh, sorry. So our main take-home messages is, as an IBD nurse, we form part of, we are an integral part of the IBD team, and we work as a bridge between the patient and other members of the IBD MDT, and personalized care and self-management support will help to improve patient quality of life and standards of care, and so much more, which I'm sure you all agree with. And thank you very much. Any questions?
Fantastic talk, and you gave a very good overview of how the reminded me my NHS days. So thanks for that. Any questions from the audience? If not, we'll move on to the next session because we're running late. So no questions, Madhur. So thank you everyone, and that finishes off the patient empowerment session. We'll have a quick 10 minutes break before we move on to the PG postgraduate session. So all the patients who are sitting here, you can have a tea break and then you can leave after this. So next session will be postgraduate session. I thank entire SAIA team for organizing this patient empowerment session. We had excellent talks from every speaker you can think of, and excellent overview of many topics. Thank you, Tina. Thank you everyone on behalf of SAIA. I'm sure some of the members would still like to stay online, but we'll move on to next session in 5 minutes' time. Thank you. Served outside, you can feel free to have them before you leave. Thank you.
earlier, wherein so many of our patients came forward and advocated for the right evidence-based treatment for IBD. It's really a new initiative, and I must congratulate Dr. Kiran for having this successful session. The next two sessions, which is the one which will happen right now, is the PG session, wherein the basics of IBD and the new updates in IBD will be discussed today. And Dr. Kiran has organized an amazing lineup of sessions to be discussed tomorrow, which will be the clinician session. So I would request all postgraduates to make the best use of the subsequent sessions. It has been specifically designed for updating our current IBD knowledge. With that, I would hand over the mic back to Dr. Kiran, and looking forward to these sessions now.
A few words.
Dr. Kiran, I think Dr. Srinivas is not online as of now.
Oh, he's not online? Fine.
No, he's not.
In that case, I request Dr. Ramesh Kumar and Dr. Setu Babu sir is not here yet. So we have another international faculty as a chairperson for this session, Dr. Masudur Rahman. He's one of the senior gastroenterologists from Bangladesh. We are privileged to have him on the board as well as a chairperson. So first talk is going to be by Dr. Ravi Shankar, endoscopic assessment of IBD, various scoring systems. We'll start in 2 minutes time. So to start the first session, I invite Dr. B. Ravi Shankar, one of the senior gastroenterologists in Hyderabad, and he works as head of the department of Yashoda Hospital, Secunderabad. Over to you, sir.
Thank you, Kiran, for giving me this opportunity to speak in this very interesting forum on IBD. And I thank so many seniors are there. And you have to excuse me for one reason, that I may have to leave the place after I finish my talk, because we have another program of Yashoda in the place. This is how we are going to focus the slides. There is some small technical issue, so we'll show the slides like this. So the topic that has been allotted to me is this endoscopic assessment of IBD, mainly about the scoring systems. So IBD, as we know, this is a chronic relapsing condition with a lifelong treatment. There is no single effective or sensitive test. Several scoring systems and classification systems have been developed. Our idea is today to simplify everything and focus on certain few things, certain classifications or scoring systems where we can use practically and make the entire topic a very practical issue. These systems are helpful in assessing severity and predicting the outcome. Scoring systems provide an uniformity in clinical trials. So obviously this slide would slightly confuse us because both in IBD and CD and UC, we have several scoring systems. Okay, we can know about all these scoring systems, but what are practically useful for us, those are the scoring systems which we should follow. And there is no point in going after all the scoring systems. Maybe as postgraduate students of gastroenterology, they can know a few more scoring systems, but once it comes into practice, when you're really doing practical work in your endoscopy room or in your office, you need to know about a few scoring systems. And as my future slides are going to show, when and where it is going to be useful. So we have certain clinical scores and certain endoscopic scores. CDAI, we all know, HBI, Mayo partial and Mayo full. These are the scoring systems. They are basically clinical scores. And we have certain endoscopic scores, CDEIS, SECCD, there is a simplified score, Mayo endoscopic score, Rutgers score, and UCEIS. Again, this appears still confusing, but I think picture is covering one small point there, that is IGIBS, IBD. IGIBD is a site where if you go, except the last one, except this last one, all these are available as an app. As we know practically, when I was a student, there was a lot of difficulty in doing this CDA activity index. But now it takes only 2 minutes for you. You can in fact educate a nurse, educate your secretary, somebody, the entire index can be done in 2 minutes only. That's what we have to do. So basically nowadays, inflammatory bowel disease, we are focusing on, of course, the basic is a clinical response, clinical remission, biochemical, mucosal healing, and other things. So clinical trials, they concentrate on this one, remission here, biochemical, and sometimes mucosal healing. Usually the clinical trials are not so much concerned about the histological healing, but histological healing is also talked about nowadays. So this is a Harvey-Bradshaw index or HBI. This is used in some clinical trials. There is no point in going into all these details, just to know that these are the items which we need to concentrate in this index. Again, there is no need to mug up anything. All these are there in the app, IGIBD app. Well, as you are listening to the lecture, you just go to Google and apply the IGIBD, click there, you will get 8 scores, 8 points of this. And that's what you have to do in your practice. General well-being, abdominal pain, number of liquid stools per day, abdominal mass, and complication. And you need not remember that for complications, I will give 1 point or 2 points. It is there. If you say complication of arthralgia is there, the app will pick up and give you a score. You don't have to remember what is remission, what is mild activity. Everything is there in the app. I think there's absolutely no point in remembering all this. Just become a practical person and go to this app. You don't have to download the app also. Anytime you can just go, put IGIBD, it immediately comes. You can keep trying now. I have a slight problem in changing the slides because we are not used to this type when we are talking. So CDAI, as I told, will take only 2 minutes. What are the important points in CDAI? The liquid stools for over a period of 1 week, abdominal pain, general well-being, extraintestinal manifestations, the antidiarrheals that are being used, abdominal mass, hematocrit, and weight. Again, whether it is 1 point is for 7 days, other point is for a day or so, like that also you need not remember. And multiplication into so much factor also need not be remembered. Just go to the app, go for CDAI and keep doing. It will take only 2 minutes and you get your scores. So same way, Crohn's disease endoscopic index of severity. This is one of the scores. It's a slightly complex score. Now, this is being not being used in clinical trials, whereas this is being used. A simple endoscopic scoring system is used, and both these apps are available again in that. Rudgit score is mainly for the post-operative persons, and this predicts whether these patients are going to get a recurrent disease or not. And this is also available in the app, but anyway, Rudgit score is not practically applicable many times, and basically this probably is, this scoring system is done mainly by the surgeons. So there are things like Vienna, Montreal, there is also a Paris modification of Montreal. They are not practically very important, but you just need to know that such scores exist. And if somebody is doing a Montreal classification, you can say, we'll go for a newer classification which is commonly being followed. Again, ulcerative colitis also, the RAME responses like clinical response, clinical remission, biochemical, mucosal healing, and histological remissions all do apply as in Crohn's disease. So Mayo score partial was applied in a few years back for clinical trials, but now Mayo full is being applied. This is also called disease activity index. In fact, some of the representative of the sponsors, they come and they say, when you say it is a Mayo full, no, they say no, it's disease activity index. It's that they do not know about it. But Mayo's full score. Again, all these are very much available in that app. You just go to that app, open it, just do in 2 minutes, everything is done. But it is better we follow these things because it has become very easy. Earlier it was not so easy. Now it is very easy and they can be followed like that. So there is again a Montreal classification for ulcerative colitis. I have just put these slides, but they are not very important. What is important, I will just show in the coming slides. There is also a ulcerative colitis endoscopic index of severity, but Mayo partial and Mayo full are important. These are some of the clinical trials that have been that are being done in our country recently, most of which we are also involved. In this, our concentration here is what are the scoring systems used? CDAI, simple endoscopic scoring system. These are Crohn's and these are ulcerative colitis. CDAI and simple endoscopic score, CDAI, Harvard Bradshaw Index. So what these clinical trials have used, these scoring systems. What you are supposed to use, again, the same scoring systems. In ulcerative colitis, partial Mayo score, full Mayo score, remove this and, it's typed wrongly. Full Mayo score, full Mayo score. Here, tacrolimus enema, the people have told it as DAI, but it's nothing but the full Mayo score. So what is practically followed worldwide is these simple scoring systems, and now we have a very simplified way of doing these things. So as a student and as a consultant, I used to feel very difficult. I used to feel the difficulty of doing these scoring systems, and as the first statement states, most clinicians do not use any scoring system, either clinical or endoscopic. Till recently, we are also doing like that. I feel, I mean, these apps are very useful, and especially when I started doing the clinical trials, we started these scoring systems, but our either the nurse or the IBD nurse, or we have some assistants, they are not exactly the nurses, but who are slightly intelligent, they can do these scoring systems for us. And of course, we also have been doing this, but now those people help us in the clinical trials. But in OPD, we haven't been doing this. And recently, again, we have started these scoring systems even in the OPD by teaching our nurse colleagues and the others who help us. Scoring systems have become a must in clinical trials. You can't escape. And it would be ideal to use these scoring systems in day-to-day practice, and it may improve a level of communication. As manual calculations are difficult, it's always better to depend on apps. And IG-IBD calculator is good, simple to use. for clinical and endoscopic scoring systems. Trained nurse or a non-medical assistance also is enough. Overall, scoring systems provide an objective approach to this dynamic disease. I think that is the last slide. I finished. Thanks so much. Thank you.
Thank you, Dr. Ravishankar. We do have a couple of more SAIA management joining, Dr. Deepak Parakkal from USA. Welcome, Dr. Deepak. And we have Dr. Akash Chaudhary and Dr. Sai Krishna is not here, I think, as a moderator for discussion. Any questions or comment, Dr. Akash?
Good evening, everybody, sir. It was a beautiful presentation. As you said, that all the apps are available online these days. And I think as a student, till you are doing your PG and you have to pass your exams, you should be knowing more scoring systems. But I think once you come into clinical practice, Mayo score appears to be pretty simple and good. Yes. So that is what exactly we do.
Yes, sir. What was found to be very complex has become simple. CD activity index, in fact, as a student, we used to struggle to do the scoring systems. Maybe you had some easier way, but now we have the apps.
Good, Ravi. We have been doing, when we were students and when we became early consultants, so many scores and all these things were not there. But one very good score was there, clinical score, that is true left criteria. And still we follow that criteria in the OP basis, in the OPD, because it's very easy to calculate their true left criteria, and you can decide whether the patient is mild, moderate, or severe. You don't do endoscopy regularly. First time when you do endoscopy, I think the Mayo score is much more used by most of the people. But if you are following up with endoscopy, Mayo you can compare. Many times the repeated endoscopies are not required in clinical practice unless it is a part of some drug trial, like a lot of biologics are coming, and we have done some studies where we do all these scorings, whatever they suggest. Most of the time these drug trials also use, in Crohn's, CDI score is still being used. Though it is very difficult, and sometimes we used to do that because there was no other score for Crohn's disease. We have seen an error where there was no existence of Crohn's disease in our country. We never saw Crohn's disease when we were a student and even in the early consultancy phase.
They will not believe it.
Yes, people will not believe. But we have seen the whole, how the things moved from non-existent and now it is looking more common than the UC. So
and
we are
Dr.
seeing
Ajit
more.
Is not an old man.
No, but I am a quite senior man. It is this thing. But see, I am talking of early 90s when I started my early consultancy. So that time the Crohn's was non-existent. We were taught that never diagnose Crohn's. Even our pathologists, sorry to say, they will always report even if there is a suspicion it's a tuberculosis. And we used to treat them like tuberculosis. They improve. But probably there was no existence. And because of the development in the hygiene, the standard of living, everything has improved. And that is why we are paying this. This is a part and parcel of the improvement in the hygiene and general condition and the richness of the people, affluency. And that is why what the people in the US were seeing that time, now we have started seeing those things. So I think it is bound to come. But definitely we are seeing now a lot. So scoring systems are good as far as when you are doing endoscopy and all that. But clinical scoring, I think, is still one should do. That gives you an idea whether the patient has any relapse, which is still mild disease, or it's a severe disease. And then accordingly you can manage.
Yeah, especially I particularly left the true loves criteria for this comment only. And I think it is followed clinically by students, by all of us clinically, sometimes, most of the times in practice. But in none of these recent trials, true love criteria is being followed. So I just kept it away so that in the future, maybe that is the future.
Dr. Ramesh Kumar, sir, as a chairperson, any comments from you on the talk?
Excellent talk, Dr. Ravi. As usual, see, the point of interest of late is many of the patients who are initially diagnosed to have intestinal tuberculosis, after 3 to 4 months, initially there's a very good response. And they are very young patients, and initially they very good response. And over the time, after 3 to 4 months, suddenly the symptoms, everything will increase, and then again we'll forced to do the colonoscopy, we'll take biopsy, again it turned out to be Crohn's disease. The one more observation which I personally made was the persons who are coming from the affluent countries. Initially they were in India, going to settle in US, Australia, New Zealand, so many other countries. When they are coming with, again, diarrhea, they are found to have Crohn's disease. Initially, they don't have after that. These are the 3 points which I would like to mention. And the differentiating between tuberculosis versus Crohn's, I think we can have some more work. I think what Kiran, of course, differences are there, but still you are not definite that this is definitely it's a Crohn's disease, this is definitely a tuberculosis. So in which area I would like to improve, either histologically or... No, we have been to so much of... See, when we went to Athens, in I think 10 years back, we went, the molecular anatomy was discussed excellently. I think it was Athens, so IBD. What is IBD failing? IBD 9.
Peddi is asking to come tomorrow for a detailed discussion.
So, no, my personal intention is to have some more developments in the diagnosis of Crohn's disease.
Yeah, we have this difficulty.
Yeah.
We have this difficulty in India especially. We have to overcome somehow by our own methods. Other big problem is the latent TB in India. We want to start any biological and do the quantiferon gold, it is positive, and then we have a lot of problem because we cannot start any of these biologics.
We have Dr. Professor Masudur Rahman from Sheikh Russell Hospital from Bangladesh, Dhaka. Dr. Masudur Rahman, do you have any comments to make as a chairperson? He's online actually. Yeah, yes, oh yeah. Yes, Dr. Rahman, you're unmuted now.
Hello?
We can hear you, Dr. Rahman, please tell.
Can you hear me, please?
Yes, yes.
Good evening. Thank you. Thanks to the organizers for inviting me to chair the session. It was a good presentations. I'm sorry that I cannot hear well the discussions because the sound quality was not so great. So in fact, I did not follow the discussion. So what I feel here in Bangladesh also, the clinical applicability of the various scoring systems is very limited. In fact, outside the clinical trial, the scoring system has very limited, or in practice, no use. In fact, but the monthly classification, which is not in fact a scoring system, rather than a sort of the subcategorizing of the disease, particularly Crohn's disease and ulcerative colitis, and this is useful. And some of the centers, in fact, uses the Montil classifications here in Bangladesh. That I think that this is useful. Otherwise, outside the clinical trial, the various scoring systems has very limited clinical use. Thank you.
Thank you, Dr. Rahman. So, any other questions to Dr. Ravishankar?
Sorry, I cannot hear you.
No, I said thank you. Thank you, Dr. Rahman.
Thank you. You're welcome.
So if no questions, we will let Dr. Ravishankar sir rush away for his next talk.
I'm sorry.
No problem. Okay, thank you, sir. No problem. Thank you. Thank you. Thank you, Dr. Ravishankar. So for the next topic is histology in IBD. We commonly come across the histopathological report. We quite often get confused what to do with it, and we can't understand sometimes, and we get pathologists to comment on it or help us with that. So we got a topic, histology in IBD, pathology and GI cross talk. Speaker for this is Dr. Bulakshmi, consultant pathologist at Yashoda Somajiguda. To chair this session, I request Dr. Anuradha from AAG Hospital, head of the Department of Pathology, to take the front seat. And along with her, we have Dr. Ajit Kumar sir, who is senior consultant at KIMS Hospital, Secunderabad. Dr. Bhulakshmi, please. Sir. Sir. Sir, colonoscopy చేసాం కదా సార్ అవన్నీ కదా నార్మల్ ఉంది సార్ colonoscopy అది నార్మల్ ఉంది colonoscopy.
Pathology in IBD. So, inflammatory bowel disease is nothing but it's a group of chronic idiopathic inflammatory conditions. To start with, there are two major types, ulcerative colitis, which involves the colon, and the Crohn's disease, which involves the whole of GIT. But most commonly, it is involving the terminal ileum and the colon. There are other two groups which are also described, which is called as indeterminate colitis and inflammatory bowel disease unclassified. Now, indeterminate colitis has to be reserved only for the surgical resection specimens and not in biopsy cases. Whereas in biopsy, if the features are features are not distinguishable, then the term used is inflammatory bowel disease unclassifiable. So, what is the role of pathologist in IBD? First is to diagnose, confirm the diagnosis of IBD, distinguish whether it is UC or Crohn's, to determine the extent and severity of IBD, rule out possibility of other types of colitis, assess the histologic response to the treatment, diagnose any complications of the treatment like CMV, identify the long-term disease sequelae like dysplasia or malignancy. So the adequate tissue sampling is essential for the accurate diagnosis and the prognostication. But there are certain limitations in histopathological evaluation, especially when there are overlapping features of UC or Crohn's, when there is fulminant phase of the disease, when we are getting limited specimens from the endoscopic biopsies. Also, if the patient is already on treatment, then the treatment-related changes also have limitations in giving us the proper diagnosis. So for a final diagnosis, the clinical features, endoscopic findings, radiology, and pathological findings play an important role. As you all are aware about the diagnosis of IBD, I just want to emphasize what are the lab parameters which are important in IBD. So CRP and ESR are both elevated in ulcerative colitis. With the treatment, these values get stabilized. But on treatment, if the values are rising, then we can predict that the patient is going in relapse. The other two serological parameters like P-ANCA and ASCA can also be used. In isolation, this test does not carry much importance, but if they are combined together, and especially in cases of an indeterminate colitis, we can utilize the results to identify whether the case will progress to UC or it will progress to Crohn's. Why? Because the P-ANCA will be positive predominantly in the ulcerative colitis, whereas ASCA will be positive mostly in Crohn's disease. Fecal calprotectin is also used. This is a non-invasive test to diagnose and monitor the intestinal inflammation. It is very sensitive in distinguishing IBD from the non-IBD colitis, but we cannot differentiate whether this is ulcerative colitis or Crohn's. So sampling of new diagnosis, sampling for a new diagnosis of IBD. What are the recommendations? We need actually the 2 biopsy fragments from all the segments of the colon, which includes the rectum as well as the terminal ileum. And these biopsies should be done irrespective of whatever the colonoscopic findings are there. Now, if the clinician is having a clinical diagnosis suspicious for Crohn's, the additional biopsies from the esophagus, stomach, and duodenum are recommended, especially for the children, because in these sites, if we see lymphocytic esophagitis or we see gastritis or granulomas, then it will support the diagnosis for Crohn's, even though if you are not having classical features of Crohn's in the colonic biopsies. Now, if the biopsy features are normal when they are taken within 2 weeks of the symptoms, then re-evaluation is suggested because the histological features, they take 4 weeks to manifest in the mucosal biopsy. Now, sampling in a known case of IBD. colonoscope, there is very limited data available, like how many samples we have to be taken. So as colonoscopic is already done to assess the treatment response and surveillance, whatever the sites are clinically relevant or endoscopic interest can be biopsied, along with previously inflamed areas can be taken. Sampling of IBD associated neoplasia with the advancement in the endoscopic, these lesions can be targeted and a target biopsy can be taken. But where such facilities are not available, the 4-quadrant biopsies of every 10 centimeter colon with targeted lesion sampling can be done. We can have pouch specimens also. So if there is a pouch that is ilioanal anastomosis pouch, then the 2 biopsies, each one from pre-pouch ileum and the other from the rectal cuff is recommended if no lesions are seen. And if the lesions are identified on the endoscopy, then the target lesions or the target biopsies can be taken from the lesion, from the edge of the erosion, or from the ulcer. Now, after taking all these biopsies, the pathologist when we are sending the samples to the lab, it is recommended that these biopsies have to be taken separately in different containers labeled with the sites. So each container has to be labeled specific to the site and then taken into 10% buffered neutral formalin and transported to the lab with a detailed clinical request form. So what are the clinical findings which a pathologist require? That is endoscopic findings. In the endoscopic findings, we would like to know whether it is a continuous lesion or it's a segmental distribution, whether there is any mass lesion, there is presence of polyp or any diverticuli, what are the clinical symptoms the patient is presenting with and the duration, the age of the patient, the family history, whether there is any history of UC or an IBD or a history of colorectal carcinoma, whether the patient is having any perianal disease, any presentations of extraintestinal manifestation. A drug history can also be given because certain drugs like NSAIDs can cause IBD-like colitis, and other lab details like stool test, the serological parameters, and the PCR for CMV. If upper GI scopy are available, especially in children, that can be also shared with the pathologist. In the clinical findings in the cases, in the follow-up cases of IBD, we would be needing the recurrence of the symptoms. What was the previous IBD called as? What treatment is given? What are the endoscopic findings with respect to response to treatment? Are there any complications like stricture, diverticuli, or polyp? Or whether this biopsy is taken as a surveillance for dysplasia. So when it comes to reporting of colorectal biopsies, we report first whether the biopsy is adequate. Then we look at the disease distribution and the uniformity. Now, ulcerative colitis is known to have a continuous and uniform distribution. When I say it is continuous and uniform distribution, all the fragments which are there inside the biopsy slide or the section will show inflammation. And in Crohn's disease, we'll have discontinuous or non-uniform active inflammation. There can be abnormalities in the lumen, like presence of pseudomembrane in pseudomembrane colitis, which can complicate the IBD, or presence of necrotic pseudomembrane in ischemic colitis. Certain parasites like amoebiasis can also induce IBD-like features, and crystalline materials like KX-late, etc. can be associated with colitis, but these crystalline materials cannot be seen if it is an IBD. Also, we have to see whether there is an abnormality in the luminal surface. With this, I mean what is the contour of the surface epithelium, whether it is undulating, whether there is villiform surface, is the surface epithelium showing any ulceration, or there is presence of any erosion. Now, the earliest and the most important feature which is seen in an IBD is presence of basal plasmacytosis, followed by increased lymphocytes and lymphoid aggregates. Apart from this, we also look at the crypt architecture. The crypt architecture is usually distorted, and this is most common in the ulcerative colitis. Now, what do I mean by crypt architecture distortion? We would be seeing crypt branching, or we will see crypt atrophy in these cases. The lining of the epithelium also changes in the IBD, like there will be depletion of the mucin in ulcerative colitis, or we can have metaplasias, like pyloric metaplasia is common in Crohn's. Panizal metaplasia is common in left side colon and rectum in ulcerative colitis. The other findings which are important for us in helping or going towards the diagnosis of ulcerative or Crohn's is muscularis mucosae thickening, which is seen in ulcerative colitis, presence of fibrosis in Crohn's, presence of subepithelial collagen. Pseudopolyps can be seen in both the conditions. We can do certain special stains, especially if there are granulomas, to differentiate whether it is a tuberculous granuloma or it is a Crohn's granuloma. And all the cases where there is severe colitis, which are refractory to immunosuppressive therapy, or patient is having severe active colitis, the recommendation is that all these biopsies have to be subjected for IHC for CMV, because the CMV is more pronounced in these cases. So unless CMV is treated, the inflammation doesn't resolve. So reporting of ileal biopsies is also done similar to that of colorectal biopsies. So to summarize the elements, what we include in the histopathology report of colitis includes the distribution of the disease, the architecture of the crypt, the type of inflammation, whether it is active, inactive, acute, chronic, granulomatous, what is the pattern of inflammation, whether it is uniform, involved or heterogeneous, the severity of the active inflammation, the complications which are present, especially the CMV inclusions, dysplasia or malignancy, other features, and finally interpretation is given. Now, reporting of the biopsies from the initial diagnostic series. When a biopsy comes onto our slide, or when we are seeing the slide, the first question what we ask is there chronic colitis or ileitis? Does this pattern represent a IBD or a mimic of IBD? So these can be addressed with a detailed clinical history what is provided to us by our clinicians. And are there sufficient features to distinguish whether this inflammation is towards the ulcerative colitis or it is a Crohn's disease? So for this, the adequate samplings and sending the samples in separate containers will help us, because depending upon the site and the predominance of the inflammation, we can narrow down the diagnosis whether it is going towards the, whether it is an UC or whether it is a Crohn's disease. And any superadded infections like CMV or neoplasia. So in the histopathological diagnostic criteria, we tend to use these terms. When I say it is consistent with UC or CD, it means that clinically, endoscopically, and histopathologically, it is either an ulcerative colitis or it is Crohn's disease. When we say it is compatible with UC or CD, that means the clinical features and the histopathological features are of either UC or Crohn's disease. When the clinical, endoscopic, and histopathological features are not sufficient enough to differentiate whether it is UC or CD, we use the term IBD unclassifiable. We also use whether it is possible or probable IBD if only histopathological features are there and we are not having the clinical details and the endoscopic findings. Either they are negative or they are inadequate or not available at the time of reporting. If there are no features of chronicity in the given biopsy, IBD is unlikely, but repeat biopsy can be done if the clinician feels that patient is having symptoms and the endoscopic findings are persisting and they are like IBD. Indeterminate colitis nowadays is not at all used for biopsies. They are reserved only for the resection specimens. So to summarize, this table tells us the differences between the microscopic features of ulcerative colitis and Crohn's. In short, ulcerative colitis is a continuous, uniform involvement of all the mucosal fragments. There is marked inflammation. The inflammation is predominantly in the transmucosa. I mean, transmucosa means it's limited up to the mucosal mucosa. So we have marked cryptitis, crypt abscesses, along with Paneth cell metaplasia. When it comes to, we can have granulomas even in Crohn's, but the granulomas which are present, the granulomas which are present in the ulcerative colitis are usually cryptolytic granulomas. That means they are present close to the crypts and not away from the crypts. Whereas in the Crohn's, it's a transmural inflammation. The inflammation or the intensity of the inflammation is little less as compared to the UC. The cryptitis and crypt abscesses are less. We can see discrete granulomas. These granulomas are present away from the crypt and inside the lamina propria, and pyloric gland metaplasia is more common in Crohn's disease. So a few photographs for showing the histological features of UC. In this we can see that there is crypt branching. This crypt is showing branching here. I can see two lobes like this. This is a muscularis mucosae hypertrophy which can be seen in UC. This is a crypt, and there are a lot of inflammatory cells here at the base of the crypt, and these all inflammatory cells, if they are plasma cells, it is called as basal plasmacytosis. Here we can see there is a crypt, and there are polymorphs which are going inside the crypts, which is called as cryptitis. And this is a crypt. In the lumen, we are seeing lot of neutrophils. This is called as crypt abscesses. So these would be the features of ulcerative colitis. Now coming to Crohn's disease, in Crohn's disease I said it is a discontinuous inflammation. Now what do I mean by discontinuous is, if you see all these crypts are looking normal and the inflammation is seen only in one crypt. So that means only few crypts are showing inflammation and rest of the mucosa is not showing any inflammation. So this is a discontinuous inflammation. We can have fissures, we can have ulcers. Now this granuloma is seen in between these two crypts. So this is away from the crypt. These are seen especially in Crohn's. We can have pyloric metaplasia in the chronic ileitis. When we are reporting the biopsies in a follow-up cases of IBD, we use the terms persistent active disease, inactive disease, quiescent disease, or healed disease. So these are the figures which show, here we can see that there is absolutely, first of all, there is no inflammation or minimal inflammation, and the crypts are little dilated. We can see little features of chronicity. So this is a quiescent phase of IBD. Here we can see that the crypts are there. There is little cryptitis, but I'm not seeing any crypt abscesses. So this is mild chronic active colitis. In this figure, we can see multiple crypts with crypt abscesses and cryptitis. So this will be moderate chronic active colitis. And in this figure, we can see many crypt abscesses along with surface ulceration or erosions, which is nothing but it is a severe active colitis. So ileal pouch anal anastomosis is usually done for UC. So the histological features what we see in this pouch would be the chronic inflammation like villus blunting, mucosal chronic inflammation is seen, and we can have pyloric gland metaplasia. There can be active inflammation. So if there is active inflammation, we need to tell what kind of inflammation it is and what is the grade of the severity of the inflammation. Additional features can also be documented like intraepithelial lymphocytes, presence of subepithelial collagen, hyalinization of the lamina propria, and presence of granulomas. Now when we see granulomas in the pouch, it indicates that either there is crypt rupture, or it could be because of the previous surgery, or it could be that the pouch is developing Crohn's disease. There can be complications in the pouch like the UC, especially the CMV or presence of pseudomembranes. We can have dysplasia and neoplasias in the pouch. So the pathological terms what we use in pouch is active pouch inflammation, which is consistent with pouchitis. This means clinically, endoscopically, and histopathologically it is a pouchitis. When we use active inflammation, possibly represent pouchitis, clinical correlation is necessary. Here, the histological features are of pouchitis, but clinical and endoscopic features are not correlating. If there is inflammation of the rectal mucosa, we call it as cophitis. This is nothing but there is residual active UC. Steroid refractory cophitis, they usually represent the Crohn's disease, development of a Crohn's disease, or the IBD, or it can be a surgical complication. So in all these cases, the clinical details, they play an important role for diagnosis. Now coming to reporting of dysplasia in IBD. Previously the dysplasias were called as adenoma-like mass or dysplasia-associated lesion or mass, that is DAL. But now with the current advancement in the endoscopic and having uniformity in reporting of the dysplasias, they are now divided into visible lesions and invisible lesions. In visible lesions, we can have polypoidal lesions or non-polypoidal lesions. Polypoidal lesion is something which is protruding inside the lumen and the size is more than 2.5 centimeters. And if it is a polypoidal lesion, whether it is endoscopically resectable or it is not resectable. Coming to non-polypoidal lesions, these are the lesions which are less than 2.5 mm in size. So they can be either superficially elevated lesions, flat lesions, or depressed lesions. So as there is increased risk of neoplasia in IBD, the surveillance with colonoscopic and the endoscopic sampling is recommended. Now what would be the frequency for the surveillance? It could be 6 to 8 years after the initial symptoms, or if the patient is high risk, especially if there is primary sclerosing cholangitis or there is a family history of colorectal carcinoma, the interval can be reduced to 1 to 2 years. So all the resectable lesions along with the surrounding mucosa has to be sampled if we are suspecting a dysplasia in the IBD. So in our pathology report, we identify what kind of dysplasia it is, what is the severity of the dysplasia. We do comment on the resection of the lesion by looking at the lateral as well as the deep margins, which we can see on the slide, and also comments on the non-colitis segment, which can be reported as a sporadic adenoma if it is there. Now, how do we grade dysplasia? We grade dysplasia as either negative for dysplasia, that means there is no dysplasia seen. When we are saying it is an indefinite for dysplasia, that means the histological features are not enough to distinguish whether it's a regenerative epithelium or it is a low-grade dysplasia. Now, the reason for this could be either there is a lot of inflammation or technical reasons like inadequate sampling or poor orientation of the biopsy what we are receiving it. And the third category would be positive for dysplasia. When we say positive, we do mention whether it is a low-grade dysplasia or a high-grade dysplasia. Now, surgical specimens are also, the resected specimens are also received in IBD. For sampling and the reporting of these specimens, we divide the excisions into non-neoplastic excisions and neoplastic excisions. When we come to non-neoplastic excisions, these are done either to confirm the diagnosis of IBD or treat the fulminant colitis of unknown etiology. Or it could be the management of the IBD-related complications like treatment refractory cases, strictures, fistulas, or abscesses, or it could be a secondary procedures after surgical excisions. Now, when this resection specimen comes to the lab, we first open the specimen along the anti-mesenteric border and fix the specimen for 12 hours in formalin. Now, the reason for fixation this is subtle mucosal lesions, if they are there, which cannot be seen in the fresh state, can be very well identified in the fixed specimens. After that, then we look at the gross finding. We look at the mucosal changes. We see the ulcers, whether there are any polyps or any specific lesion which is identifiable on the mucosal surface or in the colon. After this, then we take the sections. Now, the sampling is done like one section each is taken from the margins, proximal and the distal, and one section per 10 centimeter is taken from proximal to the distal colon. Then, if there is any fistula or stricture, that are sampled along with appendix and lymph nodes. When we are taking one section per 10 centimeter of the colon, it includes the normal mucosa along with any suspicious areas, the transition of the lesional as well as the normal mucosa, so that it helps us how the it helps in the interpretation of the inflammatory process. Now, in neoplastic excisions, we can have three scenarios. One is a macroscopically discrete lesion. If it is seen, it is sampled like a sporadic carcinoma. In sporadic carcinomas, we take margin from each section. We take one section per centimeter of the lesion if it is an invasive tumor. If it is a non-invasive tumor, then we submit the entire lesion. Then the reason for submitting the entire lesion is like probably there could be some invasive focus in that lesion. One section per centimeter of the background mucosa, the appendix and the lymph nodes. Now, if the lesion is macroscopically ill-defined, then the sampling depends upon the size of the lesion. Again, the margins are taken, and if the lesion is less than 3 centimeters, we submit the entire lesion. If the lesion is more than 3 centimeters, we take 2 sections per centimeter, and then 1 section per 10 centimeter of the background mucosa, appendix, and all lymph nodes. If the lesion is not macroscopically visible, but the approximate location is known by the endoscopic finding, then the area of endoscopic interest is extensively sampled. Now, in the surveillance biopsy, if there is dysplasia detected in a non-targeted biopsy, then that specimen needs an extensive sampling. So, on an average, the sections should be more than 10. So, these are the gross photographs of specimens which we get for ulcerative colitis. Here we can see that there is a sharp transition between the inflamed. This red is the inflamed mucosa. This is the normal mucosa. We can have superficial ulcers. The polypoidal lesions which are seen like elevated bulges, these are inflammatory polyps, and in between the flat mucosa which is nothing but atrophic mucosa. Here also we can see atrophic mucosa. Now, in the Crohn's we can see skip lesions. These folds are the normal mucosal folds. This is an ulcer here. Again, these are normal mucosal folds. So, these are the skip lesions. Then we have aphthous ulcers. We have deep serpiginous linear ulcers in the Crohn's which goes up to the muscularis propria. We can also have fat wrapping in these cases. So, these specimens are reported with respect to what is the type and depth of inflammation in the wall, what is the pattern and depth of the ulceration, whether it is deep fissuring, whether it is superficial or broad ulcers, any mesenchymal changes seen like fibrosis, neuronal hyperplasia, vessel wall thickening, are we seeing any granulomas, whether these granulomas are inside the wall or they are present inside the lymph node, whether there is presence of mesenteric vasculitis, and what are the status of the margins. If there is inflammation at the margin, again, then we can predict that the disease can recur in the patient. Now, in indeterminate colitis, if you are not seeing any granulomas throughout the specimen, but a lymph node is showing presence of granulomas, we can narrow down our diagnosis favoring that it is IBD favoring Crohn's disease. If we are seeing basal lymphoid follicles, then it favors divergent colitis. So finally, if there is a polypoidal lesion which is seen on endoscopy and the surrounding mucosa is resected, if there is dysplasia in the surrounding mucosa, the proctocolectomy is approached, and if there is no dysplasia, the patient can be kept under close follow-up. If there is invisible dysplasia, then it has to be the patient has to undergo proctocolectomy, and in the non-inflamed mucosa, if we can see a sporadic adenoma, then depends upon the endoscopic resection and close follow-up. So finally, with the good clinical rapport between the clinician as well as the pathologist, we can arrive at a definite diagnosis of IBD.
Thank you, Dr. Bulakshmi. That was a wonderful talk. While we are getting ready for the next talk, a few comments from Dr. Anuradha as the chairperson for the moderator for this session.
So that was an excellent presentation, Bulakshmi. And as you rightly said, if we have complete clinical details, it solves half the problem. Yes, so details in the sense, if we have the endoscopic scoring, it also helps us to come to a definitive conclusion. And at the foremost, it is better that we get all the segments separately labeled. And if you have a protocol of what all you have to see from the mucosal changes to lamina propria, to the muscularis, and to take a look at the granulomas and other things, I'm sure we can come to a definitive conclusion. And as Dr. Ravi Shankar said, we are not lucky to have, what should I say, the scoring systems. It all depends on what the pathologist has to see and score herself and then come to a conclusion. That is one major thing. And the other thing is the most common DD between Crohn's and TB.
Yes, ma'am.
So what is your experience?
Ma'am, like if we see the classical features of tuberculosis, the case-eating granulomas and all, and it is seen in the submucosa, and it's the first case, then we give a provision saying that it could be TB. And again, there are overlapping features. And if I see a transmural inflammation, then along with basal plasmacytosis, we would go more in favor of a Crohn's disease, and also attempt a Zedenstein in these biopsies. But if something is called as TB and then the symptoms are not subsiding, then again we look at the slides, and on repeat biopsy, we might again say that this could be, favoring a Crohn's disease.
Yeah. So I think that is one common problem which we have because of the endemicity of COX in our place. But then if we have a proper history of the duration, the symptoms, the site involved, and we look at certain features of the placement of the granulomas, like submucosal granulomas and disproportionate submucosal inflammation would favor COX more than Crohn's, and microgranulomas and patchy involvement within the biopsy bit submitted would also favor more of Crohn's. In fact, we did a study at AIG where we did an antibody CD79A, and we tried to see in which granulomas would express this antibody more, and we found that Crohn's expressed this marker much more than COX. But that's more on a research side. But on a practical note, probably if we pay attention to the microscopic findings on the mild architectural changes and location of granulomas and the inflammatory infiltrate, like even the presence of eosinophils would, so if you see that eosinophils are more, that also would favor possibility of Crohn's over COX. So that's what we have seen.
Rather than Crohn's and UC, the diagnostic challenges between whether it's TB or Crohn's.
Yeah.
So, and if detailed clinical history is not available, then it becomes very difficult for us to narrow down like what to favor. And secondly, getting all the biopsies in one container is also not recommended, because if we have different site labeled biopsies, then we can at least look how the lesions or how the inflammation is there in rest of the biopsies, and then favor whether it is what it is, whether it is TB or UC or it is Crohn's.
Yeah, it should not be like if we get, I think it should be mandatory that the clinicians should give us separately.
I just wanted to ask you, like, how is your experience at AIG getting these biopsies? Do you get it in one container or like in multiple?
Multiple separate containers. Yeah.
No, I don't think any gastroenterologist must be sending these samples in one container. There's no point sending. When you are taking the biopsies from so many places, starting from cecum or terminal ileum, and then at least 5 segment biopsies we always take. So there is no point sending, because one of the ideas is to know even the normal mucosa is also involved or not.
Yes.
Well, nice talk, madam. I just want 1 or 2 points which is important, I feel. One of the problems we face is the acute presentation. A patient comes to you first time with the bleeding, the diarrhea, bloody diarrhea, And in that situation, many times the pathologists are not very helpful in making a diagnosis. The diagnosis, if it is UC, the treatment changes. And sometimes it may be fulminant colitis, and if you just keep on treating like infectious colitis or something, you may lose time, which is very important to manage these patients. So any comments on that, I would like to know, whether in acute ulcerative colitis, what are the features? Does it help in giving a definite diagnosis?
Sir, again, there is overlapping, sir, in this. So pinpointing it like being ulcerative colitis is little difficult. But still, if we are seeing some amount of basal plasmacytosis, I think we can favor ulcerative colitis over.
Even that also
along
takes
with
2 to 4 weeks.
eosinophils and
Yeah.
the rest of the inflammatory infiltrate. And secondly, looking at the multiple site biopsies, also we can narrow down the diagnosis.
But many times we will do only sigmoidoscopy because the severe presentation we may not do full colonoscopy. So we just go and take biopsies, maximum sigmoid and rectum, maybe 2. And with that only you have to give us a diagnosis. So that is one.
So the most important differential in the acute colitis is between acute infectious and early IBD. So one point is even in the early stages of UC, the first point which we see is architectural changes, and there is basal plasmacytosis, which is definitely a clue over the infectious colitis. And the second point is the diffuse involvement. Infectious colitis is usually patchy, more of neutrophilic. These are mostly lymphoplasmacytic with architectural changes. But even then, sometimes there can be so much overlap that we can only give a diagnosis of acute infectious versus early IBD. But if the duration is more than 7 days, it's definitely histological changes of UC are seen.
The second thing is, what is the role of doing upper GI endoscopy, taking biopsies where you are suspecting Crohn's disease, even in an adult patient? Because there is some reports which suggest that the duodenal biopsy, the antral biopsy, biopsy from incisura angularis, particularly it is sometimes helpful in making a diagnosis of Crohn's. So what is your comment? Do we need to take in all the patients?
Yes, sir, because that will show the distribution of the inflammation, and the presence of granulomas in these areas can also help that this can be Crohn's disease.
So even in those patients who have limited disease to the, say, ileocecal region or ileal or a colonic disease, there also should we do routinely the biopsies from the stomach?
Can I add here?
Yeah.
So I think this is particularly useful in pediatric IBDs. So in pediatric IBDs, though endoscopically you do not have much changes, there is microscopic evidence of disease in the esophagus, stomach and duodenum. In fact, as subtle as having a focal active gastritis and focal duodenitis with villus changes and presence of microgranulomas have been detected in many pediatric cases when compared to adult IBDs. Even in adult IBDs, when you have this doubt between UC and Crohn's, there are subtle changes in the gastric and duodenal areas. So the pathologist has to look for that focal changes, which is a very important parameter to diagnose.
So even in adults also it is useful. Yes. If there is a doubt whether it's Crohn's or UC. Yes. So there sometimes it may help. Yes. Because there may be some granuloma, microgranulomas, and if you see those in the stomach, then it goes more in favor of Crohn's.
So that helps us in calling Crohn's rather than...
Right, thank you.
Yes.
Thank you, sir. In the interest of time, we'll move on, I think. There are some comments that panelist comments are not audible for people on Zoom. For those, you also have a YouTube link which is circulated, the registration page, the web page and all. It will be audible on that actually. The next topic is radiology in IBD, very, very important topic. For this, we have...
I'd like to thank the organizers for inviting me to this prestigious...
For this, we are privileged to have Professor Raju Sharma, from Department of Radiology and Radiodiagnosis Intervention Radiology from All India Institute of Medical Sciences. He'll be joining live for Q&A. We are playing a recorded talk of his, and then he'll be joining live after 15 minutes of his talk. Thank you.
Good evening, all of you. I'd like to begin by thanking the organizers for inviting me to this prestigious IBD Update 2022. What I hope to do over the next 15 minutes or so is talk to you about the role of imaging.
Dr. Vijay Bhaskar, head of the department and founder of Vista Diagnostics. We also have Dr. D.V. Srinivas, one of the senior most gastroenterologists in Hyderabad. Please.
In inflammatory bowel disease. Just allow me to share my screen. There's been a paradigm shift in the way that we image inflammatory bowel disease, especially that involving the small bowel. We have changed from doing barium meal follow-throughs earlier to now doing cross-sectional enterography, whether it's CT or MR enterography, and we'll see examples of how these modalities can help us in this clinical context. We know that Crohn's disease is a granulomatous disorder which is characterized by transmural inflammation, and the imaging hallmarks basically translate these pathological findings. The disease is characterized by discontinuous long segment involvement with skip lesions, and there's asymmetric inflammation which preferentially occurs along the mesenteric border of the gut. There is mural thickening, and in the active stage, there is enhancement of the bowel wall. There are mesenteric changes, and we'll see that with examples. Remember that there can be a disconnect between biological inflammation and the signs and symptoms. We've seen penetrating and stricturing complications even in asymptomatic patients. Enterography is important as 50% of patients with small bowel Crohn's may have active inflammation when the endoscopy is normal. So the role of imaging in this context is to diagnose the presence of ulceroconstrictive disease, to try and predict the etiology, whether it's Crohn's, tuberculosis, ischemic or vasculitic, comment on the site and the length of involvement, talk of disease activity, detect strictures, identify whether they're inflammatory or fibrotic because the management is different, identify complications like bowel obstruction, fistula formation, abscesses, perianal disease, and rarely the development of malignancy after long-standing IBD. We can also detect extraintestinal manifestations. There is a role for doing chest CT to detect associated pulmonary tuberculosis, especially in those patients who are going to be treated with biological therapy. There is an emerging role for imaging in assessing the response to therapy because the new paradigm is mucosal healing, which needs to be documented, whether on imaging or on endoscopy. So CT enterography is a technique where we give oral mannitol diluted in water to the patient, give about 15 to 1700 ml, 450 ml every 15 minutes, and then we inject iodinated contrast about 70 to 80 ml at 4 ml per second. Remember that distending the bowel is absolutely critical because collapsed bowel, as is seen in the proximal jejunum here, can mimic disease and bowel wall thickening, whereas distended bowel is what we really want to evaluate for detecting pathology. MR enterography is the ideal technique because it does not involve any radiation. Remember, majority of these patients are young and they need repeated imaging because of the waxing and waning course of the disease. We can classify the disease into the different phenotypes, whether it's active inflammatory form of the disease, stricturing phenotype, or penetrating disease. MR gives us a multi-parametric evaluation, allows us to look at the T2 signal, the contrast enhancement, diffusion, and also can assess motility using some Séné sequences. It is ideal for evaluation of perianal fistulizing disease and can be repeated as often as we like, and therefore is very useful for assessing the response to therapy. We use a combination of multiple sequences. There's the T2 weighted fat suppressed sequence, there's the post-contrast gadolinium enhanced T1 weighted coronal image. So we use multiple sequences to get a wealth of information from this technique of MR enterography. Diffusion provides us some degree of functional information. If we compare CT versus MR enterography, CT has a better spatial resolution, where MR has a better contrast resolution. CT is less prone to motion artifacts, is more easily available, is cheaper, and the exam time is much shorter, and it provides consistent, robust quality. It's easier to interpret, but it uses ionizing radiation. MR angiography has a better contrast resolution, provides multiple paradigms for disease evaluation, better assessment of disease activity. However, it is prone to artifacts, is more time consuming and less easily available. Major advantage, of course, is that it is not associated with the harmful effects of ionizing radiation. So how do we choose between CT and MR angiography? If it is the first time that the patient is being imaged, we are not entirely sure that he is suffering from IBD, we want to rule out other causes of bowel pathology as well, then perhaps CT angiography is the way to go. Also, in patients older than 35 years old, it is easier to choose CT angiography because we are not that worried about radiation. However, in a younger patient, where we know that patient has Crohn's disease and we are assessing the acute exacerbation or the course of the disease, then perhaps MR angiography is the way to go. Also, if we are looking at perianal disease, then MR angiography is really the modality of choice. We have, along with the Indian Society of Gastroenterology, published guidelines for evaluation of the small bowel, and there's a useful paper to look at published in the IJRI and the Indian Journal of Gastroenterology. We are all aware that Crohn's can come in different flavors. You have the non-stricturing, non-penetrating disease, stricturing disease, which is defined by luminal narrowing associated with upstream dilatation, greater than 3 centimeters caliber is taken as significant. Majority of the strictures have overlapping features of inflammation and fibrotic components, but we need to know which is the more dominant component so that the treatment can be decided appropriately. Penetrating disease is said to be present when there are multiple sinuses, fistula formation, or interloop abscesses or perforation. The presence of perianal disease can be added to any of these phenotypes. But this division is obviously more artificial, and it's really a continuum, and many times you'll see a combination of these different phenotypes present in the same patient. Let's now look at some examples. This is the active inflammatory stage of the disease, where you have this hyper enhancement of the wall. You have a trilaminar kind of an appearance because of increased enhancement of the inner layer of the mucosa and edema in the submucosal layer. You can see the prominent vasorecta here, which gives us what is called the comb sign. This is another example on an axial CT showing you the typical stratified appearance of an actively inflamed segment of the bowel. Again, some more examples. Here you have bowel wall thickening, the typical trilaminar appearance of enhancement, upstream dilatation in what looks like an inflammatory stricture in the proximal small bowel. It's associated with mesenteric changes. You can have the comb sign, which are the prominent vasorecta that I alluded to earlier. You can have edema around the bowel wall, fibrofatty proliferation adjacent to the inflamed bowel, which is referred to as creeping fat. Another finding which has been recently emphasized in the literature is the presence of mesenteric vein thrombosis. This is an image that I've taken from the literature showing you thrombosis of the peripheral venous draining tributaries. MR can use multiple paradigms to assess disease activity. The T2 signal, when you get bright signal in the wall, that is suggestive of inflammation, and it's useful because you can do that without giving IV contrast when contrast cannot be given for any reason. On the post-contrast images, you can see similar increased enhancement with mural stratification that we saw on CT earlier. In chronic inflammation, there is some resolution of the bowel wall thickening, and there is mild homogeneous enhancement. Diffusion restriction, which is seen as a bright signal on the heavily weighted, diffusion-weighted images, are suggestive of active disease. There are certain indices that have been devised, but these are more relevant in the research setting and are a little complex for use in day-to-day practice. Let's look at some examples. This is the T2 weighted axial image showing you bright signal in the thickened wall, and these are segments of mucosal hyperenhancement. This is a scan of the perineum showing you multiple complex fistula in the perianal region. Some more examples: T2 bright signal in the thickened wall of the terminal ileum and of the cecum. These are diffusion weighted images. This is at a p-value of 800, where you have this bright signal. This is what we call the ADC map, and the dark signal here corroborates the finding that there is restricted diffusion. Remember that Crohn's tends to involve long segments of the small bowel. Here's a long segment of small bowel involved, which is showing bowel wall thickening with bright signal in the thickened wall, some luminal compromise. These are, again, diffusion-based images showing you the presence of restricted diffusion. Strictures are defined as segments of narrowing with unequivocal upstream dilatation measuring more than 3 centimeters. People have refined the definition of stricture by adding some more criteria: luminal compromise greater than 50%, upstream dilatation more than 3 centimeters, and a wall thickness of greater than 25% of the baseline. Inflammatory strictures are managed medically, whereas fibrotic strictures need either endoscopic dilatation, stricturoplasty, or resection, and therefore this is an important distinction to make. And there are some criteria based on which we can distinguish inflammatory from fibrotic strictures. In inflammatory strictures, you get T2 bright signal in the wall, whereas you get a T2 dark signal from fibrotic strictures. The enhancement tends to be stratified in inflammatory strictures, where it is more homogeneous and delayed in patients with fibrotic strictures. When there are multiple upstream strictures, it really limits the extent to which the downstream stricture causes bowel dilatation because they limit the delivery of enteric contents. Let's look at some examples. This is an active inflammatory stricture with stratified enhancement, prominent vasorecta, upstream dilatation, whereas fibrotic strictures seen in this example show you more homogeneous enhancement, and you don't see that typical stratified appearance. There's also a sequence which we call CineMR, where we can try and evaluate the bowel peristalsis. You can see here there's a segment of ileum which is showing narrowing, and it's not really distending in any of the faces, and therefore this is not a peristaltic wave, but is an actual organic stricture. This is something that is useful and can be done only using MR. Here is another example showing you active inflammatory stricture, showing you the T2 hyperintensity with upstream bowel dilatation, whereas in this patient, you have these pseudosaculations, homogeneous enhancement in a patient who had a fibrotic stricture. This is a patient who had thickened terminal ileum, just proximal to the ileocecal junction. After therapy, this thickening has resolved, and there's now a fibrotic stricture with upstream dilatation. And here again, you can see that there is this organic narrowing in the terminal ileum with upstream dilatation. The penetrating phenotype of the disease, when there is enteroenteric fistula, presents with this kind of a stellate or a star-shaped appearance of bowel loops. Multiple bowel loops radiate to a point suggestive of an enteroenteric fistula, also seen on this CT image. Other manifestations of penetrating phenotype include sinuses, abscesses, pneumoperitoneum, etc. This is the fatty proliferation adjacent to an inflamed loop of bowel. Another example of a stellate kind of an appearance suggestive of an enteroenteric fistula. After long-standing IBD, we know malignancies can develop, and when you start seeing this kind of eccentric mass-like thickening, we have to suggest that this may be a superimposed malignancy over the background of Crohn's disease. Extraintestinal manifestations like sacroiliitis, primary sclerosing cholangitis showing you the beaded appearance of the intrahepatic biliary tree can be easily picked up on MRCP. Crohn's is also a prothrombotic disorder. This is a CT pulmonary angiogram showing you evidence of pulmonary thromboembolism. We know that Crohn's can mimic tuberculosis. Some points of differentiation: the involvement is usually of short segments in ITP, whereas long segments of bowel are involved in Crohn's. The involvement is more symmetric in TB, whereas it's asymmetric with presence of pseudocirculations in Crohn's. Enlarged and necrotic lymph nodes are perhaps the most reliable feature for diagnosing ITB, as necrosis in lymph nodes is not seen in the setting of Crohn's disease. This is a patient of ileocecal tuberculosis. Notice this enhancing thickening on this post-gadolinium MR. This is the necrotic lymph node. The center is not showing enhancement, whereas the periphery is enhancing. The presence of this necrotic lymph node tells you that you're most likely dealing with ileocecal tuberculosis. You can also assess response using MRI. This is a patient with ileocecal involvement, and this is after therapy. All the thickening has resolved. I haven't really talked too much about ulcerative colitis because this is much better evaluated by endoscopy, and it only rarely comes for imaging. Notice this patient who has rectal involvement, this stratified appearance of an inflamed rectum, and there is thickening of the entire colon. There's the descending colon showing you absence of hostrae, no hostration seen in the right colon also. This is a patient with pancolitis in the setting of ulcerative colitis. To conclude, CT and MR angiography are both robust modalities for the evaluation of IBD. Bowel distension is absolutely critical because collapsed bowel can mimic disease. MR enterography offers many advantages, and as it is a multi-paradigm evaluation. Crohn's and ITB have many phenotypic similarities. There are long segment asymmetric involvement of multiple segments with skip lesions favors Crohn's, whereas short segment asymmetric involvement with necrotic lymph node favors tuberculosis.
Thank you, Professor Rajesh Sharma. That's an excellent overview of radiology and IBD. Please be online, sir. Can we take Ashish? Can we take Professor online? I request Dr. Vijayabhaskar to make any comments. Please come onto the podium, sir, because people are not able to hear from there, I think. If you don't mind, make some comments on share your experience.
Thank you very much, sir. Good evening, all. I thank Dr. Kiran Peddi for having me here. After Professor Rajesh Sharma, is Rajesh Sharma there? Are you listening to me, Dr. Rajesh Sharma?
Yes, I can hear you.
Good evening from me, from Hyderabad. How are you?
Good evening. How are you?
I'm fine, doing fine. Thank you, sir. After your excellent talk, there's no comments there here to give anything about the MRI. Only thing is, I would request if someone is interested, there is in Radiographics 2020, there is a very good article on the nomenclature and how radiology reports have to be given in Crohn's disease especially. So that is what we usually follow, and we try to give in that pattern. One typical scenario what we see is, always we get is tuberculosis versus Crohn's. I mean, anywhere, in pathology, radiology, clinical also, that is always the doubt. So, of late, what we are seeing is now we have our confidence levels have increased in reporting Crohn's disease when compared to tuberculosis, like Dr. Rajesh Sharma said about necrotic lymph nodes and other things. But we always have that, that element of doubt in about 20% of cases. We have this doubt of tuberculosis versus Crohn's. So there, I think we cannot give a definitive diagnosis. So that is one which is radiology has kind of a difficulty. Like everyone, like clinical pathology and radiology also. But otherwise, radiology has now a very good role. More so when you send us the patient as a Crohn's disease, our role is now only to show the extent of the disease and complications. So if the patient comes on his own suspected IBD, then that becomes a challenge, what it is. So those are the two scenarios where what you expect from us, we give you once you tell us it's Crohn's disease. But you want us to differentiate between a couple of inflammatory bowel disease, then that becomes a difficult thing. So these are some comments which I make. Thank you, Dr. Rajesh Sharma. If you have any comment to make, Dr. Rajesh Sharma.
Thank you. I agree with you entirely. Most often today we can distinguish between TB and Crohn's, but there are situations where there is overlap and the two diseases mimic each other. And sometimes we land up giving an empirical trial of ATT because we're just not sure whether we're dealing with TB or Crohn's. Agree with you entirely.
Thank you, sir.
Thank you, Dr. Vijayabhaskar. Dr. Devi Srinivas, sir, you want to share your experience in radiology and gastro?
Very nice presentation, sir. As a clinician, we always want to know whether the stricture is an inflammatory stricture or a fibrotic stricture, which you have clarified anyway. And second, we always have the confusion whether to go for MR enterography or CT enterography. When somebody has extraintestinal diseases, I think we prefer like intra-abdominal abscess, retroperitoneal abscess, etc. Surgeons and we tend to prefer CT enterography rather than MR enterography. We need a comment on this from you.
Yeah, I think that's the clinician easier to comprehend CT enterography. MR enterography tends to have a longer learning curve, but it does provide us additional information, and especially in the interest of radiation, we know that these patients require repeated imaging very often. And if the patient comes for the first time and we are not sure whether we are dealing with IBD or not, then we also tend to prefer CT enterography. But once there is an established diagnosis and the patient is not acutely sick, then we tend to prefer MR enterography in the interest of radiation protection, and also because it provides us much greater opportunity to characterize the disease. Thank you.
I would like to add a comment here, Dr. Raju Sharma, regarding MR versus CT. What we often seen is MR is a better modality for diagnosing active inflammation when compared to CT because of its better contrast resolution, what you have shown there. So when we are suspecting active inflammation, especially in acute situation, MR is probably should be the modality of choice, especially if you have to show the intramural edema and then trilaminar enhancement and things like that, which are markers of acute inflammation. CT can be reserved for those cases where we are not very sure about acute inflammation or otherwise. So this is what is one comment I wanted to make.
But for the clinicians, CT images are easily interpreted by clinicians than MR images. For us, we prefer, most often we prefer CTs, but certain situations are there where we go for MR angiography.
One situation where MR definitely scores completely over CT, of course, is perianal fistulizing disease. If you have perianal fistula, there is no controversy at all that MR is the way to go.
All right, thank you.
One quick question from me, Dr. Raju Sharma. What's your experience with intestinal ultrasound? Do we do them regularly or once in a while? Or do you see it's a replacement for CT or MR in the future? Intestinal ultrasound.
No, I don't see it as a replacement, but I see it as a complementary technique. Sometimes we do use it. We don't use it very often. It's good for ileal, distal ileal disease, but ultrasound is not good for jejunal disease. Very difficult to visualize the entire bowel and give you a roadmap of the entire gut. So I don't think intestinal ultrasound is going to replace CT or MR, but it is used as a complementary technique, and it is a useful technique, especially when coupled with the use of ultrasound contrast medium.
Thank you, Dr. Raju Sharma. Dr. Rahman, do you have anything to comment on? Dr. Masood?
Thank you, Professor Raju Sharma. It was an excellent presentation. So very nicely demonstrated that most of the strictures are due to inflammations and the fibrosis, but some components may predominate in individual cases. So this has important therapeutic implications, you know. So my question is that is there any role of response to treatment by CT angiography or MR angiography, particularly small intestinal disease, Crohn's disease, when there are no other reliable indicators like inflammatory markers like fecal calprotectin or lactoferrin not elevated? So what is the role of response to treatment?
I showed a couple of examples where you can document that thickening has resolved and inflammation has resolved. For response assessment, we tend to prefer MR angiography because again, it gives us more information. You know, you're not just relying on contrast enhancement. We can look at the T2 signal of the bowel. Inflamed produces T2 bright signal, whereas fibrotic bowel gives you T2 dark signal. We look at the degree of enhancement. We look at the kind of enhancement. That typical stratified trilaminar enhancement signifies active inflammation, whereas if you have homogeneous enhancement, which tends to occur in the delayed phase, that is more suggestive of fibrotic disease. Yes, there are multiple paradigms by which we can distinguish active inflammation from fibrotic disease, and for this purpose, for assessing response speed, I think most people would prefer MR rather than CT.
Thank you. Thank you, Dr. Raju Sharma. With that, we'll move on to the final session for tonight. That's myself actually. It's a case discussion. I'm aware of we are running very late, so I'll try to be as quick as I can. Ashish, can you close this and move on? Okay, just wanted to discuss one of the complex cases we ever had. for the benefit of, especially for junior doctors and PGs. So this is Mr. GC, about 30 years of age. He had history starting from May 1997. Initially had rectal bleeding and diarrhea. He saw a GP and we were given a course of antibiotics. But because he was in Australia at the time, he had a long waiting list to see a specialist, and especially for colonoscopy. So he decided to return back to India. So his symptoms resolved and he joined a new job as soon as he came back to India. But he had recurrent symptoms from May 1998. His colonoscopy showed left side ulcerative colitis, confirmed on the biopsy. Given a course of steroids and mesocol 1 gram BD, got better. Then repeat colonoscopy in August 98, which showed IC ulcers and ileal ulcers with relatively normal colon. So it was thought whether he had actually Crohn's instead of ulcerative colitis. Patient stopped his medication at the end of 1998. So I include few MCQs here. So is there a clear north-south distinction in incidence? We all know that the incidence varies across the globe. So northern countries in northern hemisphere have higher incidence of IBD compared to southern hemisphere. So that's incidence of IBD across the globe. As you can see, the red areas are higher in incidence compared to lighter colors. So some facts: peak incidence of Crohn's is between 20 to 30 years. Peak incidence of ulcerative colitis is between 30 to 40 years. And pediatric IBD accounts for 70-20% of total IBD. Ulcerative colitis slightly more in males and CD more in females. High incidence in children who were migrated at the age of 15 years, under 15 years of age. So the commonest presentation of ulcerative colitis, again proctitis and proctosigmoiditis, which accounts for almost 50% of the cases compared to other extension. So which is the best time in course of IBD to assess prognostic factors for the best outcomes? We always need to assess patients at the outset. When they present to us for the first time, we need to categorize and do the prognostication, how this patient is going to behave in the next 5, 10, 15 years of age. We should not be delaying the prediction action for many years, because that is what is going to decide our treatment choice. Whether you want to go for step-up treatment or top-down treatment depends on the prognostication for the individual patient. For example, if somebody got extensive colitis, the chance of this patient getting into colectomy, cancer, potential mortality risk is very high. If somebody had a colitis, demonstrated extension of the colitis or extensive manifestations, systemic inflammation, no response to first-line therapy, or no mucosal healing at 1 year, the chance of him getting into colectomy is high. If somebody has sclerosing cholangitis, the cancer risk is high. Non-smoker relapses colectomy, of course, we won't advise patients to smoke. ANCA positivity, there is no response to or poor response to anti-TNF. So these are all the predictive factors. So whenever we see a patient for the first time, depending on these features, we need to extrapolate this journey and foresee all these complications coming up in the future. So which prognostic factors to be used? We can use a combination of clinical, endoscopic, imaging. Genetic is not routinely done. And serological laboratory markers like ASCA positivity has got a poor prognosis in Crohn's disease compared to ASCA negative patients. Fecal calprotectin, high fecal calprotectin can have a poor prognostic as a marker. Should we always ask about extraintestinal manifestations and family history in ulcerative colitis? Is very, very important, because it runs in families, as we all know. So somebody has got family history, the chance of transmitting into offspring is significantly high compared to normal population. So this is a classification. I'm going to skip that. Oh, these are slides. Okay. Okay, don't know what happened there. So if you look at the management of IBD, it just revolves around 4 or 5 options. 5 assays, immunomodulators, biologics, neoreagents, and surgery. So why is it so difficult when you have only 5 choices? It's exactly the point. So you need to know and experience which agent you need to use when, and how to switch from one agent to other. Mesalamines are the ones which have got highest experience and more than 30 years of age, 30 years of use. And adverse events are very small compared to placebo. They act locally and then used in ulcerative colitis, Crohn's, sometimes in IBS, diverticular disease, and for chemoprevention of colorectal cancer. So different 5 assays act differently. For example, the Pentasa, it acts like a timed release, acetol pH dependent, and azo compounds depending on the location. So we know that mesalazine not only acts on a kind of local, it's not a simple topical agent. It's got multiple properties of action. For example, they act like anti-inflammatory agents, immunosuppressive agents, and free radical scavenging agents. There are different trials done on 5-ASAs in the various issues about 5-ASA, like oral 5-ASAs, dose escalation, when to do once a daily dosing or BD, topical 5-ASAs, formulation, and mucosal healing, and so on and so forth. This is a Cochrane collaboration looking at oral 5-ASAs for induction and maintenance of remission in ulcerative colitis. I'll quickly run through. So the summary of this is oral 5-ASAs for induction of remission in UC. There is strong evidence to support the use of oral 5-ASAs for induction of ulcerative colitis. And what dose? If somebody has got mild to moderate ulcerative colitis, you can use 2.4 grams. And somebody got moderate to severe, you can use 4.8 grams. So there is good enough evidence to use 4.8 or 2.4 per day based on whether you require for induction of remission or maintenance. So this is the same slide again in words. What about maintenance? Again, there is a good supporting evidence for use of 5-ASAs in maintenance of ulcerative colitis. What about topical 5-ASAs in induction of remission in distal ulcerative colitis? Significantly supported by 38 trials and can be considered as a first-line therapy in mild to moderately active distal ulcerative colitis. What about maintenance of remission? A small number of studies, but is significantly superior to placebo in maintenance of clinical remission. So good evidence for induction of remission for topical 5-ASAs in distal colitis, and some supporting evidence for maintenance of remission. So 5-ASAs are not so much so used in Crohn's disease as we do in ulcerative colitis, but the take home from that is you can use them if somebody has got Crohn's colitis. You can use it as ulcerative colitis. Okay, so coming back to our patient again, he remained well between end of 98 and August 99. And in 99 August, he developed acute abdominal pain. He was admitted and treated as mild pancreatitis, alcohol related. September 99, he had mild abdominal pain again, treated as esophagitis and mild gastritis after endoscopy. His journey continues, end of 99, mild abdominal pain. He started on 500 TID of Misocol. So, can any one of you say or volunteer for this? So what is the importance of compliance for these patients? When do you get significant flare-up? So the answer is if the compliance rates falls below 80%. For example, if somebody is taking Misocol tablet 2 times in a day, he would be taking 14 tablets in a week. So we're talking about 20% dropout. That is, if he misses 3 tablets in a period of 1 week, the chance of this patient getting a flare-up is 6 times. So if you explain that patient, most of the patient would love to take on a regular basis. So it's only missing 3 tablets in a week, but that puts them at a 6 times higher risk of developing flare-up ulcerative colitis. He remained well between May 2000 and 2001 on Misocol. He had further flare and he developed acne, severe arthralgia, so he's consulted ortho and celecoxib and salazoparin was started instead of mesalazine. So he continued to have multiple course of steroids, started on azathioprine, but he developed pancreatitis. As you can see, this gentleman is not a straightforward case. Whatever you do, he gets into some kind of complication. His salazoparin was changed into acecol. He developed further diarrhea, required multiple courses of steroids. He had bone scan which showed bilateral sacroiliitis. He was admitted with right hip pain and MRI shows fracture, fatty change in the head of the femur. He was changed to Remicade. So this is an important slide. If you look at azathioprine, for the benefit of juniors again, azathioprine when you give to these patients, it gets metabolized into 6-MP, and 6-MP again leads to 6-TGN as an active metabolite, which is responsible for therapeutic effects of azathioprine. 6-MMP and 6-MMPR are toxic metabolites, and that can dictate toxicity of these patients. So if somebody has got TPMT deficiency, you get more TGN, so that the pathway will be driven towards the right side. So you'll get more 6-TGN and more therapeutic effect and also more side effects. So this is again very important slide. What do you do with thiopurines? When you start azathioprine for these patients, they get either idiosyncratic, they can get idiosyncratic side effects, which include gastrointestinal disturbance. Some people will come back and say, I'm getting bloating, indigestion, and gastritis type of symptoms with azathioprine, the answer for that would be to change it to 6 MP. Pancreatitis, once the patient develops pancreatitis, we cannot try them on azathioprine anymore, so that's a no-no for thiopurines. Flu-like syndrome, if it is significant, that might contraindicate future use of azathioprine or say even 6 MP. Some people may get cholestatic hepatitis. So cholestatic hepatitis without jaundice, we can get away by reducing the dose of azathioprine. But cholestatic hepatitis with jaundice, then again we should change the drug class. And certain side effects are dose dependent, like bone marrow toxicity, thrombocytopenia, leukopenia, and anemia. If somebody gets thrombocytopenia less than 150,000, you reduce the dose. If it is falling less than 50,000, you stop the drug. If somebody getting leukopenia, again absolute neutrophil count of less than 1500, you reduce the dose. If it is less than 1000, you stop the drug. Anemia, somebody getting low hemoglobin with raised MCV, you correct associated deficiency like B12 and folate and correct the anemia as well. If somebody develops disproportionately low thrombocytopenia, you need to suspect portal hypertension and nodular regenerative hyperplasia. So coming back to our patient again, he had intermittent flares with arthralgia, received blood transfusion for anemia, and he was given methotrexate and for severe arthralgia. There he comes back with shortness of breath. So when these patients develop anemia, when do you give IV iron as a first-line therapy? And whenever active IBD or intolerance of oral iron or even less than hemoglobin less than 10, that's indication, strong indication to go for iron therapy in the form of intravenous infusions. And when you correct initial hemoglobin, and you can give iron again if the hemoglobin is falling less than 12. So the shortness of breath, we given methotrexate for him, he comes back with this X-ray. So what is happening with it? He's developed severe alveolitis with methotrexate induced lung injury. Methotrexate is not very much used for ulcerative colitis, but there is strong evidence to support use in Crohn's disease. We should be aware of hepatotoxicity for this patient, and contraception, as somebody discussed already in the earlier talks, one should be aware of contraceptive protocols for that. So he was tried on Remicade and initially had good partial response, then lost the response. And suddenly in 2011, it comes back with bilateral leg edema. Evaluation showed nephrotic range of proteinuria, and renal biopsy showed Congo red stain positive. He developed renal amyloidosis. So what are next options? The biologics, he had partial response with biologic, but his biologics were used for only few months or so. How do you screen before starting biologics? You can get a quantiferon gold done, chest X-ray or HRCT chest done. Infleximab, we all know that 5 milligram per kilo, 0 to 6, and then every 8 weeks. Adalimumab, 160 milligrams, followed by 80 milligrams every 2 weeks, and then 80 milligrams, and then every 40 milligrams every 2 weeks. You consider stopping biologics if somebody attained deep remission, but you need to explain the risks and benefits of relapse again. When we stop these patients' biologics, 1/3 of these patients relapse after 1 year of stopping. And so before stopping, you need to assess these patients clinically for complete remission, be it clinical, endoscopic, radiological, or ideally all together. If somebody is on combo regime, somebody is taking biologics with azathioprine or methotrexate, for example, once they achieve remission, which one will you stop? If cost is not a factor, you stop azathioprine or methotrexate and continue biologics. If the cost is a factor, then you need to stop biologics and continue other agents. So you stop the biologics, so patient comes back to clinic in 3 months' time. Are there any ways to predict this patient is going to relapse in the future? You can do that by serial fecal calprotectin. You don't need to do colonoscopy for these patients on a regular basis. Fecal calprotectin, once it starts to rise, then you subject them to colonoscopy. Don't start directly on biologics again. But if the fecal calprotectin is rising, you confirm that again with colonoscopy, then you restart it. So amyloidosis is a rare complication of any chronic inflammatory condition, especially in IBD patients. And this patient underwent, finally agreed, he has been counseled for colectomy multiple number of times, but he was never agreeing. So agreed for total colectomy and ileostomy. And he was doing reasonably well with occasional high output stoma. and he was taking etanercept. Right. So with that, we will come to end of this. So this journey of this patient tells you how difficult an IBD management can be. So this patient was initially poor compliance. Then he was having multiple flares. He was given steroids. He developed hip fractures or hip problems. He was given azathioprine, developed pancreatitis. He was given methotrexate, developed lung injury. And he had partial response with biologics, but for whatever reason he stopped it. Then he developed all these complications like renal amyloidosis and other things. So compliance is very crucial, and then appropriate use of agents, appropriate stages, very, very important. So with that, I'll stop, and I can take any questions if anybody has any burning issues. Yes. Okay. Yes. The question here for the people who are not able to hear. So the question is, what is the role of capsule endoscopy? So capsule endoscopy, 2-3 things, sir. Number one is the indication. The role of capsule endoscopy, the foremost indication is occult GI bleed or obscure GI bleed, to locate the site of the bleeding. And we know that it is only an imaginary tool. It doesn't give you tissue diagnosis. But even before we go for capsule endoscopy, we need to do a road mapping by doing a contrast study of the small bowel, because if these patients are suspected to have strictures, the capsule can get stuck. And then the patients end up with either surgery or again enteroscopy and other things. So the primary role of enteroscopy, capsule enteroscopy, is for diagnosing obscure GI bleed. And sometimes if you're confident there is no stricturing disease, for imaging purpose, we can go for capsule enteroscopy. But again, if it shows ulcers, the patient still needs histology. And then the patient goes for enteroscopy again. So there is very limited role for capsule in IBD. If no questions, sorry.
Though there is not much of literature on methotrexate in ulcerative colitis, we are used in few patients where azathioprine patients were intolerant to azathioprine, and it works well. Probably, surprisingly, there is not much of literature on this.
The comment Dr. G. Vishwas mentioned is not much role of methotrexate or ulcerative colitis in the literature, but sometimes it works well. Yes, sir. I do have couple of patients who responded only with methotrexate, ulcerative colitis patient. But you're right, there's not much of literature support for that. Yeah. Very good point you raised actually, because when you're thinking of combination therapy, there are two ways to go for it. You can either go for a small dose of azathioprine, for example, with biologic. The purpose of that is only to prevent immunogenicity. And so when you stop the biologic, you need to increase the dose to therapeutic levels. So that same dose, like 25 milligrams, sometimes we use, it's not good enough to maintain remission for these patients. And but if you're using as a kind of a supplementary to biologics, you need to use at least 50 to 75 milligrams, or at least 1 to 1.5 milligrams per kilo. That purpose is different. But when these patients are on dual immunotherapy full dose, the chance of them getting opportunistic infection is something like 6 times compared to somebody on monotherapy. So I do usually start them on only small dose, like a kind of a immunogenicity dose. And once a patient is in remission, we'll discuss with the patient, stop the biologics and continue with a higher dose of immunomodulator.
Even the risk of lymphoma is also quite high with the combination. Risk of lymphoma.
Lymphoma risk is also high, especially for the dual therapy and all. But again, somebody, again in the earlier talks, mentioned the lymphoma risk is something like 6 per 10,000 patients. So in the absolute terms, it's still very, very small compared to uncontrolled inflammation, which can lead to higher risk of colorectal cancer or even small bowel cancers. The number 6 for 10,000 is still a small number. Yes, sir. Yes, sir. The low dose is only to prevent immunogenicity, to prevent antibodies. Yeah, you can give high dose, sir, but we don't need to give higher dose. It is a general practice and a lot of guidelines also propose that, sir, but there is no evidence to support that. It is the immunogenicity purpose requires only small dose of immunomodulator. For that, we don't need to subject the patient to higher dose of two immunomodulators or immunotherapies, immunosuppressants.
Sir, when we stop to biologicals, start the azathioprine or something, what is the best dose, sir?
Sorry.
Initially, patient on biologicals with immunomodulators like azathioprine. Dose is 1 to 1.5 mg per kg, sir. Later, we stop to biologicals. After 2 years or 3 years, patient is remission is there. Then best dose for azathioprine.
The recommended dose for azathioprine is actually 2 to 2.5 milligram per kilo. But in Indian population, what my observation is, our population, I mean, Dr. Ajit sir and Dr. Divisha can contradict me. They don't tolerate higher dose of azathioprine. And like to, I mean, Chandrasekhar Akash sir, Dr. Sharda, everyone is here. So my experience is our patients will not tolerate higher dose, like 2 to 2.5 milligrams per kilo. And they tend to develop a lot of side effects and infections and also leukopenia and other things. But coming back to your question, once you stop the biologics, you can go as a standalone therapy, whatever you do for immunomodulator, you escalate into the optimum response and maintain that dose. Whether it's 1 to 1.5, 2 to 2.5. Ideally, if you have drug monitoring, that's even better.
Then you told, sir, after stopping of biologicals, patient will came with recurrency like symptoms, fecal calprotectin, you told, sir, in sequences phase. How much duration to we repeat that fecal calprotectin?
There is again no recommendations that I'm aware of. Once you stop the biologics, to follow them up, you can say once you 3 months or so, you can follow the fecal calprotectin, but there are no guidelines on that. You just need to kind of your own practice. I do the once in 3-4 months time. If it starts to raise, then you can go for colonoscopy to predict early relapse.
If the patient is de novo diagnosis of IBD, then we start initially to fecal calprotectin and intermittent based, we repeat that test or not, sir?
Yeah, that depends on the treat to target approach here. Whatever the question is, when the patient is diagnosed with IBD and how often you do fecal calprotectin and how often you follow it up. That depends on your target. There's this concept called treat to target. So whenever you diagnose patient with IBD, when you agree on the management, you agree in the targets. So say, I'm going to make sure his fecal calprotectin comes down to less than 100 in 1 year's time. Or you say, I don't worry about fecal calprotectin, the patient is affordable, you can go for MRI scan, for example. So it depends on the treat to target. If your target is fecal calprotectin, you can follow them once in 3 to 6 months. If your target is achieving mucosal healing, you go for either colonoscopy or MR or not ideally CT.
Thank you, sir.
Most of the times you assess the response by the clinical symptoms. Those true love criteria are all there. No? So fecal calprotectin is not done frequently because it is not a, it is a very costly investigation. It costs 3,000 to 4,000 per patient. So when the patient is not responding, then you go for fecal calprotectin. In clinical trials, they do it often to assess the response, but in a clinical scenario, you don't do it often.
Or patient counselor.
Sir, what is the success rate we can expect from the patient who stopped the biologics?
1/3 of the patients relapse within 1 year. So 75% or 70% of the patients would remain in remission even after 1 year of treatment. But these numbers are purely based on the data available. When it comes to individual patient, it is either 100% in 1 year's time or they may remain in remission for years together.
Sir, if he relapses again, it will be the biologics only the medicine for him again, or azithromycin can help?
Not necessarily. If you pick up the disease flare early, you can even be okay with immunomodulators, because the reason for starting biologics was for certain parameters, either aggressive disease or the patient failed on immunotherapy, but disease burden might be higher. But when you achieve remission, the disease burden would have been reduced. So you might be able to substantiate your use with only immunomodulators.
Thank you, sir.
You told about azathioprine toxicity, and the indication for stopping is for platelet count decrease of less than 50,000. Is there a cutoff for methotrexate induced toxicity?
Bone marrow suppression?
Yeah, for bone marrow suppression.
Again, these are the guidelines from ECHO. So whatever the numbers I told you, the guidelines from ECHO. There are no guidelines from ECHO on methotrexate toxicity, but more often the methotrexate toxicity we worry about liver fibrosis and all. So we monitor these patients with non-invasive monitoring, either by fibroscan or MRI elastography of the liver.
Because we had a patient on methotrexate with thrombocytopenia.
Yeah.
But there are no cutoffs, as you're saying.
Yeah, I mean, any significant trend, I mean, the trend is important. If it continues to drop, the patient will not for methotrexate always.
Thank you.
50,000 is a standard cutoff for anything.
Yeah.
For
any drug.
Yeah, for any drug, or for any parameter, cirrhotic patient, and we do biopsies or do any elective work. So that thing also with 50,000 is the standard. You can always say.
Yeah.
Above 50,000, you are safe.
No, sir, that is for intervention. Somebody who is on methotrexate, if his serial counts are dropping over a period of time, you don't continue, you discontinue.
How long you will wait?
So generally every 3 months you do monitor their CV. So if it is dropping means most likely drug induced only, you stop it.
Serial.
Don't wait for 50,000.
Alternate. We need to go for alternate. Now we have a lot of new smaller molecules and other agents.
You
So
have
we should go for
exhausted azathioprine. You have exhausted now methotrexate. What is next?
we even consider.
I'm not talking of new molecules.
Yeah. No, like tofacitinib is now available.
Now we have.
But whatever it is, sir, because the dose reduction cannot happen with methotrexate, and there is no option of dose reduction. We either have to stop it or continue it, not like azathioprine.
Sir, any exposure regarding NDT15 polymorphisms for azathioprine?
NDT polymorphism for?
NDT15, sir, polymorphisms. It's common in Asian settings.
How many?
Asians.
Yeah, I mean, in our population, NDT polymorph is more relevant compared to TPMT actually. But I think only AAG is doing NDT polymorphisms here, and it's not routinely available in outside laboratories. So I did send a few patients to AAG for doing NDT polymorphism, and then the patient is positive for that, we don't start azathioprine. But TPMT is widely available. But I agree, in our population, NDT is more relevant than TPMT. And also TPMT genetic is not that, I mean, what matters is the enzymatic activity of the TPMT, not the genetic
Genotypic and
genotypic
phenotype.
activity is not that relevant.
So 6 TG is better
That's a
than
drug
TG.
metabolites. Yeah. That will close today's session. Tomorrow we have an exciting day out, and request all of you to join us tomorrow at 9:30. We got a series of speakers, starting with Dr. Professor Vineet Ahuja, who is very well known in IBD circles. He's from All India Institute of Medical Sciences. Then we have Vishal Sharma from PGI. We have Saurabh Kedia from All India Institute. We have Professor Ian Lawrence from Western Australia, Perth. And we have Shaji Sebastian from UK. We have Gurusimran Kochar from USA talking on use of role of intervention endoscopy in IBD. We have Deepak Parakal talking on COVID in IBD, and lots of other exciting sessions. So look forward to see you tomorrow. And we have dinner served outside. Please join us. For those on Zoom, the same.